Good morning to respected faculty, colleagues, and delegates. Welcome to the 6th annual Lupus Meet of 2021, organized by the Lupus Initiative, Kolkata. Lupus Initiative, a voluntary health organization, was incepted 10 years ago in 2009 with the goal to empower the patients suffering from this multi-system and challenging disease. So every year in January, a scientific meet is conducted on lupus, which is organized by the LIK, which invites faculty from India and abroad to discuss the challenges and advances in this field. However, this year, due to the pandemic, this program was delayed. But as the old adage goes, better late than never, right? So although the pandemic has posed many hurdles, it has not been able to dampen our spirit because we have found yet another way to conduct this program in a whole new hybrid fashion, wherein the international faculty will be attending virtually and the national faculty in person. So this year's theme is to discuss the clinically relevant yet lesser discussed aspects of SLE. So we have a series of interesting topics lined up, waiting to be discussed over the next 1.5 days, which will end with a few challenging cases presented by the students. With this, I welcome you to the Lupus Meet of 2021 and hope you have an enriching experience. So our first talk is going to be by Dr. Syed Atiqul Haq, who is a professor of rheumatology in Dhaka, Bangladesh. He's one of the co-founders of the Bangladesh Rheumatology Society and the current president of APLAR. He will be talking about the lupus challenge, about the social challenges in the management of lupus, one of the very relevant but under-discussed topics, especially in the Indian scenario. So we are very grateful for you to being able to take out time for this. This session will be chaired by Professor Olokindu Ghosh, who is the president of IRA, and Dr. B.G. Dharmanan, consultant rheumatologist from Bangalore.
Thank you, Reshmi, for the introduction. We have this first program. You can tell or talk this one as President's program. President Appler is there, President IRA with President-elect of Indian Rheumatology Association is there. And the important social problem for which this Lupus Initiative Kolkata was initiated a couple of years back. So for the first time, we thought, let us start our proceedings with the social challenges in lupus. And fortunately, we got none other than Dr. Syed Atiqul Haq. He's a very close friend of us. He's the President Appler at this moment, as you have already heard. And he's a very big man by chair, very big in his heart, but very, very nice and gentleman out and out. So may I request Atiq to initiate his proceedings. Welcome, Atiq.
Should I share now? Is it my turn? I thank the organizers, particularly Professor Olokindu Ghosh, for inviting me to speak in this important session. Feeling particularly proud to find Professor Arup Kumar Kundu, one of my most favorite friends, with whom I had some happiest moments in the position of the chairperson of this session. My topic is social challenges in the management of SLE. Wherever the art of medicine is loved, there is also a love of humanity. I have divided my talk under 3 headings: introduction, challenges, and conclusions. First, introduction. The pathogenesis of human suffering is often biopsychosocial And the sociological factors include interpersonal relationships, social support dynamics, and socioeconomics. Society and SLE are very intricately interconnected, and the interweaving factors are that these are three major interweaving factors: cost, chronicity, disability, and employment. Cost of SLE. This is a systematic review that shows the mean annual cost of treatment of a control group was about 8,000 to 10,000 US dollars. That of patients with SLE without nephritis was 14,000 to 17,000 US dollars, and that with nephritis was 17,000 to $21,000. So we must conclude that SLE is an expensive disease. Now let's switch to disability and employment. This is a South African survey among lupus patients about their living experiences, perceptions, and unmet needs. And the authors observed that those who had resigned from their formal employment cited challenges like SLE-related role limitations together with employer dissatisfaction for multiple hospital visits or admissions or being more at home rather than at work. All the 6 formally employed participants had completed tertiary education. Those without higher qualifications struggled to find or continue work. More than half of the participants had either left school before completing secondary education or had obtained inadequate grades and had abandoned tertiary education. For most, further education was impossible without financial means. Now let's move on to challenges. The challenges may be classified under broad headings of economical, cultural, and planning, though these are somewhat overlapping, and that's why in the next part of my discussion, I shall not discuss them under 3 discrete subheadings. First, poverty. You can see that there are countries in the world like Bhutan, India, Pakistan, Bangladesh, with per capita GDP 1/15 to 1/20th of some other countries. In these communities, households often sell their possessions to cover the healthcare cost, particularly when chronic diseases require long-term costly treatment. Lumina cohort is a US cohort. Lumina derives from lupus in minorities, nature versus nurture. This multi-ethnic longitudinal cohort was established in 1994 in the USA. And the authors of this article studied the associations between selected independent variables with self-reporting working disability, and they found that poverty was a strong predictor of disability. And this is the Hopkins lupus cohort, and they have reported on the effect of economic status, socioeconomic status on the survival. And they found that lupus families which had annual income less than 25,000 US dollars had 1.7 times higher mortality than those who belong to families with more than 25,000 US dollar income. Now let's move to education and literacy. This is another study by Ward, and these dark bars represent lupus and the white bars represent all-cause mortality. This study demonstrates that the mortality decreased progressively with the increasing years of education. Gladel cohort is a Latin American cohort. And here also we can see that along with other factors, this mean years of education was lower in the patients who died earlier. Health-seeking behavior is another social factor, and the health-seeking behavior seeking resort to means other than our scientific medicine is quite common all over the world. One is complementary and alternative medicine use, and in Britain, Canada, in USA, in a 2000-year report, 50% of the lupus patients reported seeking help to CAM or complementary alternative medicine. The percentage was 65.5% in China and 53.6% in Mexico. And this is a study which shows the consequences of the use of complementary and alternative medicine. And we can see, apart from some other factors, the users of complementary and alternative medicine had higher damage index, significantly higher damage index by SLEC 1.6 and 1.2, and also poorer general health. And treatment adherence is another social factor. And the prevalence of adherence was 45.9% in Brazil and 48.7% in Shanghai, less than 50% in both of these studies. And this is a prospective study in which 19 countries were, 19 centers of 10 countries from different continents of the globe were incorporated. And the authors observed that half of the patients were non-adherent and 20% were objectively severely non-adherent, often without the knowledge of their physicians. Steroid dose had to be escalated in 68.9% of those flaring patients. And so they concluded unmasking of non-adherence was very much important for avoiding unnecessary treatment escalations. And as per a WHO study, the determinants of non-adherence belong to healthcare system, to provider relationship, disease, treatment, patient characteristics, and socioeconomic characteristics that included literacy, resources, and cost of medicines. And that is another study on intentional medication non-adherence. And the surveyed patients suggested that poor communication with the rheumatologist along with the lack of validation of their symptoms contributed to not valuing the recommendations of the physicians. And that also contributed to a development of a cynical outlook and little belief that medicines would improve their condition. Now, disparity and access to care. What is access to care? The access to care is a realized ability to receive appropriate medical care in a timely manner, free from geographic or financial barriers. Care for patients with lupus, like that of many chronic conditions, necessitates advanced training, experience, a strong physician-patient communication skills, and access to other subspecialists and medical technology. And here we can say the US status, the SLE patients who were only on Medicaid had to travel much longer distance. This is 42 miles compared to others 20, 23, and 24 miles for accessing the lupus care. What are the determinants of access to care and disparity? These are urban versus rural divide and ethnicity and minority issues. These are actually the major determinants. And this is again another study, and it shows that rural residency was characterized by 1.55 odds of having higher activity score of SLE. And similarly, the rural lupus patients had much significantly higher incidence of renal disease or lupus nephritis. Ethnicity and minority issues. This is again from the US Lumina study. Here we can see that Hispanic and African American patients had higher lupus activity measured by SLAM-R. They have higher. That was an independent predictor of high disease activity in lupus patients. And even this same ethnicities, Hispanic and African American, they had also higher mortality. We can see here 15% and 12.2% compared to 7% in the Caucasians. This is from Gladial, Latin American cohort. Even, Latin American, these are, I would say, somewhat colored like us. And here also you can see that disease activity and damage indices were higher in African, Latin American, and mestizos compared to the whites. So we can sadly include that, there is disparity in the accessibility of care that we provide. Community hygiene and infections. This is another review done by Indian public health expert, Professor Diodhar, and he has compared, different types of environmental factors with different types of infections, and he found that respiratory infections correlated strongly with polluted air, and excreta and sanitation. Disposal of excreta was, closely related with diarrhea and vector-borne infection. Water mismanagement and global environmental challenges were correlated strongly with diarrhea, vector-borne, and other types of infections also. And if we look at the percentage of population using basic sanitation service, we can see in our part, that is in Bhutan, Nepal, India, and Bangladesh, this percentage of population using the basic sanitation services is much lower than those in Uzbekistan, Malaysia, Sri Lanka, and Vietnam. As a result, we can see this is the South Asian share of world daily due to infections. South Asia is contributing to the major part of daily due to Japanese bee encephalitis, leprosy, dengue, tuberculosis, hepatitis B, all these things. And we can again see Nepal, India, and Pakistan, these countries top the list of incidence of tuberculosis per 1,000 population. This is another Hungarian study. Here the researchers have compared death in the lupus patients with death in general population due to various causes, and these gray bars represent lupus patients and black bars the general population. Here also we can see the death due to infection was much higher in the lupus patient compared to the general population, and death due to sepsis was also significantly higher. So we can say that infection that is more common in areas with poor environmental hygiene is a major cause of death in lupus patients. Governmental priority and planning. These are the three important aspects that government has to do for saving the patients, that is budget, manpower planning, and model of care. Here we can see what is the percentage of GDP that is spent on healthcare in different countries. You can see this percentage is 17.6 in USA, 11.7 in Germany, and 9.5 in Japan, whether it is only 4.2 in India, 2.5 in Indonesia, and 3.4 in Bangladesh. So our governments are also spending much less compared to their abilities. And as a result, you can say the out-of-pocket expenditure of percentage of private expenditure in health. This out-of-pocket expenditure is highest in Bangladesh, Vietnam, and India. It means, it reflects the, poverty of government participation and also non-availability of other resources for cost reimbursement. Now, if we switch to manpower planning, again, we can see the number of physicians per 1,000 population is again lowest in Thailand, Bangladesh, and India. Model of care. This is another work by Keith Lim, and he found that in our countries, the healthcare is divided into two sectors, public sector and private sector, and the public sector has three tiers, primary, secondary, and tertiary. But this public sector is characterized by weak referral linkages, poor information management, low investment, low quality of care, based largely on crisis care approach not suitable for longitudinal care of chronic conditions. And on the other hand, the private sector is a free market sector without any referral system. The specialist care is overburdened with primary care problems, reducing the efficiency of the specialist care. So in conclusion, I can say social factors may influence quality of life, disease activity, damage, and survival of the SNE patients. Multiple factors, social variables are interact, and the solution has to be multi-pronged. In fact, there are many factors, but I have addressed these factors: poverty, education and illiteracy, health-seeking behavior, adherence, disparity and access to care, community hygiene and infections, government priority and planning. And we can see all these variables are such that they are intricately interwoven each influencing all others. And as doctors, what can I do? Our medical expertise is our core competency, but as per CanMed's framework, these are 6 additional competencies that we have, and the most important one of the important of this is health advocate, and we have to carry on advocacy for increasing health manpower, increasing national health budget, improving environmental hygiene and infection prevention and control, reforms in the model of care, parity in healthcare, increasing faculty and training positions for rheumatology and related specialties. And also at the individual levels, we must acquire the ability to establish appropriate doctor-patient relationship, and we should be able to communicate and converse with the patients and convert them into knowledgeable partners of decision making. It means we doctors will have to become teachers. We know that, and in the Latin language, doctor means teacher. A good doctor teaches you how to take care of yourself. And I would, end my talk thanking you all with this sentence: a good teacher is a doctor who heals ignorance, and an artist who inspires creativity. Thank you all.
Thank you very much, Professor Atikul Haq, for a wonderfully conceptualized and executed talk. And is there any questions from the audience? When you are thinking about your questions, I take the privilege of asking a question. And SLE being a disease of young women, there are generic problems which are faced by young women all over the world, like body image issues, being rebellious by nature, poor adherence. You have discussed it very well. But one problem we faced as a unique problem in our country is issue of marriage, because marriages are still determined by parents and arranged in our country. What is your opinion about this issue in Bangladesh?
Actually, Dharmanand, the words are very indistinct. I couldn't hear everything, but just I have said, in Bangladesh, actually, we are suffering from all these social factors. The factors that I have highlighted, they are commonly shared among all the South Asian countries and also other, I would say, low and middle income countries. And these things are affecting Bangladesh equally. And we have our lupus patients have difficulty in accessing our care. They have poverty. They cannot afford to purchase the medicines. And also most of them cannot afford the hospital costs. So whenever we treat SLE patients, we have to look from the social perspective to organize lupus care, to support their expenses. We have to do all these things in Bangladesh also.
Yeah, thank you. But my question was, if you can hear me, my question was the issue of marriage being a disease of young women, and marriages are still in India and Bangladesh. I think most of the marriages are still arranged marriages. Do you feel this as an important issue when you are counseling your patients regarding issue of marriage? I think Professor Atikul is not able to hear us clearly.
Yeah. Actually, words are very indistinct. I don't know why. Whether my lecture was distinct to the audience, I'm not very much sure.
Your lecture was loud and clear, sir. It was fantastic. Anyway, with there is no comments, I think I thank Professor Atikul Haq for being a wonderful opening batsman for this nice meet. Thank you very much for joining us.
Thank you very much.
Thank you, Dr. Atikul, for that insightful talk on the social challenges in lupus management. Next up, we have a talk on eye in lupus and the urgencies and emergencies related to the eye in lupus. Although a seemingly small organ, the importance of vision cannot be overemphasized. So the talk will be given by Dr. Aman Sharma, who needs no introduction. He's a professor at the Rheumatology Division at the Department of Medicine of PGI Chandigarh and the founder of Indian Vasculitis Registry. Sir, we thank you for your time and would like to invite you to start your presentation.
Thank you very much. At the outset, I would like to thank Professor Lakendu Ghosh sir for this very kind invitation and for this talk in an area which I love, the interface on rheumatology and eye specialty, uveitis and all that, which I've been associated with since almost 14 years now, ever since Dr. Bambri left for Australia. Am I audible? I hope I'm audible. I was very much looking forward to my visit to Kolkata because it's always such a enriching experience as far as academics is concerned, socially, culturally. You know, I always I'm eager and looking forward, but due to some reasons, personal reasons, I had to cancel up the last hour. Anyhow, I'll start off on the job that has been assigned to me by sir.
Sir, I'm sorry to interrupt.
Can you hear me?
Sir, I'm sorry to interrupt. We would like to call the chairpersons of this talk. It will be chaired by Dr. Rudas Ghosh and Dr. P. Damodaram. Could you please come on stage, sir?
Sure.
That has been changed, sir.
I think it's such a wonderful experience all the time when we come to Kolkata. Very gracious, generous hosts, excellent academics, and wonderful hospitality, social gatherings and all. I think the chair can...
So eye in lupus, eye is one of the important organ involved in lupus. Even though it is not included in the new classification criteria, eye is involved in significant number of patients affected with lupus. And this topic will be delivered by Professor Aman Sharma. And you all know very well Aman Sharma. He is a senior member of Indian Rheumatology Association, professor, and he has got a lot of publications, and he has published a lot of books, especially in the vasculitis. And with this brief introduction, I would like to invite Aman Sharma to continue his this topic.
Thank you, Damodaram, for that generous introduction. I think how I have planned my talk is that I'm going to intersperse the topic with a lot of cases that we have seen, and I think that is what would probably be exciting. I hope that is exciting to the audience. Without much ado, the first case was a young lady who had 18 years old, who had fever and had diminution of vision. She was seen in the uveitis clinic, and she was being worked up for uveitis, for the vision loss that she's had. And when she was seen in the uveitis clinic, as you can see, that the disc was pale on both the sides, and there were some areas which were there were some infarcts which were spread out in one of those eyes, and the vision loss was very profound. And besides that, over a period of time, she was noticed to have anemia, and she subsequently a mantle was put in, and then she started to have some rash over the malar area, which initially the ophthalmologists feel that, I vividly remember that they thought whether this is some reaction kind of a thing to mantle. But when we saw that, we thought that this is probably evolving into a malar rash, which is more like lupus. This was around 2 to 3 weeks after the eye illness had started. And then once we investigated, she was having ENA 3+. And over a period of time, there was a progressive decline in the sensorium to the extent that she became comatose, and she developed a lupus organic brain syndrome kind of a presentation. And CSF was normal and MR brain was normal. APNA workup was done, which was negative. This is the rash. These pictures have been taken with permission. You can see that this was a classical butterfly rash, and there were cutaneous vasculitis lesions over the fingers. With this, I think the diagnosis was pretty clear. She was treated with methylprednisolone cyclophosphamide. The sensorium improved gradually. Vision in the right eye did improve to almost near normal, but there was no improvement of vision in the left eye, and she eventually developed optic atrophy of the left eye. So, and the sensorium also, when I say gradual, one has to remember when there is a severe, profound organic brain syndrome kind of presentation, Even if you treat with steroids and cyclophosphamide, generally it takes 4 to 6 weeks before the present. So you have to be patient along with the family to really see when the response kicks in. Another case, young lady again, presented with inflammatory arthritis for 2 months, along with altered behavior in the form of decreased oral intake, decreased interactions, repeated crying episodes. She was howling in the ward. I remember we were having an MD exam there, and she was howling with pain. She was not recognizing the family members. And also there was recent onset vision loss for only 3 days. And on top of that, when we saw, there was visual acuity, as you can see, was only counting fingers, and the lid was swollen, and there was conjunctival chemosis. On the front desk examination, there were bilateral flame-shaped hemorrhages in all 4 quadrants. There was disc edema, and as you can see here, there was some perivascular cuffing, which was also seen in this. I hope the pictures are being projected clearly. The MR brain which was done, which showed bilateral heterogeneous extraocular muscles with proptosis, normal cavernous sinuses, optic nerve, and there was no cellulitis, and there was no evidence of any infection anywhere. We suspected lupus. Workup was done over a period of time, which showed the ANA3+ homogeneous, dsDNA positive, complements were low, APLA workup was negative. She did have proteinuria, and there were some active segments of the urine, and it was not difficult to make a diagnosis of lupus, and she was started on methylprednisolone and cyclophosphamide ulcers. So the total diagnosis was lupus nephritis, no neuropsychiatric SLE, bilateral inflammatory central lateral vein exclusion with frosted branch angiitis, and also lupus orbitopathy. The key is one has to act fast and treat fast. You shouldn't really wait for all the evidences and start treating these patients quickly. And in this patient, after 3 days of pulse, the edema and congestion settled. Vision at that time didn't improve, but psychosis improved gradually over next 3 weeks. So this is what one has to remember. Many times some of the manifestations might improve, the other manifestations may not, and I'll dwell a little bit deeper into this during my presentation. Another case, young female, decreased vision in the right eye for a month, which was insidious onset, painless, progressive. She also already had vision loss in the other eye for 4 years, which was initially transient vision loss followed by intermittent headaches, and had lost complete vision in 2017. This patient was seen in 2019, was also having hypertension and headache for the last 3 years. And you can see the visual acuity in one eye was counting figures, and in the other eye, she was denying perception of light. The rest of all investigation, all extraocular movements and other things were okay. So if you see, these are the dilated pupils, and you can see the media and everything, they were abnormal. And you see there were some, you can see these branches, I hope you can see these branches of the vessels which are occluded. And if you can see these late branches also, which are occluded here, I hope these are clear if you trace these vessels here. And these are late phase, and there was hypoperfusion. And if you can see here also, you can see the vessels, and there is relative hypoperfusion. And this is fundus fluorescent angiography, which showed that the vessels are occluded here, as you can see, and in some vessel they were showing some leakage, so which was showing some evidence of activity. When we reviewed the history, there was petechial rash, photosensitivity, arthritis. There was some claudication in the upper limb. There was history of 2 spontaneous abortions. There was renal dysfunction. ANA was 2 plus speckled. Lupus anticoagulant was positive, and so were the anticardio-dependent beta-glucoprotein antibodies were positive. MR brain showed multiple lacunar infarct. So this was lupus with secondary antiphospholipid syndrome, with CNS involvement, with renal involvement, and also with the eye involvement of the kind that I've talked to you. It was treated with steroid and cyclophosphamide, hydroxychloroquine, aspirin, warfarin, and telmisartan. I required a scattered laser for those, new vessels and for wherever the leak was. So to the topic, if you look at the eye involvement in SLE, it can be because of the disease per se, it can be because of the infections, and it can also be because of the drugs, and top of the line is hydroxychloroquine. So what can be the disease-related issues? The disease-related in the anterior, from the outside, we can have paniculitis, we can have orbitopathy, I've shown you, we can have focal myositis also, we can have discoid lesions over around the eye area. epitheliopathy, scarring and ulcerations, and peripheral ulcerative keratitis can occur. We can have sicca, episcleritis, and scleritis. These can all be seen. Basically, these can all be related to the disease. In the posterior segment, we can have lupus choroidopathy. We can have lupus retinopathy. We can have retinal vasculitis. We can have maculopathy. And in the disc area, we can have optic neuritis. We can have ischemic optic neuropathy. And NMO spectrum disorders, some of the patients we've seen, and I think Orgo will recollect during his stay what he had seen here, that we have seen these presenting because of the NMO spectrum disorders in their proven lupus patients. The pathogenesis is, it could be immune complex mediated, direct antibody mediated damage. It could be vasculitis. It could be thrombosis. Some of the examples I've already shown you. The causes of vision loss in SLE can, it basically depends upon what is involved. Anterior segment, you can have a severe keratoconjunctivitis and sicca. Lens, we can have cataract secondary to inflammation, or due to corticosteroids, we can have vitreous hemorrhage, which can be because of proliferative retinopathy. In retina, we've shown some examples: severe vaso-occlusive retinopathy, CRVO, branch retinal vein occlusion, central retinal artery occlusion, branch retinal arteriole occlusion, exudative retinal detachment, toxic maculopathy because of the drugs, which we'll see. Choroid, we can have lupus choroidopathy. Again, some of the examples have shown. Choroidal effusion, choroidal infarctions can occur. Choroidal neovascularization. It is not easy to image the choroid. You have to do a special staining like ICG to look for isolated choroidal lesions. Many times in neuroophthalmology, these are the all that we've talked about. And plus, we can have optic chiasma and cortical infarcts. So peripheral ulcerative keratitis, it is rare. It is more common in rheumatoid arthritis. It can also occur in membranous granulomatosis, but it can rarely occur in lupus also. This is due to the vasculitis of the surrounding limbal vessels. There may be markers of systemic inflammation. There can be interstitial keratitis and keratoadenitis also in these patients. So in these patients, we have to treat aggressively with steroids and cyclophosphamide as an aggressive immunosuppressive therapy. The other thing is scleritis. This can cause visual impairment. There can even be scleromalacia. This is rare, but can happen even with lupus. That's what one has. There can be prolapse of the intraocular structures. It can both be anterior, wherein there is severe periocular pain, deep ocular injection, or it could be posterior, where the anterior the eye may not be red, but there may still be severe pain and blurred vision. And at times you might need to do the ultrasound examination of the eye to see whether the posterior part of the sclera is involved. It generally parallels the disease activity elsewhere. So in these also one has to treat aggressively. The other feature, other manifestation can be SLE retinopathy. The prevalence varies in different series from 3% to 29%. The active inflammation is there in the retina and choroid, which echoes the active vasculitis is the other organs, especially CNS vasculitis. So I showed you, one of the patients who had primary CNS kind of manifestation, primary CNS involvement along with this. The features can be cotton wool spots, which are nerve fiber infarcts. There can be hemorrhages. I've shown some of those. And I'll show you the branch retinal vein artery occlusion and the central retinal artery occlusion subsequently. There can be widespread capillary non-perfusion. There can be ocular neovascularization. There can be vitreal hemorrhages and traction retinal detachment. We have to have a very good ophthalmologist with special interest in retina and uvea. They can really be a great help. And sometimes the patients can either go from us to them or from them to us. And it's important to work as a team. Sometimes you would have to discuss the treatment strategies in close consultation with the ophthalmologists. This is the paper that we published. This is the image that we published recently in Rheumatology Oxford January issue. This was a patient who first presented to the ophthalmologist. You can see there was a total involvement on the right side, and then the partial involvement on the left side, whereas there is perivascular cuffing, as you can see here, but rest all showing hemorrhages, and then there was some features of cherry red spot kind of presentation. So these all can occur in patients with lupus. Subsequently, she had some arthralgias and some subtle facial rash. Skin biopsy also did show lupus band. ANA was positive, dsDNA and complements were normal, and MR brain was also normal. One has to remember, as I've already told you, that this can be associated with CNS lupus, even vaso-occlusive retinopathy, and also retinal microangiopathy can have almost more than two-thirds of the patients having CNS lupus. Some of the work has been done by Doug Jabs, who we had here in one of our uveitis meetings in Chandigarh, and you can look up his publications over the last 3 decades on CNS involvement in SLE. The other thing is lupus choroidopathy. It's extremely rare. It again is associated with disease activity, just like other manifestations. ICG, as I've told you, you need to ask your colleagues to do, if you are suspecting, to do a special investigation. Pathogenesis is multifocal, uncontrolled hypertension, immune deposits in the choriocapillaries, and anti-retinal pigment epithelium antibodies. These also require long-term immunosuppression with steroids and other agents like cyclophosphamide. So again, also treatment can be rewarding if you intervene early. Towards the end, optic neuritis and ischemic optic neuropathy again is rare. The visual acuity is poor, most worse than 20 on 200. Recovery again is variable, as I showed in from some of the cases. And it can be full if you intervene early. 2-finger counting. It correlates again with disease activity. There can be ischemic demyelination, then inflammatory demyelination. And degree of axonal loss is equivalent to the visual outcomes. Ischemia due to the involvement of vessels supplying optic nerve head and retrobulbar nerve. Again, treatment has to be steroids with cyclophosphamide or cyclosporine. Switching gears, I've talked about the disease, but I told you about infections and also drugs. So, young lady who presented for the first time with vision loss has had arthritis for a few years, 1.5 years. There was some fever, there was some dyspnea for 2 years, had hemolytic anemia on evaluation, serositis, proteinuria, antibodies. But remember, she presented for the first time to the ophthalmologist. ANA, DSD, and Smith positivity. There was LV systolic dysfunction. Lupus with SLEDAI of 24, steroid, cyclophosphamide discharge, comes back with painful vision loss for 3 days. Retina suffice, no diplopia, no ptosis, no trauma or any impression recently, no evidence of lupus disease activity when she came. In conjunctiva, there was mild redness. As you can see, pupils were dilated. You can see here, left eye seemed to be normal. Right eye, hand movement at 10 centimeters, 6/12 in the left eye. Fibrin was seen in the anterior chamber inferiorly, suggestive of an hypopyon, and yellow glow in retroillumination, suggestive of exudates in vitreous, which cleared with topical betamethasone within 48 hours. Wide field posterior segment photograph did show there was a yellowish exudate in the posterior pole extending to the mid periphery, and the vitrectomy and pars plana vitrectomy was done, and sample was taken. As this is a QH, infection was high on the cards. All infections, cultures, including the fungus, was looked for. And QH, you can see these, septate, hyphae, and you can see the calcofluor white mount. On Sabrod's dextrose agar, Aspergillus fumigatus. This is pretty clear. So Aspergillus causing a vision loss in somebody who was treated with immunosuppression. This is what this patient was there when Orgo was here with us. So one has to remember that infections can be a devils in patients with SLE and can also cause vision loss. This patient was treated with voriconazole. Unfortunately, the spread to disseminated infection could be averted, but vision did not really improve. The other side of the story, occasionally the cotton wool spots may be associated with retinal hemorrhages and may result in the Roth spots, which are seen in patients. You can see all these Roth spots are seen in patients with lupus. We can have CMV retinitis. Those of you who remember from Love and Bailey's description of tomato ketchup and salad retinopathy. This is CMV retinitis for all of you. And I think this again, one message that I wish to tell, that CMV can mimic SLE, can cause flare of SLE, can cause first presentation of SLE. And if there are decreasing counts and with immunosuppression, especially patients are not improving, I always tell all my residents that look at the fundus more carefully. Sometimes fundus might give you the clue as to what's going on in the patient, besides all other investigation. This is very, very important key. There can be bullseye maculopathy. We are all aware about it. And these are the 2016 American Academy of Ophthalmology recommendations. The major risk factors are hydroxychloroquine and a chloroquine dose. Why chloroquine is up there? For those of you who are active on Twitter, you would have seen that there was a Twitter poll going on recently. And I was surprised to say that even in some countries across the globe, chloroquine is still being used instead of hydroxychloroquine in treatment of SLE. And it's been presumed that probably chloroquine risk is higher as compared to hydroxychloroquine. And the other important thing is duration of use. More than 5 years, assuming there was no other risk factors in the beginning. And the patients who have renal disease, they are more likely to have hydroxychloroquine retinopathy. So one has to be careful there. The other use of concomitant tamoxifen and also macular disease, if it is there in the beginning, it may hamper the way you screen for susceptibility to chloroquine or hydroxychloroquine. So screening frequency, baseline is fundus examination within first 1 year. So not that you make the patient wait, you can start and get the fundus examination done within a year, add visual fields and OCT if maculopathy is present. And once the first baseline is normal, one does not need to do the screening up to 5 years. And if they are present of other risk factors that I've already alluded to, as the spectral domain, optical coherence tomography, which all our ophthalmologists are having these days. What are the recommended and non-recommended tests? The main recommended tests are ideal to do are automated fields, OCT. Others are, fundus autofluorescence and multifocal ERG. These are there in the specialized centers. And I can tell you, fundus autofluorescence can show you changes of hydroxychloroquine or toxicity, even when the visual fundus examination is absolutely normal. This depends upon the fluorescence of rods and cones, and this is a fantastic investigation, and it is more sensitive than doing the other fundus examination as such. There are newer tests which may or may not be available: microperimetry and adaptive optics retinal imaging. The time domain OCT, fluorescent angiography, full field ERG, Amsler blade color testing, and EOG. These are not really recommended for screening as such. So with this, I wish to conclude that eye involvement in SLE may be due to disease, infections, or drugs. Any part of the eye or extraocular structures can be involved. The key to good outcomes is early diagnosis and appropriate management. With this, I think I would wish to thank Alakendu sir again, and I will be very happy if there are any questions. Thank you very much for your patient hearing.
Thank you, Aman, for your case-based discussion on the eye involvement in lupus. I think there will be some question. May I ask postgraduates and other to ask few questions to Dr. Aman. Dr. Arup Kundu.
Thank you, Aman, for your lecture, nice lecture and fluency, just like before. I want to know just only what is the commonest ophthalmic urgency encountered by lupus, the disease lupus, commonest among all this plethora of description.
Commonest urgency and emergency would be CRAO and CRVO, which can be because of the lupus, which would make you treat immediately, because there would be sudden but profound vision loss. We've seen these do occur, especially if you're in the tertiary care center. We see not so infrequently patient coming with sudden loss, and then where you have to act fast and investigate also fast for all the other involvements.
And according to your experience, what is the commonest emergency you have encountered in your PGH and DR?
I said, when I said urgency and emergency, I said this sudden profound vision loss because of CRAO, CRVO. So that is one. You can club it as urgency or emergency. The other ones are obviously hydroxychloroquine associated things are milder, but they are irreversible. Whereas all these things, infection can be an emergency. I said this aspergillus thing. There can be other infections also. Because of paucity of time, I have not been able to show those. So whenever the patient comes with sudden severe vision loss, it could be optic neuritis. We've seen, NMO spectrum disorders coming with vision loss. If you don't pick up early and treat aggressively, there is an element of reversibility in the beginning, which might become irreversible if you don't treat early and aggressively.
Have you seen any case of hydroxychloroquine-induced toxicity
Yes, we
seen
have.
pro patients of lupus? How much?
Yes, we have.
How many
Yes, we
patients?
have, but very rare. We have seen, but it is rare. I remember seeing 4 or 5 patients in the last 20 years.
Okay. It's totally irreversible.
Yes, once it occurs, it is a maculopathy, it is irreversible. That is why I said, if you do the fundus autofluorescence, you might pick up the changes in the periphery much earlier than doing the other fundus examination, and maybe, you can do those and revert the progression. It starts from the periphery and goes towards the center. That is why once you suspect, it is probably good to screen them at regular intervals.
Thank you. Thank you, Aman.
Dr. Somaranjan Pal.
Thank you, Professor Aman, for your brilliant presentation, as always. I have a question to ask you the other way around.
Yes, sir.
We get patients with history simulating acute optic neuritis,
Sir,
who are ANA positive, but even followed up several years down the line, they do not develop lupus.
Sir.
So it is very difficult to label them and treat them. What is your message, carry home message regarding these patients? I personally have few patients who are presenting in this manner, developing repeating episodes, improving with steroids, and then recurring at periodic intervals. They never develop lupus. What is your message for them?
Thank you very much, sir. I think, first of all, I'm so happy to hear from you and to see you in good health. And I would wishing to meet you in person also, because we shared a bond with you and as with all other senior people from Kolkata, other also. So the question is very valid. The thing is that I would look at it from a different perspective, that to label somebody as having lupus based only on ANA and steroid responsive, posterior segment involvement, presuming that MS and other things have been excluded, that I would rather say that I won't really be labeling them as SLE unless I have any other clincher for diagnosis of SLE, and we've done the MRs also. And if you're suspecting some kind of a subtle behavior change and you see it could be organic bend syndrome, you can do the SPECT examination to look for any hypoperfusion. You can even do a PET to see that whether there is hypometabolism in any areas of the brain. If all those are normal and you believe that there is nothing to suggest lupus elsewhere, I may not really treat it as SLE. I'll just, ANA positivity can be there without being a causative agent. But if it is posterior segment involvement, which I'm sure you and our eye colleagues are going to treat with immunosuppression, then we will look at the behavior of the disease as far as eye is concerned. And we are very within our right to give immunosuppression the way we would give for lupus-associated eye involvement. And probably time the duration and extent that the way we would do it. If you look at the severe uveitis with posterior segment involvement, half of the patients, 50 to 60% of the patient, even with diligent, investigations, we can pinpoint the cause. In nearly 40 to 50%, we may never be able to pinpoint what's the cause of posterior segment involvement in the eye. But we treat it almost the same way. There are recommendations from Focus Initiative. I would urge our colleagues to have a look at 2 articles which are a must read for all rheumatologists. One is a Focus Initiative document in the American Academy of Ophthalmology journal, Ophthalmology. I think it was in 2017 or 18. The other is the Jim Rosenbaum's write-up on the eyes have it as a review article in arthritis and rheumatology. It beautifully, touches this area from our perspective and how we should treat. I hope I have answered this question to some of your satisfaction, sir. And I'm again personally very happy to see you.
Thank you, sir. Thank you.
So, few minutes left. I will ask a last question to Aman,
Yes.
sir. Sir, among anti-malarial drugs, quinacrine has got low ocular toxicity. So,
Yes.
why we are not using the drug? Why it is not available in the Indian market? Any specific reason?
I think the leaders are there. We probably have to make a case. The advocacy cell which Danda sir has been proposing and all Kendu sir has been supporting. And I think the Dharmanand sub can take up with all of us, you, me, and all of us together. Probably all advocacy issues according this can be taken up by the advocacy group of IRA.
There are no questions. We conclude this session here and we'll
Thank you very much. Thank you. I really enjoyed, and I'm missing it. But I wish everybody has a good meeting. Thank you. And thank you, sir, for asking me to speak.
Thank you, sir, for that very informative talk on eye and lupus. Next up, we have a topic which never seems to be discussed enough amongst us rheumatologists, autoantibodies and SLE. So this will be divided into 3 sessions. The first will be autoantibodies at the bench side by Dr. Sapan Pandya, the Secretary of IRA. The second will be autoantibodies at bedside by Dr. Chandrasekhar from Bangalore. And the third will be autoantibodies in cloud by Dr. Shumantu Mondal from Kolkata. The session will be chaired by Professor Sukumar Mukherjee from Kolkata and Dr. Abel Lawrence from SGPGI, Lucknow. Thank you.
Good afternoon, friends and colleagues. On this special lupus physical meet after the COVID pandemic we had experienced. I hope all of you are well. Today, one of the interesting sessions is autoantibodies. As you know, the systemic lupus is a polygenic, heterogeneous, systemic autoinflammatory disease with variable phenotypes and many organ dysfunction. All of us are practicing patients of lupus, and we often ask for the autoantibodies. There are almost 100 autoantibodies in systemic lupus, including autoantibodies against the nuclear, cytoplasmic, extracellular antigen, surface membrane, and all these autoantibodies are released because of loss of tolerance. Loss of tolerance, and that leads to polyclonal B activations and T cell antigen. And we are, most of the time, not possible to ask for all autoantibodies because it is too expensive, not always available. So you have to choose, and that's why the title of this presentation is one for the bedside, for good clinical practice, one for the bench, for the research worker, and one in the cloud, that is our ignorance. So obviously, we have to go through this in 1 hour time, most of the antibodies, and I'm sure all of us will be waiting for the different discussions and how autoantibodies play as a biomarker or a marker for immunopathogenesis and organ dysfunction. To start with, we have got autoantibodies at the bench side, and Dr. Sapan Pandya is here. Welcome, Sapan. Welcome. And I pass it on to Dr. Lawrence for the continuation now.
Can I have the previous slide, I think? Okay, this is not the first slide. Okay. Thank you, everyone. Good morning. Good afternoon, rather. So nice to see all of you. As Aman said, as soon as Alakindu sir said, I'm planning a lupus meet, I said, I'll come on my own money, but I'll come. I've been fed up of not meeting people. It is phenomenal to see Professor Sukumar Mukherjee still on the first bench, still coming on the stage. He's an example to so many of us. Enthusiasm, zeal, especially for the postgraduate students who are confused whether we should listen to stuff. This is what zeal is all about, I think. What has COVID taught us? I have shared with you some of my creativity in the IRA chat group, which is mostly humor. This was one of the best creativities that I saw about COVID, the era. Zahar is qadar ghul gaya hai hawa mein, koi asar nahi raha hakim ki dawa mein. कहाँ गले लगाकर मुकम्मल होती थी मोहब्बत, हाथ मिलाने से भी महरूम हो गए हैं आज इस जहां में। ये कैसा गुनाह है, ये कैसी सजा है, कैद भी हुए तो अपने ही मकाम में। मसाफत दूर तलक ले आई थी आदम को, लाजमी हो ना पाया रुकना इतनी रफ्तार में। फैसला यूं सुनाया आईने कुदरत ने, सुना है फासलों की सजा हुई है कुर्बतों में. This is one, it beautifully describes every aspect of COVID-19, lockdown and all of it, I thought. So I just thought I'd share with this. Alkindu sir, I think जानबूझ के मुझे टॉपिक दिया, वो दीदी और मोदी का गड़बड़ चल रहा है ना, so that's why I think gave me this topic. I am a clinician. I was trained in SDPGI 15 years back. As all of you know, SDPGI are considered to be some of the most confused guys. So I was trained in lab then, but then since then I've only been handling clinics. So what I'll do is I nevertheless thought I'll do this stuff and then I'll hand over all the questions for able to answer, who's my colleague there and a professor in SDPGI. This was a very good line I read from the rheumatologist about 2 years back. The diagnosis of lupus is similar to the diagnosis of minestrone soup. No single ingredient or combination of ingredients will confirm or exclude the diagnosis of either lupus or minestrone soup. Each has its many variations. However, no matter how minestrone presents, it is never confused with clam chowder. So this is more regarding clinical aspects of lupus, which is also true for the autoantibodies of lupus. All of us know that by and large, ANA by immunofluorescence would be positive in lupus. There are very few cases which are negative. This is my profile, the profile of my presentation. And I thought that it makes sense to write the number of slides because, gentlemen, males have very short attention span. So just one slide for each, as you can see here. History, one slide. Mechanisms of autoantibody production, ANA by immunofluorescence, 2 slides. Solid phase assays, dsDNA, anti-SM, just 1 slide on each of these. Because there's going to be a session on APLA I saw later on by Atil Rahman sir and a takeaway slide. So just total 11 slides. Bear with me for 11 minutes or 12 minutes at the most. This is the LE cell, as all of you know. Hargrav's, for those of you who don't know, most of you would know, was actually a clinical hematologist in the US. And he and I think the other name was Thomas Morton, who actually described the LE cell, which is basically a polymorphonucleoside which engulfs nucleus. And here you can actually see some of the debris here, some of the debris of the nuclear that you can see there. And it was around 1950s that the dsDNA and the ANAs came around. The names, these funny names of SM and Rho are actually from, SM comes from Stephanie Smith, who was the patient from whom the anti-SM was isolated. Similarly, these names Rho was defined at these times, and then La. And Cardiolupin has been pretty recent, and we are still confused about the antiphosphate antibodies. All of us know that. But now we're doing it by ELISAs. It was earlier done by radioimmunoassay. This is regarding how the antibodies and ANAs are produced. So basically, it's we all know that viral infections lead to interferon production through these endosomes, and the TLR7 are pick up the mRNA, whereas the endogenous DNA CPG motifs are picked up by the TLR9, and then they, through the interferon pathway, lead to interferon production, which leads to autoantibody production. So the exogenous pathway are the viruses, the endogenous pathways are the DNA, the degraded DNA. Most of the times in normal circumstances, these don't reach the endosomes, but only when there is aberrant DNA production then they reach these, and then that's how it's presented to the TLR9. There are also defects in phagocytosis. All of us know about apoptotic cell defense in lupus. We know that C1q animal model and also in humans, when there is C1q deficiency, it leads to lupus. Defects in endosomal and lysosomal degradation of endogenous DNA or defective handling of misfolded RNA. Now that is what the Rho60 actually does. We'll come to that function later. And so a Rho60 deficient animal model or those genes which lead to deficiency of Rho60 lead to lupus-like presentations. Why are only some of the autoantigens selected? Why is it only, there are thousands of antigens in the cell. Why just the Rho, the La, or the Smith, which is picked up? That's because they are linked to the nucleic acids, and nucleic acids, as you know, are present to the TLR7 and 9. So that's the one reason. The other reason is some of these are linked. For example, the SM and RNP are linked together. It's like, Amit Shah and Modi. So they come together. And so these kind of theories are all why only some autoantigens are selected. This is regarding immunofluorescence. Earlier, we used to do those Austerlony techniques and immunodiffusion and counter electrophoresis, which were cumbersome methods, are no longer used. There were also these rat liver subsets used, and if you have gone through the SGPGI workshops and seen that book, there are sections where they describe how the liver and kidney sections were made from the rats. So earlier they were used, but now we have better cell lines. While the sensitivity of ANA we all know is about 95 to 99%, the specificity is only 20%, and the positive predictive value is even lesser. That's a problem with ANAs. What are the steps of immunofluorescence assay? We done this when we were doing our DM, and after that, only read this. You have these Hep2 cell lines, glass slides. If the serum contains the antibody, then you wash them, put the serum and wash them, and then add the fluorescent conjugate to it. And if the antibody is present, it will show immunofluorescence. That's picked up by the immunofluorescence microscope. So these are the steps. These are the various patterns of the ANAs. I will not go into all of the details, maybe some of them. Basically, these patterns give you an idea about the antigens, but there's a lot of expertise involved here, and these developed over repeatedly seeing these slides. Now we use the Hep2 cell line, which is, as all of you know, is a cancer cell line. Many centers use Hep2000, which basically has the 60 antigen transfected into it. The advantage of the cancer cell line is that you have a lot of antigens because they are proliferating cells, and so you have large nuclei and more autoantigens that facilitates. The principles of immunofluorescence is basically that there are these wavelengths which these molecules pick up and then they emit, and each fluorophore has a unique wavelength. Fluorescein and rhodamine are the ones which I use. And then there are these two kinds of bulbs. One is the halogen quartz bulb and the other is the vapor. But since the other one has an autofluorescence, these are the ones which I use. There is a direct immunofluorescence where the antibodies bind to the tissue like the kidneys, and there is indirect immunofluorescence, the one which is shown here. There are troubleshooting steps, which I won't again go into the detail, but basically the pH of the buffer has to be more maintained, and they prefer frozen section to paraformaldehyde because the paraffin emitted section, because the paraffin changes the antigenicity of these cells. Therefore, this is preferred. These are the patterns as you can see here. This is the homogeneous pattern. For those of you who report ANAs, that's a fine render pattern. And these are these lysosomes show up there. The row and the la. And this is the nucleolar pattern. And that's the cytoplasmic pattern. What is the endpoint of dilution? Well, so if you were to do an ANA screening of at the dilution of 1:40, then you can find about 30% false, even in normal disease. But if you were to take the dilution up to 1:320, then that figure goes down to 1 to 3%. So the ideal dilution would be 5% of the normal population when it shows positive. That's so you have to run the test at your own normal population and see. But 1:20 or 1:160 would be optimum between sensitivity and specificity. Apart from these, there is a proliferating cell nuclear antigen positivity also, which basically has differing fluorescence because of proliferating cells, and again, but seen in only about 1 to 5% of lupus patients. There are problems if the fluorescence is weak or non-specific fluorescence, then there is another problem with the conjugate if it is outdated. The disadvantages of immunofluorescence, as you can see here, it's labor intensive, needs years of experience. Well-trained technicians can do it, does not identify the exact antibody. So this might tell you the pattern and give an idea. If you have homogeneous positive, that it might be DSG or histones, but it still doesn't give you the exact antigen which is involved, does not identify the exact autoantibody. And the row 60 might be missed because it might be washed away. Similarly, the ribosomal P also may be missed. The row 52 also, since it's cytoplasmic. And if the advantages of automated immunofluorescence are, and there are studies which have shown that the automated might be actually doing better than the humans. You can do a lot of, you can do about 20 slides and 140 assays at the same time. Coming to the solid phase assays, these are the solid phase assays, ELISAs, fluorescent microscope assays, and the immunoblots or immunoline assays. There are technical limitations of solid phase assays. While they are sensitive, they may not be very specific. The ELISAs, this is the methodology. I think all of you would have seen ELISAs, so I won't go to the details. That's the antibody created, and if you want the antigen in question, you add the fluorescent antibody and then substrate, and gives the color difference, which is picked up. The advantage of ELISAs are they are highly sensitive, ease of performance and reproducibility. Most of us now do commercial ELISAs in the labs. We used to have in-house ELISAs, but now most labs have shifted to commercial ELISAs. The disadvantages are that they are less specific, pure antigens are needed. There are also automated ELISAs which are very useful, and you don't need subjective. There is less of subjective error. You have cartridges and barcodes which mark for patient numbers. The immunoblots advantages are that it can be done in large numbers, semi-quantitative, decreases the labor cost because the nitrocellulose membrane is also now less costly, also identifies exact autoantibody. So the problems are that it is less sensitive, it misses the conformational epitopes, you might not be able to pick up those, not as many antigens as in immunofluorescence. So the nucleolar, which give nucleolar pattern might be missed there because those antigens are not easily available. I won't go into the details of this because this is not much used. Coming to the dsDNA, the ELISAs that we report have single stranded contamination, and therefore you actually have to treat them with S1 nuclease before, so that the single stranded DNA is lysed. Or you can do a Crithidia lucidea assay, which has this either mitochondrial huge or a kinetoplast, which is just dsDNA, circular dsDNA. It doesn't have single stranded DNA, and it shows up like that. So that's quite a specific test for anti-dsDNA. The problem is that sometimes there can be some immunoglobulins which can bind non-specifically to them. The FAR assay also used to be a very specific test, hardly used now. It was a radioimmun assay. And and as I said that earlier, in-house ELISAs, most of us now use commercial ELISAs. And it is important to validate from time to time these ELISA kits. The anti-SM co-localizes with the small molecular RNPs. They co-localize together most of the time. So most of the anti-SM antibodies would also have the RNP along with it. The reverse is not true. Subunits of SM form a heptameric ring, as you can see here. This is how the antigen looks like. The normal function of the SM proteins is to import the SN RNPs to the nucleus. It virtually always with RNP. The U1 RNP complex has these three proteins, the 70 kilodalton protein and the ANC. So the different kits, some of the kits might pick up just one antigen, some of them might have all three together. So if you have only one of these and the kit doesn't pick it up, then it might be reported as negative. I'm not going into the clinical associations because Chandrasekhar is going to take that up in the next talk. The anti-Rho and the 52 or amino acid sequences, they do not share any homology, which was previously believed, do not cross-react. And the location of the cells are also different. So while the Rho 52 is largely a cytoplasmic antigen, the Rho 60 might be in the nucleus or the nucleolus. Normal function of the Rho 60 is believed to be a chaperone and degradation of defective RNA. And that's why, as I said, that if you have a Rho 60 knockout, then they get a lupus-like disease with anti-spliceosome antibodies. The Rho 52 belongs to the tripartite motif group of proteins. There is a lot of interest these days in this particular protein. As you can see here, they are involved in anti-inflammatory function through acting on NF-kappa B and interferon. It's an interferon regulatory protein basically. So, and it is ubiquitation of proteins, binds to FCC of IgG and degradation of IgG as well. So mice lacking Rho 52 again are reported to have glomerulonephritis and hyperglomerulinemia. So they were believed to be having not that much of an important role, but now increasingly the roles are being defined. Anti-Li is a 47 kilodalton shuttle between the nucleus and the cytoplasm, and again has roles in basically RNA stability, mRNA stability. And in a negative lupus, Rho 56 will be washed out, as I said, or if the Rho 52 is cytoplasmic, and that's why people use the HEP2000, which has the Rho 60 transfected into it. But if you have another antibody like the dsDNA, now the problem with HEP2000 is only 10 to 20% of these have the Rho 60. So if you have a dsDNA which shows a homogeneous pattern and just about 20% of Rho 60, then it actually shows a dsDNA and the HEP and the Rho 60 might be missed. So you would still get an ELISA or a blot to treat that. This is a immunoblot showing the various according to the molecular weight. Just one side on APLA because APLA is being covered in the evening. It was first picked up because of phosphate of VDRL. They do not bind the anionic phospholipid, but actually recognize the serum proteins like beta-2-GP1. Antibodies against the former, example, protein C and S are also. There are also those we all know about the phosphatidylserine and phosphatoethanolamine and prothrombin antibodies, which are again increasingly being labeled as non-criteria phospholipid antibodies. The lupus anticoagulant, as all of you know, is a functional assay. This is one part of it. The Russell Viper Venom diluted time, the normal serum. If you have when you add the phospholipids, it coagulates. But when you have antibodies to the phospholipid, the coagulation is delayed and you have to add extra phospholipid to produce the coagulation. There are also second steps, the mixing step, which I won't go into the details of. And now we are doing anticoagulation ELISAs. The problem with these is that the antigen may have been washed off if no color appears. These are troubleshooting which you should know, and check the substrate period and conjugate if it doesn't show up that well, the ELISA of the cardiolipin antibody. There are some other antibodies which I'll just mention. Anti-RNLK is 1 to 5% of cases, not very important. You know about the direct Coombs test and the antiplatelet antibodies, beta-2, GP1, anti-neuronal antibodies, NMDA receptor, and other ones which are increasingly being found but not still have clinical associations. And this shows the cytoplasmic staining, which used to be done with the rat, is still done with the rat, liver, kidney, and stomach, because that shows a better cytoplasmic pattern. Most of the autoimmune hepatitis antibodies and ribosomal P and even Jovan and those kind of things are cytoplasmic patterns. So as postgraduate students of rheumatology, definitely you should know about these patterns and how to interpret these. So my takeaways are that immunofluorescence is still the gold standard for sensitivity of ANAs. Automated tests may be in vogue in the future. Patterns may suggest the relevant autoantigens. Row 60 may be missed on an IF, and so row 52 too. And cytoplasmic, the ones which show cytoplasmic pattern also may be missed. You should be aware of these. Solid phase assays like the ELISAs are easy to do, reproducible, but at the cost of some specificity. Immunoblots may miss some nucleolar antibodies. dsDNA methods have to take into consideration single-stranded DNA contamination. And while Crithidia lucili would be ideal, it's something which we don't order very often. ENAs are done by immunoblot and may be confirmed by an ELISA in an occasional patient where you're not still certain of the diagnosis. So I think with that, I'd like to end my talk. And do we take the questions now or at the end of the session?
Are there any questions?
You can even ask after the clinical. I think most of the questions would be for the clinical association, so we can have them.
As Sapan's compared lupus to a soup with many ingredients, you can think of SLE as several sub-syndromes, each with their own pairs of manifestations and autoantibodies. And it is these autoantibodies are primarily useful in understanding these sub-syndromes. So I invite Dr. Chandrasekhara to give a talk on the clinical correlations of autoantibodies, and you know that you can use it for prognosis and monitoring disease. In addition, in my experience, when you can predict the autoantibody from the clinical setting, then that is when it is most useful. So it works both ways. I invite Dr. Chandrasekhara to give the major talk of where you might have a lot of This one the point. This one is
Good afternoon. At the outset, I thank Dr. Alkindu and his team for inviting me to present this lecture. I think I remember the last year in the same meeting, I had an opportunity to discuss about the pathologic and pathogenetic process of an autoantibodies with reference to lupus. I think this time the topic switched to the bench side then to bedside. I think Dr. Sapan has elaborated how in a lab we can test and make these autoantibodies. And when the result comes into the clinician's hand, what exactly we should do with reference to these autoantibodies. As the time progresses, as the technique has improved, we used to get only ANA 2-3 decades before. Then we got few more autoantibodies into the list. And the profile, which used to be 10, became 12, now became 24. Once the microchip technique comes, probably you get all the 120 autoantibodies typed within 8,000 rupees or 10,000 rupees. Then you have it. So now you have the full spectrum of autoantibodies results in front of you. The question comes is, what should I do with this? So now, we all know that SLE is a disease of autoantibodies. It's one of the epitome of a disease of autoantibodies. I think anytime when we talk of autoantibodies, it's SLE and SLE-related diseases what we talk of as one of the best example to discuss about autoantibodies. And we all now know we have more than 100 autoantibodies. And this happens to be the only disease where 3 autoantibodies are included in the criteria. 4, I mean the ANA itself is one of the autoantibody with which you start the diagnostic criteria. And we have anti-dsDNA, Smith, and anti-cardiolipin, which are given due scoring when you are going for a diagnosis of lupus. So per se, autoantibodies starts its journey with reference to lupus in the clinical setting from the point of diagnosis. When you have to diagnose, you need these autoantibodies to be positive before you make an unusual, authentic diagnosis of ANA negative autoantibodies, which is quite unusual, but otherwise a presence of an autoantibody is a must before you make the diagnosis. Then comes the point, actually, I think the chair Abel was telling that can I use these autoantibodies? Can I progress? Can I predict? Can I titrate? Can I alter, prognosticate the patients with the autoantibody results I got? Or in addition, can I also personalize the very treatment and the medication to the patients? Can I take a call? Should I go with an aggressive treatment for this patient in the very beginning? Should I go with a lesser profile immunosuppression to this set of patients? Can I utilize this as a marker or a predictor for personalizing the treatment as well as the prognostications and therapeutics? So why personalization is required? I think Professor Mukherjee said in the very beginning that SLE is a heterogeneous disease, and it's one of the highly variable disease. Presentation varies, outcome varies. The clinical outcome varies from patient to patient, from the same patient from time to time. So treatment strategies, currently what we depend on, we heavily depend on the critical organ that is involved. If there is a renal involvement, we go aggressive. If there is a CNS involvement, we go aggressive. If both the systems are involved, aggression is still more. If pulmonary involvement is there, we are moderate in aggression. If it's only skin and musculoskeletal system, the aggression is still more lesser. So currently, what takes a decision is the critical organ involved, and based on that, we actually look into the aggression of the disease. So treatment strategy currently depends on the clinical presentation. And we all know that there is an association of autoantibodies and the clinical presentation. So this is a theoretical basis on which all of us know autoantibodies are pathogenic. So most of the autoantibodies produces immune complex or drives the anti-dependent cell-mediated cytotoxicity or whatever the mechanisms through which these autoantibodies are generating the disease process. The pathogenesis produces clinical features and damages. That's a point on which currently we are taking the treatment strategies. Treatment strategies are currently decided by what is the clinical features, what are the organ involved, what is the possibility or a likely damages that's going to incur. Based on that, we are intervening. Based on that, the end point of the patient comes is the outcome. So if any patient comes, what we are worried about is the outcome. The whole tree process, mechanistic process that happens with reference to autoantibodies is the way it makes the way through to the outcome. So now, what are the factors which influence the pathogenesis of an autoantibodies? Why I just want this fundamental is for you to understand what next is going to come on the screen. When it comes to the pathogenesis, why there is so much of heterogeneity? Not all patients with anti-dsDNA will have a renal involvement. Not all patients with Rho positivity will have a dry eye or dry mouth. There is a few percentage or a few proportion of patients who develop renal disease. Quite a good proportion of patients may not develop the renal disease. This is expected to happen because of the multiple factors by the very characteristic of the autoantibodies. The epitope it decides, the IgG pattern, what type of immunoglobulins it is, whether G, 4, 1, 2. What is the pattern? What is the epitope it recognizes? What is its capability to increase or raise the complement activations? All these factors of the autoantibody decides whether it's going to be pathogenic and what is the pattern of pathogenesis it produces. Then the genetic and other existing disease of the host, whether the individual's genetics, the individual's penetratability, and various other coexisting diseases do influences how the autoantibody produces pathogenesis. In addition, what we forget about is the presence of few of the chronic infections like cytomegalovirus infection, Epstein-Barr virus infections, varieties of chronic persisting viral infections tunes and alters the way immune response occurs to any of the antibodies. When that tuning is there, that also determines how an autoantibody is going to have a pathogenesis. And the drugs that we use both for the lupus and other associated conditions. So the pathogenesis is influenced by varieties of other factors in addition to the autoantibody. So what I mean here is, it's not just the presence of autoantibodies which can 100% associate. That's why you don't see in any of the autoantibodies 100 association. Association ranges from 40% to a 70-80% max. And we say the p-value less than 0.05 is good, great. And we say that the association is good. But when it comes to the individual patient, this statistical significance of 0.06 doesn't allow to personalize the medicine. So now, how to go about this? So in addition to that, as I said, the outcome in addition to pathogenesis also decides on the other determinants of health and the treatment interventions. The final thing comes is the outcome. This is the fundamental on which we are working to figure out how to improvise the personalization of the treatment. So I will just share you in next few slides the work that's going on in Chandra Rheumatology Center with reference to how to utilize these autoantibodies in predicting or trying to help out in personalizing the medicines. So how have we worked it is, we took the clinical features, the organ involved, and we took the outcome. What we did is we classified the outcome into 6 categories. As you know, less than 4 is considered as the disease in remission. We categorize them as less than 4 without steroids, less than 4 with steroids, 4 to 10 without steroids, 4 to 10 with steroids, more than 10 of the SLEDAI score, and the death. These are the 6 outcomes which we have taken. And also we altered the way we have used immunosuppressive therapies. The mild, where methotrexate, hydroxychloroquine, and prednisolone less than 10. Moderate, mycophenolate, azathioprine, cyclosporine with or without steroids. Steroids can be more than 10 but less than 0.5 mg. Aggressive, where we have used cyclophosphamide, rituximab, or bolus. So based on this, we try to figure out how these complex autoantibodies can help in predicting the outcome. So in addition, when we first tried with, can these autoantibody predicts the clinical features? When we were trying to use for the predicting the clinical features, there was very limited correlation. What we could see was a significant association of dsDNA with renal involvement, SSA with dry eye and dry mouth. Barring that, rest of the antibodies were marginally influencing either the outcome or the clinical features. So what I meant here is the correlation was not significant. In addition, we had another problem because the distribution was normal. It was not really helping in the outcome of these set of patients. So this is how we looked into the correlation. If you look into the correlation, I'm sorry for the crowding and the small letters, you can very well see that dsDNA has a negative prediction for the early 2 outcome. That is a less than 4 with and without steroids, and it has a higher tendency to have the outcome of on the higher side. That is 4 to 10 or less than 10. So there is a gradual worsening if they are positive to anti-dsDNA and positive to Smith. On the contrary, SSA and SSP has a little bit other way around. So there was some impact or influence of these autoantibodies with reference to outcome as an individual. But most of us know we never get one autoantibody in a patient. Usually, with an exception of few, most of the patients we get 2 or 3 of these autoantibodies positive. So that being the case, working with single autoantibody as a predictor may not help us much. So we work towards making what is called as using the artificial intelligence and ML, using Python language. We were trying to cluster the group of autoantibodies on the frequency of their occurrence. So you could see that in the patients less than 4, we have a crowding. But as you can see, the dsDNA happens to be one of the common autoantibodies. I mean, that's obvious in this group because lupus is the patients whom we are considering. And that being the case, we are not surprised by seeing dsDNA being in the higher percentage. So if you could see the number of patients and their congregations, and we were trying to cluster them to figure out different groups, we could see 4 clustering in these groups. Cluster 1, where we had almost no patients, which had SCL70, PCNA, PMSCL, CNP, JO1, and MM2 and SSB. Cluster 2, which had histone, RIPE protein, and Rho52. Cluster 3 had dsDNA, Smith, RNP, nucleosome, and SSA. You can see that most of them are ENAs, extractable nuclear antigens. Cluster 4, where all are negative. Most of these 24 autoantibodies which we are analyzing, most of them were negative. Then we tried to figure out, is there a difference in the outcome? If you look at it, the SLEDAI less than 4 without steroids, you can see a good number of patients with negative for all the autoantibodies were significantly in the patients with a good remission. And also, the patients in cluster 3 and cluster 2 didn't behave much differently, except for a good number of patients with the one more column where the SLEDAI of more than 10. So what it means that there was some amount of difference in the outcome, which is quite obvious, but it is not that very obvious with this kind of clustering. So then we went on analyzing. We could also see that Raynaud's phenomena was high in the cluster 2, and also renal involvement was high in cluster 2, where there was dsDNA. So that made point clear that though it doesn't completely depend upon the system that is involved, there is some element of prediction possibility based on the clustering of these autoantibodies. We all know that there is a good amount of interaction that happens between the autoantibodies. dsDNA with SSA could be protective. dsDNA with a low titers of SSA may not be protective. There is a sort of a cross interaction which happens between these autoantibodies, which should be brought into the flow when we are going to predict in a clinical settings. So then what we did was, we tried to figure out that there are some of the autoantibodies, we had no patients at all. And we also compared between the groups, which has been clustered by these mechanisms. Is there a significant difference? We could see that these had no significant difference between the group. So we took a wise decision not to use these autoantibodies, and we deleted these antibodies for our further reclustering. We reworked our clustering, deleting AMA, M2, JO, PMSCL, and CNPV, which was not significant. And then we redeveloped the clustering in this. When we did it, first cluster which evolved was Rho, SSB, histone, and RIPE protein. And the cluster 2 was dsDNA, Smith, RNP Smith, nucleosome, and SSA. And other one is all negative. If you see the predictability has now improved to up to 3 groups. But these are the 2 groups where still predictability is not great. The reason here is we need the numbers. The number of patients currently we were able to analyze is only around 257. We need at least around 500 patients data to analyze this to get into a reasonable statistical understanding, because AI and ML work with the larger number. We can have more good number of patients. With the larger number of patients, the differentiation and characterization improves. And also you could see that when we reclustered, more number of clinical features also become separated out. And it's also quite clear that presence of oral ulcers, presence of Raynaud's, presence of renal involvement, which usually predicts a worse prognosis, are clustered into the areas where these autoantibodies are grouped or clustered. So it makes us more clear to understand that the clustering based on the autoantibodies can help us in predicting the outcome. So you can start working in the very patient walks into you with these autoantibody profile, how exactly, where exactly the patient can move through. So then subsequently, we analyzed it further within the subgroup, but the numbers are still less. You could see that there is some amount of difference in the group. In the dsDNA, you can see higher proportion of patients being with the SLEDAI of more than 10. We also tried to analyze the impact of the drugs that we have used. You can see that the good number of patients were on the low dose, and in the patients who are all, who had less number of autoantibodies which are influencing, we have to use higher dose drugs, especially in the patients with dsDNA. But it was not statistically significant because of the varieties. The problem here is the number. We will be working on this. What are we working at this point of time is using these data and these analytics. We are going into the next step of statistical analysis using correlations and others. I mean, I'll not go into the details, just to, we could see that there is a lot of associations which we can see. Smith have a positive association with low dose treatment doing good. And we are just working on these associations to figure out a scoring pattern or a scoring system which should help us as a model in predicting the patient as soon as he walks into you with his ANA profile. And it just can't be with autoantibodies, because the problem is, as I said in the very beginning, mere presence of autoantibody doesn't guarantee us that it's going to produce that particular disease or that particular organ involvement. To guide that, there are few other clinical characteristics which has to be clubbed together. So we are proposing an integrated model of putting the whole system in place so that we can have and develop a probable scoring system which could help us in the very beginning as the patient walks in to personalize his treatment, that whether he has to go for an aggressive, mild, moderate, or the way he moves forward with reference to his treatment and therapeutics. Hope this application from bench side will move successfully to the bedside. It needs a lot of efforts and things are going on. Hopefully in another couple of days or months, we should be able to catch with it. Thank you very much.
Any questions? Can I ask you one question, Chandrasekhar? That is, what are the unmet needs of autoantibodies in the evaluation of SLE patient who have got so much of phenotypic variation and organ damage? Some of them may be attributed to pathogenesis. Some of them are considered the biomarker. So how do you place this, particularly with reference to very early SLE?
Yeah, so the unmet need is that if we can figure out in the early SLE,
yes,
whether you need him to take to an aggressive treatment or a less aggressive treatment, because now it's very clear from the experience of rheumatoid and vasculitis. Earlier to intervene in the autoimmune disease process, outcome and prognosis is good. So now I need to figure out whether I should put this patient onto a high aggressive immunosuppression even before the organ are involved or not, is a point of question that all of us are worried about. We are always worried, if I put a cyclophosphamide in a patient who would have never developed an endoxan, I won't excuse myself. On the contrary, if I delay giving a rituximab or a cyclophosphamide for a patient who develops after a year end with a renal involvement, we think twice. We made a mistake of not exposing him to rituximab or endoxan. To what we are trying to explore is, and what is one of the major unmet need is that, can I personalize this in the very beginning when the patient walks in without a major organ involvement or a major organ damage, so that I can pick up the right patient for a right treatment? I mean, the more major problem for us is, unlike 10, 15 years before, where we didn't have much choice to pick from the treatment options, we now have I can say almost, I say that we have a cafeteria choice of immunosuppressants. The question that comes for us is that, which one I should choose, how should I choose, why should I choose? And these questions are the three unmet needs with reference to most of the autoimmune disease, especially a disease like lupus, and which is a heterogeneous disease, and you have a disease which is too mild to a worse disease. So that is a major unmet need which we are.
Now, I am raising this question because in the laboratory practice nowadays, ANA panel has been brought out. An ANA panel plus minus without any scoring system. That may be confusing to the clinician. Even it goes to the internist. It becomes very confusing to make out a case. Because I say this one day, I had a case of systemic lupus, who's ANA positive and all other negative, anti-coup positive. Anti-coup positive. And that was a big surprise. What are the specificities of anti-coup positivity in the clinical context? Patient is being treated traditionally with hydroxychloroquine with or without steroids. But implication of this kind of autoantibody in the panel may be very confusing. That's why I raised this question.
See, that's one of the interesting issues. The problem in reference to autoantibodies, the question that remains is, if we report titer, does it help? Answer to that question is partially yes and partially no. The reason is the titers of the autoantibodies, with an exceptions of few like anti-dsDNA, CNK, etc., do not match to the clinical presentation and the clinical severity of the disease. So that being the case, so the plus, 2 plus, 3 plus, finally you get to take a call whether the coup-related symptoms and signs are present or not. If it is present, then 1 plus also is significant. If it is not present, 3 plus is also insignificant. Okay. Another major challenge in these are the interaction between the autoantibodies. As I was trying to tell you, if there are more than 2 or 3 autoantibodies, the way the immune response is going to be is a totally deviated immune response. Then the decision making or a treatment making becomes a different. Actually, what we are doing here in this particular model building, unique to other, because I think there are around 25 papers have been presented in the way what we are doing. The same pattern of pattern recognitions have been worked out. Basically, most of them are the number is an issue. So we have in our center, we have quite a good number of patients who have been followed up. We have only picked up 250 so far for analytics. We have approximately around 600 plus lupus. We have been followed up for nearly 5 to 8 years. So we have the data day by day of these set of patients. So we are just looking at those. Can this develop a predicting model? We are also simultaneously applying mechanistic model as well as the other AI's models to integrate the outcome. Let's see where we go. I mean, it's an attempt. It's just an attempt. Yes, sir. Now we are planning to get the scoring into place.
I think I understand what Dr. Mukherjee is trying to say is that many a time, many labs report borderline or doubtful things as positive. This is where the
standardization.
Standardization. Ideally, I can believe only if I see the strip. So there should be a picture, and this is where the grading, is it clearly positive or is it borderline positive?
Yeah.
This causes a lot of confusion. And coming back to who generally behaves like an MC, mixed connective tissue disease like phenotype, limited scleroderma, some ILD, some lupus features. In fact, you can confuse who patients with MCTD.
If doctor is confused, the patient is confused and follow up with this.
Yes. No, that's a bedside problem. I think Sapan has to address that. But the bigger issue that we have is standardization of reporting is very much not there. There is no standardization of reporting across the labs, and the reporting, even the diagnostic companies which are manufacturing those kits also don't enforce the reporting processes.
Is there any subgroup analysis of those patients who has got multiple autoantibodies with high IgG levels, or subgroup who has got high disease activity like that?
I couldn't get you, Damodar. Can you come back?
High immunoglobulin G levels.
And the autoantibody relations.
And the severity of the systemic disease.
No, we have not really worked into that actually. There could be, but what we have seen is higher the autoantibodies, more likely the disease is going to be aggressive, especially external ENA, extracted nuclear antigens when they are present. Usually they have a little more aggressive disease. But I have not seen or not knowing, not read the literature about IgG concentration, autoantibodies, and the lupus outcome. I am ignorant about it.
And did you made an attempt to see the level of complements and?
We are at it. Actually. We are step by step moving to the complement levels. We are step by step moving into the clinical scoring patterns.
Thank you, Chandrasekhar. And now we pass on to the next, because we are running behind time. Shumantra Mondal autoantibodies in cloud to make us more confusing than what is happening in clinical practice.
Good afternoon, respected chairperson, my respected teachers, my dear colleagues and my junior. Moving to the third topic of this session heading, lupus looking through autoantibodies. And I am starting with a case of a 49-year-old female with 3 months history of arthritis, hematuria with anasarca. She had skin rash and Raynaud's phenomenon. Her previous skin biopsy showed leukocytoclastic vasculitis. Lab features showed hypoalbuminemia with a raised creatinine level, and urine analysis showed active sediments with a very high 24-hour urine protein of 9 grams per day. She had a low C3 and C4 level, and her renal biopsy showed class 4 lupus nephritis with a full house pattern of immune deposition in indirect immunofluorescence study. She was treated with mycophenolate and steroid, and after 7 months, there was normalization of the serum creatinine level and complement level, and urine protein level reduced to more than 50%. So from the description of the case, we can expect the ANA result, but the ANA was found to be negative, which was checked 3 times by ELISA and 2 times in HEP2 cell line. Her dsDNA antibody in ELISA was also negative, as well as the ANA profile. This case was published in American Journal of Nephrology recently in 2015, which showed ANA negativity in a lupus nephritis patient who is having full house nephropathy. It is such a case where ANA positivity was strongly expected, but ANA came to be negative, or where the autoantibodies in the cloud. So it can be stated as ANA negativity in lupus. I have subdivided this topic into 3 following headings. What are the evidences from the literature about the ANA negativity in SLE? What are the probable causes of ANA negativity in SLE? And should, apart from the nuclear component, the cytoplasmic or mitotic component be included in the ANA testing or not? The first description of ANA negativity in lupus was given by Kolar in 5 patients who are having photosensitivity, but ANA was negative in 1976. Subsequently, in 1982, McHardy et al. Showed ANA negativity in almost 9% of their SLE cohort. In the various reports, the overall range varied from 1% to 28%, but after the use of the HEP2 cell line for the indirect immunofluorescence, ANA negativity in lupus is actually very rare, and it is less than 2%, as can be seen in the latest edition of textbook of Kelly, that in SLE, almost 99 to 100% of the patients are ANA positive. Most of the case description were given from 1976 to 2000, in which 19 papers described almost 164 ANA negative SLE patients, among which almost all, that is 97%, was described between 1976 to 1987, before the widespread use of HEP2 cell line as IIF substrate. In 2004, there was a analysis which was published in QJM, which included these 19 papers, in whom almost in 78% of patients, the diagnosis of lupus was questionable, and out of the remaining patients, the true ANA negativity could not be established. Now, after 2003, there is another report which was published in 2018 with a description of 20 ANA negative lupus, among which almost 1/3 had questionable lupus, and in the remaining 70%, the actual ANA negativity was found to be less than 2% only. And ANA negativity in lupus can have various factors or due to many causes. One of them, as I have mentioned, the questionable or indirect or incorrect diagnosis of the SLE, which was seen in most of the previous reports, in which almost 78% of the cases has insufficient clinical data, most of them not even fulfilled the ACR criteria for lupus. As we can see in these cases, in most of the series, the number of ACR criteria fulfilled was 3, but actually at least 4 or more ACR criteria is required for a diagnosis of lupus. And these are the studies before the use of the SLEEK criteria or the latest ACR EULAR criteria. These are mostly published from 1976 to 1994. So incorrect inclusion of patient may be a factor which can show this high percentage or high proportion of ANA negativity. So when ordering for ANA test, it is important to consider other important differential which may mimic SLE, but in which the proportion of ANA positivity is very less or either absent. Another important factor is the concurrent immunosuppressive therapy, which can alter the ANA result, and it has been shown in previous studies that high dose of corticosteroid can influence ANA result. In most of the previous studies, the details of the ongoing medication or the previous medication was not given properly. And so, as we can again use the chart, in neither of the cases, the treatment at the time of ANA testing was not given. So the ANA result may be influenced by concurrent high-dose immunosuppressive therapy. Proteinuria can have effect on the ANA result, and it can be shown that patients who are initially ANA negative can be found to be ANA positive following successful treatment. And because better treatment or successful use of immunosuppressive can halt the proteinuria and reappearance of the ANA, which was initially negative. Another important factor is the presence of active serositis, in which there may be leaching of autoantibodies into the third spaces like the pleural space or peritoneal spaces. So in these cases, the serum may show ANA negativity, and the pleural or peritoneal fluid, if can be used as a substrate, can show ANA positivity. In the disease course, seroconversion is another important factor, and it can be seen in both ways. Patients who are initially ANA negative can become ANA positive subsequently, as it can be seen in 10% in cases. On the other hand, initially ANA positive may become ANA negative. And this is a recent Swedish study which longitudinally analyzed the ANA seroconversion in SLE with 54 newly diagnosed cases. And they have shown that almost 13% of patients lost their ANA positivity over time. Most commonly, the patients who were positive for antihistone, anti-Smith, Ribo-P, or dsDNA showed a seroconversion from positivity to negativity. On the other hand, the antibodies directed against the ribonucleoprotein were constant during the disease course. So it is also important that the disease course might have some influence on the ANA positivity. And if there is a strong clinical suspicion of ANA, we may have to repeat our test accordingly. This I have kept as the 5th point, but this is the most important point, that is the technical aspect which can affect the ANA detection. We most commonly use these 3 test methods. One is the indirect immunofluorescence, which is considered as the having highest sensitivity to more than 95%, and it is approved by the ACR to be used for the detection of the ANA. There are other tests like ELISA and multiplex bead assay, which are somehow lower sensitivity than the IIF, but they are now improving and they can do a large number of tests in a short time. For ELISA, the major problem is there is no uniform cutoff values, and different labs use different cutoff values, which might influence the ANA result. So if we do not use the IIF and rather use the solid phase assays, then there is somehow a better chance of getting ANA negativity. Another critical step is the antigenic deficiency in the substrate. In most of the studies which was published before 2003, they used multiple different substrates for the IIF, including human prostate cell, human granulocyte, human splenic epithelium, mouse liver, rat liver, fibroblast, kidney cell. And after the use of HEP2 cell, it was found that the HEP2 cell are rich sources of the autoantigens, and they can improve the sensitivity of the ANA detection. They also give a very large nuclei for the easier and more better detection of the patterns of the ANA. So before the HEP2 era, the proportion of ANA negativity was somehow larger, but after the introduction of the HEP2, the ANA negativity is actually became much lower. However, there are some limitations of the HEP2 cells, mostly dependent on the manufacturer, and one study showed that using 5 HEP2 kits, the overall agreement is only 78%. Another study detected ANA negativity in lupus using 3 kits and showed a wide variation ranging from 5 to 22%. Previously, Rho deficiency was a drawback of the HEP2 cells, but after 2000, the Rho transfected cells have improved the detection rate of ANA. Some other technical factors like inadequate fixation and drainage of the antigen, especially when alcohol are used. Discrepancy in the specimen dilution, which is used by the different labs, and the variation in the reporting, that whether it is a negative or 1+ positive. Regarding the last two parts, there was an article published from our country that what should be the optimum screening dilution for the diagnosis of SLE. And they took patients from SLE, inflammatory myositis, and rheumatoid arthritis and controls. And they used 5 different dilution and have shown that the base discrimination between healthy patient and SLE can be done if we use the sample dilution or screening dilution of 1:80 and intensity of at least 2. And it is important to note that this 180 dilution has been considered as the entry criterion in the latest ACR EULAR guideline for the classification of ANA, which has been published in 2019. And this article was published in 2007. Coming to the last part, should the cytoplasmic component be included in the ANA testing? We usually use different nuclear patterns, that is the homogeneous pattern, different types of speckled pattern, or the nucleolar pattern, or the nuclear dot pattern. And these cytoplasmic patterns are usually not included in the ANA reporting and not permitted. Anti-RIBO-P is one of the specific autoantibody which is seen in SLE, but they usually give cytoplasmic pattern. So if cytoplasmic pattern is not included in SLE patient with only RIBO-P positivity, will be reported as ANA negative patient. Now let us see what is the current status of reporting of the nuclear and the cytoplasmic pattern. But before that, this study that anti-nuclear antibody negative SLE in a SLEEK cohort, which included 1,137 patients. They divided their patient as per the HEP2 cell result on 3 groups: ANA positive, that presence of either nuclear or nuclear plus cytoplasmic and mitotic component, all negative, and isolated cytoplasmic or mitotic component positive. They found almost 93% patients were nuclear positive or nuclear plus cytoplasmic component positive. Interestingly, only 1.5% patient had only cytoplasmic and mitotic component positive. So if we include this pattern along with the nuclear pattern, it will likely reduce the ANA negative SLE case. And this study showed from different countries, almost 67 countries, that cytoplasmic component are reported by more than 72%, that is almost 3/4 of the laboratories. It is considered as ANA positive in more than 50% of the clinician and 62% of the lab professional. And if we combine indirect immunofluorescence with some specific tests like ELISA or line immunoassay, it could give us better result. So let us summarize the 3 headings. So ANA negative lupus, what is the burden? There are wide variation. They are mostly seen before 2000, where the detection was not done by the HEP2 cells. But using HEP2 cells, the proportion is very less than 2%. The probable causes of ANA negativity, it is multifactorial. The technical heterogeneity of the ANA detection, difference in the lab parameters used, reporting expertise can influence the result, along with some other factors that may be patient-related, like the proteinuria or the concurrent immunosuppression. So it can be corrected by more uniformation of the techniques and using sensitive assays like indirect immunofluorescence. Will inclusion of the cytoplasmic component reduce the ANA negativity? Definitely yes, as we have seen from the 2019 study that cytoplasmic and mitotic pattern can be seen even in sleek cohort, all were diagnosed as SLE in 1.5% of the patient. Last question, will there be any ANA negative lupus in future? As per the 2019 Euler-Asia criteria, as the entry-grade criterion has been set as a ANA positivity in at least 1:80 in HEP2 or equivalent cells. So in future, probably ANA negative SLE will not exist. Thank you.
Thank you, Sumantro. Only one question. Please.
Very interesting, Sumantra. What proportion of renal limited lupus would be ANA negative? Is there any data there? Because our patients mostly are positive, but renal limited lupus, like the one you said. Because if you have a full house effect, which means IgG, IgM complements, if there are so many immunoglobulins, why should the ANA be negative if there is a B cell drive which is producing those immunoglobulins? But the question is, what is the renal data on that?
Yeah, so I have started with the case that is, this patient was a full house pattern of nephropathy, but still the patient was found to be ANA negative by different tests. And they have also published some of this type of case series, but the probable cause of this ANA negativity was not explained because in this patient, there was no diagnostic dilemma. They have used the HEP2 cells, they have used the ELISA, they have used the line immunoassay. But still that in the face of a very high degree of proteinuria, as I have mentioned as a cause of ANA negativity, can be the most probable explanation of becoming ANA negativity in this highly active stage of the disease. And after treatment, but it has been also shown that after treatment, the 7 months data, there was no seroconversion. That the initial ANA negative patient, after controlling of the proteinuria, she did not become seropositive. So this is an exceptional case.
Dr. Sumantro, just one small question before I conclude. What dose of steroid and duration of steroid therapy make the patient positive ANA to negative?
Sir, there are few case reports where steroid and immunosuppression having some effect on the ANA negativity have been described. It was most of the studies have done before 2000, and the immunosuppressant was used at that time was chlorambucil. The steroid was given in 1 milligram per kg along with chlorambucil, and after 4 to 5 months of treatment, they have shown the ANA became negative. But actually, what was the cumulative dose that was not given?
But so many cases we have seen, most of us have seen, it's hardly to get a ANA being negative on steroid. Whether it's a dose or duration, that is important. Whether even with the remission, dsDNA can become normal, anti-ROM become normal, but the ANA will be negative. That is a very hard finding to see in a longitudinal study. That's what I'm asking, is the dose or the duration that is important, because that is the way the full remission. We'll come to the preclinical SLE, then we can understand what is the genetics of these type of cases.
So
it's difficult to comment on this because most of the clinician will think, make the ANA negative. Everything will go into remission minus the ANA. If ANA may be in low titer, but not totally absent. That is my feeling, but your understanding is different. That's why in one of the slides you have mentioned steroid, but it is very non-specific, neither the dose nor the duration, which is important.
So the Swedish study which I have mentioned, they have followed up it for 96 months, and they have showed the patients who have autoantibodies mostly directed against the nuclear component, that is the anti-dsDNA, anti-SMIT, they become negative, but the patient who have autoantibodies against the RNP component, that is anti-RNP-SM or anti-ROLA, they usually have a stable autoantibody level over the time. So if a patient having a background autoantibody positivity, which are mainly directed against the DNA component, there is a theoretical possibility that after treatment, they can have seroconversion from positive to negative.
Thank you, Sumantro. I think we are 5 minutes late. Let me close the session with lot of confusions, conflicts, and some of the practice tips in the diagnosis of SLE, in prognostication, and in the prediction of the severity, and finally the outcome of remission. Still, it is a Cinderella of medicine where autoantibodies remain very speculative in the long run unless we make a journey further and make the laboratory more efficient in reporting cases. Otherwise, we may be confused. Thank you all.
Thank you, speakers, for that wonderful session on autoantibodies. Now we move on to the last talk before we break for lunch. There are not many emergencies in lupus, but the few which exist are organ-threatening, if not life-threatening. So to talk about this topic, we have none other than Dr. Debashish Danda, the current president-elect of APLAR and the past president of IRA. So we thank you for your time and presence over here. The session will be moderated by Dr. Narayan Banerjee and Dr. Molly Taba.
Without much delay, may I request Professor Danda to start his session. He doesn't require any introduction. I think his topic will take a whole one-day session, but I am sure that Professor Danda will be able to finish within time. Professor Danda, please.
Somebody said just now that lupus doesn't have many emergencies. Lupus is full of emergencies. Lupus is an emergency disease throughout life. Now, I'm also coming just before the lunch. Lunch is not a very healthy food for modern civilizations. I think forget the lunch for some time now. If you feel hungry, keep your mask on. Now, if you see the natural history of lupus, as Dr. Chandrasekhar was mentioning, how could one diagnose preclinical lupus? It's a difficult scenario, but the future of medicine will definitely identify the genes and the environmental interaction, which initially presents with autoantibodies, eventually only the clinical features of organ involvement come to the clinicians, actually see the patient only after a long period of preclinical phase, like in rheumatoid lupus also. And then eventually the flares and organ damage, etc. happens. And then comorbidities like infections related to drug or atherosclerosis, malignancies, all can come in. For any disease, economic impact is an important factor. And this study has shown that the patients with severe lupus has much higher cost compared to the people with mild and moderate lupus. And this has been studied both in the inpatient services, emergency doors, the clinics or outpatients, as well as in pharmacy. So this is very important that you can see here that if you see from the patients having outpatient or emergency doors or OPDs, pharmacy, everywhere the white bars are the ones which reflect the severe lupus, and the cost is much higher compared to mild and moderate lupus. Now, these are some of the categories of lupus emergencies. This is far from being complete. It can present a general systemic emergencies, hematological, pulmonary, renal, GI, neurological, cardiac, and pregnancy-related are some of them which all of us come across who are in rheumatology practice. The general systemic ones are actually the most severe ones. One of the biggest challenge in lupus, as all of you know, is fever. And this may include the following ones, but it may not include always macrophage activation syndrome, catastrophic antiphospholipid syndrome, and thrombotic thrombocytopenic purpura are some of the general systemic features. The fever is one of the general systemic emergency in lupus. And as you know, in case of fever, in SLE, infection versus disease activity is the main challenge. Whether it's a fever with chills or no chills is one of the simplest clues that people with patients with lupus with disease activity without infection usually do not have chills. Same, all of you know, low complements are usually features of lupus activity as compared to high. Similarly, low counts and low CRP, as all of you know, that except for serositis, there is a mild elevation of CRP because of lupus. Patients have high anti-CRP antibodies. We don't get much of CRP elevation in lupus. Now, macrophage activation syndrome, although described predominantly in systemic JIA, it's present in almost 1 to 5% of patients with lupus. And can be a life-threatening complication. It is presented in many of the autoimmune diseases, including lupus. Although the hemophagocytosis is supposed to be a characteristic feature, it's not it is not found. And also it can give rise to various clinical features involving cytopenias, drop in ESR, high CRP, rise in liver enzyme, coagulopathy, with fibrinogen being low, that causes the low ESR, low platelets, high D-dimer, high triglycerides, low sodium, hyperferritinemia, all of you know, and many other features, but most important is the high spiking fever. So the patients usually may go for renal deterioration, neurological complications, and there is a significant mortality if not detected early. And these are the patients often can be easily missed out in the setting of SLE because some of the features mimic lupus activity. So this is the characteristic hemophagocytes may not be always present in lupus. Up to 40% of patients of lupus with MAS may not have hemophagocytes in the bone marrow. So if you see in the context of rheumatic diseases, this picture gives very beautiful picture. The genetic predisposition, there are certain genetic predispositions which give rise to macrophage activation syndrome. There are defects in the cytolytic pathway. There are background inflammatory activity which happens in all autoimmune diseases, predominantly high IL-6, IL-1 beta, and IL-18. And they all can give rise to transient defect in the cytolytic pathway. And the triggers can be infection of any kind. It can be drugs also. And they eventually give rise to a macrophage activation, expansion, cytokine release, and cytokine storm, causing high T cell activation, expansion, and IFN gamma production, which causes a vicious cycle acting back again on the macrophages. So this is the broad overview of how it happens. So this is one of the NLR C4 gene mutation is one of the factors which makes a subject susceptible to repeated macrophage activation syndrome. So this picture has those rashes which can be transient and it can cause changes in liver. So all those as well as the high ferritin, the low platelet, the drop in hemoglobin, high CRP are some of the features associated with this mutation causing recurrent. So these are some of the series of MAS in lupus, and you can see that they have reported variably with fever, hepatosplenomegaly. But one of the things is the WBC count drop is one of the consistent features in all the series. And here also, right on top, there's one series, and the subsequent ones in Kawasaki. So all the lupus series of macrophage activation syndrome has got drop in count is an important clue. So what is the difference between the macrophage activation syndrome of lupus as compared to Shogia? So what is the more important differentiating feature these people have reported is that the children with lupus, underlying lupus, when they have macrophage activation syndrome, they usually have much more severe organ involvement than Shogia. So mortality, there seem to be little lesser mortality in lupus-related macrophage activation syndrome as compared to systemic JIA. However, the mortality has been consistently dropping because people are identifying early and treating preemptively. So ferritin levels is a very important clue. All of you know the more than 10,000 is almost 90% sensitive and 96% specific for HLS in a series of 330 children of all causes, not just
And also primary HLS seem to have much higher ferritin in one series compared to macrophage activation syndrome in the setting of connective tissue disease. You can see here 15,000 versus 1,300. So how it is diagnosed? There was a diagnostic criteria for HLS in 2004, which had either a molecular diagnosis or 5 out of the 8 clinical features: fever, splenomegaly, cytopenia, hypertriglyceridemia, hemophagocytosis, high ferritin more than 500, lower absent NK cell activity, and also soluble IL-2 receptor alpha as a biomarker. But this was revised again in the setting of systemic JIA, and they have put ferritin more than 684 and any two of the following, which include low platelet, high AST, as well as triglycerides and fibrinogen. There was also a score called H score, which was used to, they have found a cutoff on the H score for people to be diagnosed as HLH. But the problem with the SLE is that the criteria of the SOGIA, when is applied for macrophage activation syndrome in SLE, it can be a problem because if you follow the SOGIA associated macrophage activation syndrome guidelines can be met by a significant number of juvenile SLE patients without macrophage activation syndrome. So it gives a lot of false positives in children especially. On the other hand, if you take the HLS 2004 guideline, which is highly specific, and it would pick up only 1/3 of juvenile SLE with macrophage activation syndrome, thereby it will give a lot of false negative. So this was the criteria which was worked out with the 5 clinical features and 6 lab features. And if somebody had 1 or more clinical plus 2 or more lab features, could be classified as a MS associated with juvenile SLE. Now, macrophage activation syndrome in SLE is a real challenge. And when this series had compared the pediatric SLE from adult SLE, what they have found is macrophage activation syndrome, the presentation, the initial presentation, at presentation, it was present in this series, about 85% of them had presented in pediatric at presentation, whereas in adults, only 30% of those who had MS had presented at presentation. And this may also be unrelated to disease activity. And SLE patients, it's not unusual to have normal complements, normal dsDNA, when in fact, you should suspect MS in lupus when the patient of SLE was in front of you, got disease activity control, fever settled, count settles, dsDNA, C3, everything settled. Suddenly, there's a rebound of fever in spite of disease activity control. And that is the time you should look for suspected and look for low ESR and other markers. So, however, this Chinese study has shown the SLE flare and infection were the most common triggers for macrophage activation syndrome. Often those infections mostly viral, we cannot detect them. And this is another series in which they have found that the thrombocytopenia and high CRP levels, when present, it actually indicates a bad prognosis and ICU admission. Steroids have been everywhere, the first line of therapy, and many places on the single agent. We use usually dexamethasone 10 milligram per meter square till the activity of MS is controlled. But also second line immunosuppressants like cyclosporin or tacrolimus and etoposide have been used. In some patients, steroids are contraindicated. We have people could afford IVIG, and rituximab has also been used, and rarely cyclophosphamide and mycophenolate also. So the clues are hectic fever, drop in counts in absence of any other features of disease activity, which was recently normal, drop in ESR, high ferritin, high triglycerides, and liver enzymes. Diagnostic, you have to diagnosis by criteria and the bone marrow biopsy, if you can get it, good. And steroids plus cyclosporin, usually that is the one we use, and very rarely etoposide, although the literature shows the etoposide is good for very aggressive MAS. And prognosis is bad if it is not detected early. Now, next, emergency catastrophic antiphospholipid syndrome. So this, in half the time, they are precipitated by infection or surgery or malignancy or pregnancy or a withdrawal of anticoagulation. And the clinical presentation usually multi-organ failure, usually kidneys, lung, adrenal, neurological, and cardiac. And you can see the clues can be dermatological manifestations, and ischemic features, and usually the treatment requires, this is the only antiphospholipid syndrome where you need immunosuppression with steroids or IVIG or rituximab. TTP, again, it's not a very common condition, and the classical pentad may not be always there. The pentad of thrombocytopenia, schistocytes, fever, transient neurological deficit, or kidney failure. It may not be always there. You may have, however, in presence of schistocytes, you should always suspect, and if not treated, it can be deadly. And here, plasma exchange is one of those therapies which is successful. Skin warnings can be like these. You can have in the middle picture shows the livedo picture. You can also get very acute cutaneous lupus features on the left side, and you can also get periangual erythema, nail fold vasculitis, showing suggestions of very severe lupus. Hematological manifestations, usually severe cytopenias. It may be mono, bi, or tricytopenia. Always rule out B12 and deficiency and macrophage activation syndrome. Hematological complications of lupus, usually one of the best to respond to steroids alone often, and they may sometimes recur cyclosporin or IVIG and rituximab also. Now, pulmonary complications. Although pulmonary features are less common in lupus, pulmonary complications of lupus are usually severe. Although commonest presentation is serositis, which is often asymptomatic, large effusions can be symptomatic and bring the patient to casualty. Diffuse pulmonary hemorrhage, sinking lung syndrome, pulmonary embolism, and lupus pneumonitis are others. I will just touch upon them. So this is a picture which shows on the left side, you can see cardiomegaly as well as right pleural effusion. On the right side, the CT scan, it shows also pleuro-pericardial effusion. Pulmonary hemorrhage is a very severe complication of lupus. Neutrophils usually infiltrate the intraalveolar and peribronchial septal vessels, which eventually lead to anatomical disruption of the capillaries, and it also leads to extravasation of the red blood cell into the alveoli and interstitium. Neutrophils also undergo apoptosis and fragmentation, releasing the proteolytic enzymes and reactive oxygen intermediates, causing inflammation and fibrinoid necrosis on the interstitium. So this picture, X-ray also shows, and the histopathology also shows the changes. So this is a better CT scan showing diffuse alveolar hemorrhage, and this is showing how the RBCs are extravasated and infiltration of the various inflammatory cells into the interstitium as well as alveoli. So the clue is usually drop in hemoglobin, altered blood from the airways, and images. And again, high dose steroids, rituximab, and sometimes plasma exchange is also used. Shrinking lung syndrome. This is one condition can be very easily missed out. I remember actively diagnosing myself 3 patients in my whole career, because I was directly, when at the junior level, when I used to see patient that is directly in emergency or acutely when I get a call from the ward. Patients will come complain of severe dyspnea of very sudden onset, and pleuritic chest pain. So very important differential diagnosis of pulmonary embolism. And if we forget the habit of percussing the lung, looking for the liver dullness, you will never find it, because this is one condition where the liver dullness appears much higher up, and when you see on the right side. And similarly, if you do suspect that, you should also see on the other side. So if you see the picture here, the X-ray shows the elevation of the hemidiaphragm, and the chest CT scan also shows, including cardiomegaly. And this picture is much better in showing the elevation of the hemidiaphragm, and you can see shrunk in the lung in the 3D reconstruction. Treatment is usually very high dose immunosuppression, very acute presentation, and rarely rituximab, but cyclophosphamide may be needed after the steroid pulse or IVIG or rituximab. Pulmonary embolism is again one of the major causes of emergencies in the ward of patients when admitted, and they cause ventilation perfusion mismatch and arterial desaturation, right heart failure, arrhythmias, all kinds of complications. And you have to suspect based on the symptoms of dyspnea, pleuritic chest pain in the right setting, and you have to start with heparin, and you have to establish the diagnosis. If needed, thrombolysis or even embolectomy sometimes have to be done. So in approach in a patient of SLE with PE is D-dimer. I'd like to say here one thing here. A positive D-dimer do not confirm pulmonary embolism, but a negative D-dimer actually can exclude pulmonary embolism. If D-dimer is elevated, you do a VQ scan. Now, in VQ scan, instead of doing ventilation perfusion scan in that order, you do the perfusion scan first. And if the perfusion scan shows there is a cutoff of perfusion, then you do the ventilation scan. In some conditions where CT angiography is contraindicated because of contrast-related renal complications in a lupus setting, you may have to do a VQ scan rather than CTPA. CTPA is, of course, more clear in diagnosing that. And then you should do antiphospholipid antibodies workup, and all minimum 3 antibodies as ACLA, LA, and beta-2-GP1, and then anticoagulation, maintaining high INR. Lupus pneumonitis is another serious complication. So this is one of the pictures. It can be easily diagnosed as a bacterial or a viral pneumonia. You can see in this picture, in the A, you can see that there is a pleural effusion as well as pneumonitis. Eventually, after a few days, in the B, you can see there's loculated pleural effusion. C, you see on treatment, there's some pleural thickening, but the consolidation has disappeared. And D, in CT scan, you see after a few days of immunosuppression, completely disappeared. So similarly, this is a picture of lupus pneumonitis. There's a few others. Treatment is again only high-dose immunosuppression with second-line agents. Renal, all the trainees know here, so various types of lupus nephritis. And these are the pictorial presentation of how from minimal change with podocyte injury, mesangial in class 2, in class 3, 4, diffuse nephritis, vascular changes of APS kidney or in tubulointerstitial damage, all that is there. But what is more important is right on top, what you have is that the crescentic glomerulonephritis, which is a very serious condition and emergency. These patients come with rapidly progressing glomerulonephritis and eventually very rapidly going for renal failure if not detected. So there will be high blood pressure and creatinine rising very fast. And RPGN, when it is suspected, you can see here these cartoons, the normal picture of the glomerular apparatus, and you can see in RPGN there is so much of narrowed capillary lumen, immune complexes, and there's a increased number of cells in the mesangium. There's more polymorphonuclear cells, fusion of food process. Every practical change is there, and this process happens very fast. And if these patients are not treated aggressively, you will be losing that patient or go for a chronic kidney disease. So basically, RPGN can happen in many settings, but lupus is one of the causes because of the circulating immune complexes or a type 2 immune-mediated mechanism. The GI malignancies, GI complications are other serious emergencies in lupus, mesenteric ischemia, GI vasculitis, as well as other causes of mesenteric ischemia. Lupus enteritis, the entity, and lupus pancreatitis are few of them you should remember. So mesenteric ischemia is usually can be because of thromboembolic process of antiphospholipid syndrome or because of vasculitis in patients of lupus. And they usually have angina, and usually after food they have fullness and pain. And how you should not miss these patients. You have to have a high degree of suspicion whenever these characteristic symptoms of abdominal angina, etc., are present, abdominal pain. Now, GI vasculitis, again, as I told you, the similar presentation, mesenteric ischemic symptoms are pain within 30 minutes after eating, bloody diarrhea, bowel perforation, hepatitis, pancreatitis, and cholecystitis are also intestinal vasculitis features. So these pictures you can see here, these are very characteristic pictures. Once you have seen, you will not forget. These are called the target lesions or double halo sign. These are very commonly seen in a lupus enteritis patients. So there are many other pictures here. So similarly, here also you can see quite a few. This arrow are marked here. You can see, and same is it can be an initial presentation also in patients with lupus for the first time. Immunosuppression again is the mainstay of therapy. Neuropsychiatric lupus almost always come with emergencies. PRES is not truly a neuropsychiatric lupus related, but it's associated complication. But PRES can also present. Transverse myelitis, meningoencephalitis, retinal occlusion hemorrhage, some of them you may come across. So this, all of you know, the ACR classification for CNS lupus is different. And CNS lupus is a different disease than rest of lupus. So you must remember that CNS lupus may not have high dsDNA. CNS lupus may not always have low C3, C4, and CNS lupus may not have a lot of other systemic features. So you can see from aseptic meningitis to CVA to extrapyramidal symptoms to confusional states, cognitive impairment, mood disorders, to peripheral nervous system disease, mononeuritis, peripheral neuropathy, demyelination, radiculopathy, everything possible. And they all can come to casualty. So primary neuropsychiatric lupus can have focal neuropsychiatric disease, which is often due to antiphospholipid antibodies. Whereas it can also be because of diffuse neuropsychiatric disease, which is usually various antibodies in the CNS like antineuronal, antiribosomal, antineurofilament, all kinds of antibodies they cause. Sometimes the focal conditions are also because of the secondary neuropsychiatric lupus features, and also complications of SLE like uremia, hypertension, steroid treatment, infection can also give rise to both focal and diffuse neuropsychiatric manifestations. This picture, if you see, you can see from A, B, C, D, E. If you can see that there are various type of hyperintensities in the brain, and see F, G, and H just after immunosuppression completely disappeared. So these patients can be easily misdiagnosed as so many things if it is seen as isolated. As I have told you, that the CNS lupus or neuropsychiatric lupus may not present with malar rash and mouth ulcers and other things. This is another picture. All kinds of changes there. There are infarctions, there is cerebral edema, there are hyperintensities, all kinds of features are here. So this again, lupus cerebritis, unless detected early and immunosuppressed, will give rise to fatal complications. So you can see here again, A, we got a cerebrovascular disease in A, and if you see A and B, both of them have got cerebrovascular disease features. You can get ischemic features, and you have you can see the C. You can see we have the sagittal sinus thrombosis picture, and you have transverse myelitis in this picture. So transverse myelitis, there are many causes, but always in a young patient, especially the female patient, you must think of transverse because lupus is a cause. We had many patients of lupus with transverse myelitis. Immunosuppression plus or minus anticoagulation. Remember, in CNS lupus, immunosuppression plus or minus anticoagulation is very important. One word of caution: when acute lupus comes for the first time to you, please do not start the hydroxychloroquine immediately, because hydroxychloroquine can lower the seizure threshold. So at least for a month or two, you control the disease activity with immunosuppression and other supportive therapy, and only then you start hydroxychloroquine. It has to be given. Hydroxychloroquine has got many benefits, including preventing relapse of CNS lupus. But if you start right in the beginning in a severely floridly active disease, you may end up getting more seizures, and seizures can kill also. Anticoagulation is very important because focal neurological deficit in APS is possibly one of the commonest causes. Autopsy studies of CNS lupus have shown that the large majority has actually having more of a vasculopathic process because of antiphospholipid syndrome rather than vasculitis. Now, PRES, all of you know, it's also called acute hypertensive encephalopathy or reversible posterior leukoencephalopathy. Is basically happens, it's a neurotoxic state when there is inability of the posterior circulation to auto-regulate in response to acute changes in blood pressure. And hyperperfusion with result in disruption of the blood-brain barrier results in vasogenic edema, usually without any infarction. So PRES will have three main imaging features. One is the hollow hemispheric at the watershed zones, or you can have superior frontal sulcus imaging changes, or you can also have parieto-occipital dominance in terms of presentation. Acute neurological symptoms, at least one or more out of seizure, encephalopathy, headache, and visual disturbance may be there. Risk factors or the setting is usually severe hypertension, blood pressure fluctuation, renal failure, immunosuppression therapy or chemotherapy, eclampsia, autoimmune disorders. And the brain imaging may show, I told you the three different patterns, but they also can cause bilateral vasogenic edema, cytotoxic edema with pattern of posterior reversible encephalopathy syndrome, which the radiologists are familiar with. Now, pregnancy-related complication, the last part of the talk. The eclampsia in pregnancy is one of the complications. And if you see the three pictures here, we have on the left side the non-pregnant picture. We have preeclampsia in the middle and the normal pregnancy on the right. What you can see here between preeclampsia and normal pregnancy here is that the extravascular trophoblasts as well as the NK cells are little less in preeclampsia compared to the normal pregnancy. So this is one of the things. Normally, the NK cells seem to be having a protective role against any endothelial or vascular injury. These are called uterine NK cells, and they have a protective role which is lost in SLE in pregnancy. Up to 30% can develop preeclampsia. The another problem is that patients who develop preeclampsia and SLE may also mimic like a lupus flare. So you have to look for features of leukopenia, look for low uric acid, etc., compared to preeclampsia, who usually have leukocytosis and high uric acid, and a few other features of lupus activity. Management of pregnancy in lupus, you should discourage pregnancy if the disease activity not under control, and if the creatinine is more than 2, and you have to have all the baseline parameters normal. You have to also be cautious about the complete heart block features because of SSA and SSB antibodies in SLE before planning pregnancy. The cardiovascular emergencies in lupus, predominantly pericarditis, myocarditis, tamponade, valvular disease, as well as coronary artery disease. So you can have all of it in lupus. And so conduction disturbances not only happens in the fetus because of SSA antibody, it also happens in the patients themselves. I have seen patients where the patient was affected and had gone into complete heart block with high titer SSA, SSB positivity. Endocarditis, Liebman-Sack endocarditis. Atherosclerosis, lupus, rheumatoid, all autoimmune diseases are independent risk factors for coronary artery disease. Myocarditis is another important risk factor, cause high mortality in acute lupus. And pericarditis, if there is a tamponade, they can also give rise to mortality. So the presentations of autoimmune heart complications are less. It's about 1% or less, but they can be severe. So it's important to think of those in the right setting. And if there is a features of right heart failure and pulmonary embolism has to be suspected. Also important red flag signs of myocarditis and SLE is that if there is a unexplained high titer troponin 1 as well as anti-pro-BNP, as well as you can do patients with a endomyocardial biopsy can differentiate, which is rare complication of long-term HCQ, can cause cardiomyopathy but it is not a routine procedure. Only expert cardiologists can do. And cardiac MR also can differentiate non-ischemic patterns from ischemic patterns. Antiphospholipid antibodies can give rise to coronary artery disease, valvular disease, myocardial dysfunction, pulmonary hypertension, as I have mentioned. Pericardial disease in SLE is very mild usually, and it is part of both the criterias. The pericarditis is present in about up to 50% of patients, but half of them are asymptomatic. The risk factor for severe pericarditis are presence of hemolytic anemia, proteinuria, lymphadenopathy, anti-Smith antibody. There are also associations of reports of association of lupus nephritis, ILD, PAH, leukopenia, thrombocytopenia, low complements with cirrhosis or pericarditis. Pericarditis has also been reported with low vitamin D state. Anti-Smith antibody, anti-Jo1, double-stranded DNA, RNP, all have been reported. In pediatric SLE, anti-chromatin, anti-ribosomalpin, anti-La has also been found to be associated with pericarditis. Now, cardiac tamponade is found to be associated more often with low C4 complements. And it's very important to identify the size of the pericardial effusion by echocardiogram rather than doing any other invasive procedures like cardiac cath. The treatment is usually for, if it is a monocirrhosis, mild NSAIDs are enough. If it is a polycirrhosis going towards severe moderate, you need immunosuppression. But one important word of caution to all the younger people who are in training or just finished their training, never try to tap a pericardial tamponade by yourself. Pericardial tamponade should be always tapped by the cardiologist in the intensive care setting. In Dubois lupus, if you see, there was a series of 25 patients and 5 patients died. And this is a very high mortality. And this was, an autopsy showed that all of them had laceration of the myocardium. Because in lupus pericarditis, there is also associated myocarditis, underlying myocarditis. So when someone does a blind tapping, you can unknowingly injure the myocardium and lacerate the myocardium. This is very important. So there are also reports of other drugs, colchicine, IVIG, methotrexate, anakinra. So take-home message is always rule out infection versus disease activity in lupus emergencies. Infection is still one of the important killers of lupus. Judicious immunosuppression, as you know that slowly we are going away from steroids and cyclophosphamide. Steroid is being replaced with tocilizumab, with rituximab, now with avacopan. Mycophenolate has replaced largely cyclophosphamide. So immunosuppression can kill, so you have to be cautious. Anticoagulation in APS, as you know, you have to maintain a high INR between 3 and 3.5. And this is like a two-edged sword, and the patient has to be educated. Critical care in appropriate scenario is indicated, as I have shown the various clinical scenarios. Now, lupus is a very interesting disease. This is a very interesting disease for not only for rheumatologists, but for internists. 100 years back, people used to say, if you know syphilis, you know medicine. Then came diabetes. If you know diabetes, then you know medicine. More recent time, people said, if you know HIV, you know medicine. But at all time, if you know lupus, you know medicine. Lupus is a disease, can affect every system in the body, from mild to moderate to severe to critical. So lupus is a disease, has to be learned by heart. This is Golden Temple in Vellore. And this is 2,500 kilogram gold laid over a stone structure. The gold is from Reserve Bank of India. So apart from CMC, Vellore has another wonder there. This is the world's biggest golden temple. Thank you very much.
Thank you so much, sir, for the excellent and elaborate talk on lupus. Definitely agree with you that if you know lupus, you really know medicine. And not only it has an impact on physical, but the emergencies and the mental is also, we cannot comprehend for each patient. Before we break for lunch, we would like to invite one question or maximum two, because it's a very important topic. Then we can break for lunch. Any questions? I'm sure there is one or two. Otherwise, if there are none, maybe you could talk to sir in the lunch break. So we'll close the session for now. Thank you very much.
Thank you. Thank you, Chairperson. Thank you, audience. Thank you, Lupus Initiative Kolkata, Professor Ghosh and his team for this wonderful meeting and inviting me for this. I'm very glad that this movement is taken momentum, and it is very useful to the patients. Many patients are coming back to us and telling all the good thing you are doing for the patients here. Thank you very much.
I would like to request everyone to join back at 2:30 for the afternoon session.
Hello, Professor Dr. Anisul Rahman, sir.
Yes, hello, I can see you. I can hear you, I mean.
Can you, sir, we are testing mode, so can you start your presentation, sir?
Which one? I've got two.
Yeah.
Hi, Anna, sir.
Oh, hi, David. You want me to start my presentation? Okay. Hang on.
Can you, sir, start your presentation, sir? Just have a test.
I'll do that.
Sir is doing it. Just wait for 3 minutes.
I'm just going to on my laptop. Hang on.
Yeah.
Okay, can you see that?
Yes, sir. Yeah, we can see, sir. Can you just change the slide, sir?
Yeah. Hang on. Hang on, sorry. Is that working?
Yes, sir. Perfect.
I'm changing slides.
Yes.
Yes, sir. Perfectly okay.
Perfect.
Right. I'll stop sharing, shall I?
Yeah.
Okay, on the program, when will I be doing this? Is it at 2 p.m., 2:30 p.m.? When is it?
Yeah, sir, 2:30 p.m.
2:30 p.m. So in an hour's time, roughly.
Now is 1:54 here. So.
Okay, that's fine.
Thank you, sir.
So sir,
Do you want to test your other presentation, Anna, sir?
Yes, sir.
The other one?
I'd like to request Professor David D'Cruz, sir. Can you just start your
I think Anna, sir, wanted just to check his other presentation. He's got two talks.
Right. Sir, having two talks. Sir, can you just check the second presentation?
All right, that's fine. I'll do the other one. Hang on.
Did you do a recorded version, Anna, sir?
No.
Nor did I. There's no time to do these
I
things.
just sent them it,
Yes,
and I didn't see
same here.
how I could either. They didn't send
Yeah.
a way to do that. So.
They didn't send instructions, that's right. Yeah.
So, all right, let me share the screen again. This one. Can you see this now?
Yes, sir. Yeah, perfect, sir.
Looking good.
Perfect.
All right. Great.
Perfectly okay.
Right.
Yeah. Great, sir. Thank you.
Terrific. Okay. So I'll get my talk up. Let me just open the slide. All right. Where was I? Okay. Can you see the slides? Hello. Can you see the slides?
Yes, sir. Yes, sir. Yes, sir.
You can see the
Can you
slides.
make it the
All
full screen?
right. Let
Yes.
me make it onto full screen.
Yeah.
Okay.
Yes. Now you are getting the full screen slide. Yeah, it is
Okay.
changing.
It is
Perfect.
changing.
Perfect, sir. Perfect.
Fantastic. That all looks good then. Okay. And you can hear me clearly?
Yes, sir. Absolutely clear.
Yeah.
Yes,
Very good.
absolutely perfect.
Excellent. Okay. Well, that sounds good. All right. So I'll stop sharing then. Yeah. Very good. So like Anna said, I just wanted to check my time because it's here 8:30 in the morning. And according to the program, I'm on at 5:15. Is that right?
Yes, sir. 5:15 at Indian time.
Indian time. So
Now it's 1:57 as per Indian time.
It's 1:57 at the moment. Okay, fine. I'll work out the time difference. Okay, that's fine. Good. All right. Any other questions or problems? You got my mobile number just in case there's trouble, and you've got a set of my slides as well, just in case there's trouble.
Sure, sir. So,
Excellent. Good. Okay, that's fine.
Thank you, sir.
So you have lunch. I'll have some breakfast. Okay. Thanks very much. Then I'll log in a bit later. Then. Yeah.
Right, sir.
Thank you.
Thank you, sir. Thanks.
Great.
I, on behalf of Indian on behalf of Indian Rheumatology Association, welcome you all to our ensuing National Congress to be held at Hyderabad in December 2021, precisely from 9th to 12th December. We have the vision to enlighten the inner strength in rheumatology in the country to progress forward in this COVID environment in new normal era. And our mission is to empower the patients along with the primary caregiver, with the primary physicians in reference to the rheumatology, what is being practiced in Indian scenario. And this National Congress will be having both the basic research part as well as the clinical research part contributed from the young budding scientists involved in the clinical part along with the scientific contribution which is being done at the laboratory itself. And it will also involve the best orations and the best deliveries from the national and the international luminaries. And we'd be having different small interest group like vasculitis, like spondyloarthritis, like rheumatoid, scleroderma. And we would be having debates involving the young rheumatologists to contribute what is happening in the country and abroad. We will be having the best sessions in rheumatology, which is being practiced. So I invite you to enjoy this scientific extravaganza after a long waitage for the last 1 year, which we could not help because of obvious reasons. So again, I invite you to participate one and all actively to contribute, to extract, to encourage, to update knowledge in rheumatology, what is being practiced in our country, and to share the updates with the people who are the best person, best knowledge producer and knowledge givers in the country and abroad. Thank you all.
আর এখন ইয়েগুলো দিয়ে দিচ্ছি, স্লাইডগুলোকে। হ্যাঁ, স্পন্সরটা দিয়ে দিই। করে রেখে দিয়েছি আমি সব একসঙ্গে করে একটা ইউএসবি রম লাগানো থাকবে ও তাহলে ওইটাতে লাগিয়েছে, ওটাতে লাগিয়েছে। নেক্সট স্লাইড, আর এটা প্রেস করে রাখলে এটাকে চেঞ্জ করা যায়, কালার চেঞ্জ করা যায়, তারপরে করে একটা হাইলাইট করে মনে হয় দেখেছিলিস তারপর লেন্সের মতো করে যায়। চল
I, on behalf of Indian Rheumatology Association, welcome you all to our ensuing National Congress to be held at Hyderabad in December 2021, precisely from 9th to 12th December. We have the vision to enlighten the inner strength in rheumatology in the country to progress forward in this COVID environment in new normal era. And our mission is to empower the patients along with the primary caregiver, with the primary physicians in reference to the rheumatology, what is being practiced in Indian scenario. And this National Congress will be having both the basic research part as well as the clinical research part contributed from the young budding scientists involving the clinical part along with the scientific contribution which is being done at the laboratory itself. And it will also involve the best orations and the best deliveries from the national and the international luminaries, and we'll be having different small interest group like vasculitis, like spondyloarthritis, like rheumatoid, scleroderma, and we will be having debates involving the young rheumatologists to contribute what is happening in the country and abroad. We will be having the best sessions in rheumatology which is being practiced. So I invite you to enjoy this scientific extravaganza after a long waitage for the last 1 year, which we could not hold because of obvious reasons. So again, I invite you to participate one and all actively to contribute to extract, to encourage, to update knowledge in rheumatology, what is being practiced in our country, and to share the updates with the people who are the best person, best knowledge producer and knowledge givers in the country and abroad. Thank you all.
Good afternoon, everyone, and good morning to our dignitaries from the UK. We shall commence our post-lunch session. The first talk will be given by Dr. Anisur Rahman on difficult APS, and this talk will be moderated by Dr. Sharboni Shengupto, Dr. Namisha Patel, and Dr. Partho Karmakar. I would request them to come on the dais, please.
Good afternoon, everyone. I think we should start the post-lunch session. We are already 5 minutes late. It gives me great pleasure to introduce Professor Anisur Rahman. He is Professor of Rheumatology and a consultant rheumatologist at University College London. He is the lead teacher for rheumatology and has won many prizes for the same. He is a member of the national and international lupus research groups, a life member of both British Isles Lupus Assessment Group and the Systemic Lupus International Collaborative Clinics. His major clinical interests are SLE, antiphospholipid syndrome, and chronic musculoskeletal diseases, pain. I invite Professor Rahman to start his talk.
Hello, everyone from London. Thank you for that nice introduction. Can I just check that you can hear me all right? You can, good. All right, I'm going to share my screen and I'm going to start the presentation. If there's any problem, if somebody can shout out to me so that I know, otherwise I might not know. I'm just going to start my presentation now. So the subject, I've been asked to give 2 talks, and this is the first talk. It's called Difficult Antiphospholipid Syndrome. And this is my disclosure statement. I've spoken at a meeting, and I'm a co-inventor of an agent based on domain 1 designed for the treatment of APS. So to start with, what is the antiphospholipid syndrome? And actually, you'll see the same slide in my later talk, because I don't know if some people might be watching recordings of these later. So antiphospholipid syndrome is the commonest acquired cause of thrombophilia, that is recurrent risk of thrombosis. And it causes 10 to 20% of recurrent miscarriages, or at least it did until treatment became available. Now, very importantly, it can cause strokes in under 50s. In fact, it's estimated to cause up to 1/3 of strokes in under 50s. So if you see somebody who's very young with a stroke, always think of this syndrome. APS can be primary or secondary. Primary APS means that it's APS with no other disease, just APS by itself. Secondary means that they had another disease first, most typically lupus. We believe that APS is actually caused by antiphospholipid antibodies in the bloodstream that bind to phospholipid protein complexes and actually cause the clinical effects. But remember that up to 5% of healthy adults test positive for these antibodies anyway. These are, if you like, false positive tests. The people are testing positive, but they don't have any disease because of it. And although APS is defined in terms of thrombosis and pregnancy loss, patients can have other manifestations such as livedo reticularis, rash on the thighs, and cardiac valve lesions. So 3 important things about what I'm going to say. The treatment of APS is essentially preventive. That is to say, we're trying to prevent things, not treat the symptoms. Lots of times, people with APS are essentially asymptomatic. They don't have any symptoms. They may have some joint pain, for example. Sometimes people have symptoms like rash. But often what we're saying to people is take drugs, such as anticoagulation long-term, even though you feel well, because otherwise you have a risk of a thrombosis. So if you're going to ask somebody to take a drug with long-term side effects, and you're doing it to prevent something, you have to balance the risk of what you're trying to prevent against the risk of side effects. So here are the classification criteria for APS, which date from 2006. These are the latest criteria. They are actually being updated at the moment. But what these classification criteria say are that you can diagnose this condition in a patient who has clinical features, that is to say either arterial thrombosis, venous thrombosis, or pregnancy loss, with laboratory features. So the person has to have 1 clinical feature at least and 1 laboratory feature at least. Now, these laboratory features that I've shown in red are sometimes called the criteria assays, because the criteria for APS only mentioned 3 types of test: the anticardiolipin ELISA, the anti-beta-2 glycoprotein 1 ELISA, and the lupus anticoagulant test. And these must be consistently positive, that is at least 2 occasions 12 weeks apart. And that rule is there because some people, especially with infections, have transient positive antiphospholipid antibodies. So remember, to diagnose this, they must be positive for the antibody, they must have a clinical feature of disease. And what do I mean when I say a positive test? Now, this is very important as well. I don't know how your laboratories report it. Different laboratories report it differently around the world, but some laboratories will say it's positive if it's just above the upper limit of normal. According to the criteria, those low positive tests are not really positive. For the criteria, you have to have a strongly positive test. That is to say, anticardiolipin of above 40, anti-beta-2 glycoprotein 1 above the 99th percentile for normals in your lab, and lupus anticoagulant can be either positive or negative. And a very important thing for you to remember is you've got 3 tests here. Not everybody is positive in all the tests. A patient can be single positive, just 1 test, double positive, 2 tests, or even triple positive, all 3 tests. And these people who are triple positive have a high risk of thrombosis. It's a high risk group. So I've been asked to talk about difficult APS, and I'm going to concentrate on the thrombotic APS picture. But before talking about difficult APS, well, what is easy APS and what is standard APS, which is not difficult? Well, easy APS, and you see I put it in speech marks because it's not really that easy. Well, firstly, there's no doubt about the diagnosis. The patient fulfills the serological APS criteria. They're positive for at least one of those tests persistently. Secondly, the patient has at least 1 confirmed thrombosis. So they definitely are an APS patient. So in easy thrombotic APS, the evidence says anticoagulate, preferably with a vitamin K antagonist. That's the first line, and continue it. So don't stop it. Continue it long term. And if you're lucky, if it all works fine, then they won't have any further thrombosis. So you have a patient on a preventive agent who nothing else happens to them. That's easy APS. That's APS the way we would all like to see it. But even easy APS isn't really easy, unfortunately. One thing which is well known is that it's very difficult to control the INR in patients with APS. The INR can be very variable, can go up and down unpredictably. There can be difficulties with compliance. Are the people taking the medication? If somebody misses their warfarin, for example, for several days, their INR might go down and they might have a risk of clotting. On the other hand, because the INR is difficult to control, if you're aiming for an INR between 3 and 4, it might be that some days the INR is 6 or 7, and they might have a risk of bleeding. And furthermore, these drugs, these vitamin K antagonists, can interact with other drugs. So although I painted a picture of somebody who just takes warfarin every day, has the INR measured, and doesn't clot, actually many people have much more difficulty than that with vitamin K antagonists. So why did I say that anticoagulation was the way? Because all the evidence so far suggests that. So I went back through the literature. The two biggest systematic reviews were both published about 15 years ago by Lim, who published only RCTs, and Ruiz Irastorza, who is in Spain, and he looked at both RCTs and observational cohort studies. So what both of these authors were doing was looking at all the literature, saying what you should do for patients with APS, and they agreed. They agreed that there isn't any evidence-based treatment except for anticoagulation to prevent another thrombosis. They agreed that there's no particular time period which you can say that's enough, we don't have to stop it. Although in my later talk, which is coming in a couple of hours, I'll talk a little bit about whether you can ever stop in anybody. And they agreed that there should be a higher INR for arterial thrombosis. So quite often, for venous thrombosis, the INR is kept between 2 and 3. For arterial, it may be a bit higher. Now, these are quite old papers, and in preparation for this talk and some other talks I've been doing on Zoom recently, I thought, well, really, I should see if anybody's reviewed it since then. So I found the latest reference I can, and this is the one here, Sayer and colleagues, in 2021. And interestingly, they didn't cite any systematic review after these two. So nobody seems to have reviewed this literature really very much after that. And what Sayer and colleagues said was pretty much the same, but they also included the direct oral anticoagulants. So my first difficult APS scenario is going to be about that. So these are the 4 difficult APS scenarios I'm going to talk about. Firstly, you've got a patient on a vitamin K antagonist, you want to change them to a direct oral anticoagulant. Can you do that? That's a difficult decision. Secondly, refractory thrombosis. You're treating somebody with anticoagulation, but still they keep having clots. Thirdly, the catastrophic APS. This is a rare condition, less than 1% of people with APS, but it causes widespread thrombosis and is life-threatening. And fourthly, slightly differently, not exactly APS, but an APL positive patient, haven't had a thrombosis yet, but you have to decide whether to give them any treatment or not. Should they have treatment to prevent a first thrombosis? So these are my difficult APS scenarios. So here's the first one. The direct oral anticoagulants, I'm talking about things like rivaroxaban, apixaban, dabigatran. These are not agents which block all the vitamin K clotting factors. They block specific clotting factors. So for example, rivaroxaban acts against factor 10A. So they're very specific for individual clotting factors. So why would we want to make this change? Because the world is doing this. We in the APS world maybe have been behind the times for the rest of the world, because many other people, for example, on who have atrial fibrillation or other things which put them at risk of clots, are being changed from vitamin K antagonists to these direct oral anticoagulants. And why is that? Because their effects are much more predictable. So there's an end to all this INR monitoring. Somebody on rivaroxaban does not have to have regular INR tests. And you can see that that would be a great benefit to the patient. There are fewer problems with drug interactions. You're less likely to have kind of the anticoagulation varying widely from day to day. And it has been used successfully in other prothrombotic conditions. So this sounds good. You know, if I were a patient, it would sound good to me to be on this drug. But why might it be a problem in APS? Why can't we just assume that if it works for atrial fibrillation, it will work for APS too? Why can't we assume it? Well, remember how they work. They target a single clotting factor. And some patients with APS have antibodies to those clotting factors. So for example, factor 10 antibodies have been described in APS. So if you've got a patient with anti-factor 10 antibodies, will a DOAC that targets factor 10 work, or will the antibodies cause a problem? And secondly, there's no good agent to reverse it. So if you have a patient on warfarin and they come into hospital with bleeding, then you can give them vitamin K. But for these, there isn't a good agent to reverse them. So you might have a problem if somebody on these drugs was bleeding. So those are some possible drawbacks. And the large randomized controlled trials in these other conditions, things like atrial fibrillation, typically didn't include patients with APS. So we actually don't know whether these drugs would work in antiphospholipid syndrome. We don't know for sure. So what do we do in medicine when we don't know for sure? We're going to do a clinical trial. So what clinical trials have been done? And the point is that the evidence is rather inconclusive. There have been 2 trials reported, and they gave different outcomes. So the RAPS study at the top was done in the United Kingdom at UCL and King's College. And that trial compared rivaroxaban to warfarin. Now, what you have to know about this trial is who got into the trial. Only patients with a venous thrombosis were included. No patients with arterial thrombosis were included. They were already on warfarin, and half of them were changed to rivaroxaban. The other half were kept on warfarin, so 55 in each group. And they weren't looking at clotting as an outcome measure. So the outcome measure was a laboratory outcome measure. It took the blood of the patients and they checked to see if it clotted the same in the rivaroxaban group and the warfarin group. Now, what they found was in that laboratory measure, rivaroxaban was non-inferior. So a non-inferiority study is a bit unusual. In most clinical trials we hear about, we want to know that the treatment group does better than the placebo group. In these studies, we're not trying to prove that rivaroxaban is better, just that it's not worse. Because if it's not worse, all those other benefits that I talked to you about, like not having to do regular INRs, mean that it would be preferable for patients. So remember, they're only trying to prove it's non-inferior. And in this study, it was non-inferior, but it was a laboratory outcome measure. And we can't say very much about clotting because nobody had a clot. In the whole 110 patients, nobody had a thrombosis in this study. So the RAP study says, yes, you can probably use it in people with venous thrombosis. But the TRAP study, which was done in Italy, said something very different. Now, a TRAP study included very different patients. So these were high-risk patients. You remember in an earlier slide, I told you that patients who were triple positive, had triple positive antibodies, were a very high-risk group. So in the TRAP study, they chose to include only these high-risk patients, which they didn't in the RAP study. And they included both arterial and venous cases. And in this study, they had a very bad outcome. So if you look, that there were 59 patients on rivaroxaban, 61 patients on warfarin, and the rivaroxaban patients did much worse. 11 out of 59 had bad outcomes, not just thrombosis, but also heart attacks and major bleeds. And only 2 out of 61 of the warfarin patients had those bad outcomes. But it was a very short follow-up period because the TRAP study was stopped on safety grounds. The safety committee said, look, you can't carry on with this. Clearly, the rivaroxaban is worse. You've got to stop the study. So if you have to stop a study, then that looks pretty bad for the rivaroxaban group. So after TRAPS, rivaroxaban became much less popular, if you like, and the European Medicines Agency and the MHRA in the United Kingdom are not currently recommending it for APS. But some people say that is excessively cautious because suppose you just use it in the low-risk venous patients, the people who were in the RAP study, maybe it's going to be okay in those people. Maybe the TRAP study gave this result because they just used high-risk patients. So there's a question there. Might it be okay in some patients? So now there's been a third study published, and this study was from Spain, from 6 hospitals. And this study had some advantages over the other 2 studies. It has a 3-year follow-up, which is longer than the other 2 studies. It has a clinical endpoint, that is to say number of clots, not like the RAP study. And it has a bigger number. So we've got 95 rivaroxaban versus 95 continuing vitamin K antagonists. And you can see that they have some high-risk patients, those triple positives, but not all of them were high risk. And they have some arterial thrombosis, but not all of them. So this study covers a lot of different groups with a long follow-up. So this is a good study. And what does this study tell us? So look at the table. If you look at the table, essentially, the rivaroxaban group may be doing slightly worse. If you look at the top line of the table, recurrent thrombosis is higher in the rivaroxaban group, bleeding isn't different in the two groups. But remember, one of the advantages of rivaroxaban was supposed to be that it was more predictable and give less bleeding. But look at the bottom line of the table. 9 strokes in the rivaroxaban group, no strokes in the vitamin K group. The authors don't conclude that rivaroxaban is worse, but what they conclude is they can't be sure it's non-inferior. It may be inferior. So at the moment, the evidence suggests that we can't change all our patients with APS to DOACs. It may be possible to change some patients who have had only venous thrombosis and low risk. At the moment here in the UK, the official advice is not to change anybody to rivaroxaban, but if somebody already is on it, then they can continue on it if they had only venous thrombosis and they're low risk, as long as you talk to the patients about it. But very few people are being changed to rivaroxaban at the moment. So this is the conclusion then of that part of the talk. At present, the European and British medical agencies have eyed against it. I think that might be too extreme, definitely not for triple positive, not for arterial thrombosis, but maybe in venous thrombosis with single positive. Now, my next difficult APS scenario is refractory APS. And many of you may have patients like this. The patient is getting vitamin K antagonist, but they're still having thrombosis. So the first really important thing is to check that they are actually being anticoagulated. Is their INR actually in the therapeutic range? Why might it not be? They might not be taking their tablets. They might be taking a drug which interferes with their tablets. So make sure that the INR was actually within the therapeutic range when they had a clot. And if it's not, what you might have to do is check it more frequently. But assuming that they were being properly anticoagulated and they still were having clots, what can you do? So that review by Sayer I told you about gives you these options. Increasing the warfarin, or the anti-vitamin K antagonist, to a higher target range INR, changing to heparin, adding an antiplatelet agent such as aspirin to the warfarin, or changing to fondaparinux, which is a different form. It's a bit like heparin, but different. So you can do these things if you can't control thrombosis in people who are already anticoagulated. The third scenario is catastrophic APS. Now, as I mentioned, it's 1% of people with APS. How do you know a patient has catastrophic antiphospholipid syndrome? This is a person who 3 or more organs and or systems are involved at the same time. They have the systems being involved very quickly. Over a short period of time, lots of things happen. So, for example, they might have infarcts in various fingers, maybe in the kidney, they might have a pulmonary embolus, lots of things happening at the same time. This is very, very dangerous. Now, strictly speaking, you should be confirming by histology that there is small vessel occlusion. That may not always be possible. It's a fast-moving thing. Usually the case is a patient has positive antiphospholipid antibodies and suddenly is getting multiple clots in different areas, which you might be seeing by imaging. It's got a very high mortality. It's so rare that you can't do clinical trials in it really, but Ricard Severa in Barcelona has produced a registry of cases, which is the best source of information about this syndrome. And if you look at this registry, the mortality is 37%. Essentially, if you have a patient with CAPS and you treat the patient and they're alive at the end of your treatment, that's a good outcome. That's how dangerous CAPS is. So what is done with CAPS? If you go to the papers from that registry, they will tell you that the best form of treatment will involve one or more of these things, and often many of them. Certainly they have to be anticoagulated with therapeutic doses of heparin. Most APS does not need steroids. Steroids doesn't help APS in general, but intravenous steroids is often used in CAPS. Rituximab can be used because it depletes the B cells making the antiphospholipid antibodies, and either plasma exchange or intravenous immunoglobulins, whichever is more available to you where you are, can be used. You can see this is very expensive interventionist treatment, but it's life-saving in some people. We at UCLH often use plasma exchange. And some people have argued that if, say, you have a leg which is thrombotic, and the tissue is dead, it's going black, that itself is a source of clots which are flying off into the rest of the system, and you should amputate it in order to stop the caps. But of course, that might be difficult because it might not heal properly. It's a really, really difficult situation. And right at the bottom, I've put eculizumab because complement seems to be involved. And eculizumab, which is an anti-C5a monoclonal, has been used in a few patients. We have a very complicated patient in our hospital who has had catastrophic antiphospholipid syndrome and also thrombocytopenias. It's really hard to anticoagulate somebody who's got bleeding risk and clotting risk. And that particular patient had done well on this eculizumab, but I haven't seen it in other people. So my last difficult scenario is, if you like, at the other end of the spectrum. I've just talked about the most lethal possible antiphospholipid syndrome, the CAPS. Now I'm talking about the most benign possible condition. This is people who actually nothing seems to be wrong with them. They have APL in their blood, but they're not having any thrombosis, and they've never had one. Now, this is a difficult situation because we can't just put all those people on anticoagulation because they might never get a clot. We know that approximately 5% of the healthy population have APL, but only 0.05% have APS. So if we just gave them all anticoagulation, we would be treating 99% of them inappropriately. That would be a bad thing to do. So what about just people with SLE then? About 25% of patients with SLE have APL at one point or another, but only 7 to 15% have APS. Again, we can't just give them all anticoagulation because we'd be over-treating at least half of them. So what are we going to do? How are we going to decide who to treat? How do we manage a patient with persistently positive APL who hasn't had a thrombosis, but they might be going to get one? Would we give them warfarin? Would we give them aspirin? Can we stratify the risk in some way? So risk stratification is really, really important. You have to work out how high the risk is. How are you going to do that? You have to ask a hematologist to collaborate with you because the hematologists do other tests that we rheumatologists don't do, like factor V Leiden, activated protein C resistance, and so on. So if they find that there are other risk factors as well as the antiphospholipids, that might make you more keen to anticoagulate. Now remember to do the really simple things. So somebody who's got APL, you can talk to them about smoking. Don't smoke, obviously. Don't use the combined oral contraceptive. And flying, there might be things they can do. For example, wear stockings on a long flight and so on. Not that anybody has any long flights at the moment, but at one point in the future, we might do that again. In terms of the antiphospholipid antibodies themselves, look out for the high titer antiphospholipid antibodies, people have very high levels, and the double or triple positive patients. So if you look at all the things on this slide, let's say you've got a person who's a heavy smoker, who has factor V Leiden, high titer APL, and double or triple positivity. If they have all of those things, you might consider anticoagulation. But if they don't, there is some evidence just to use aspirin. So how good is that evidence? I'll tell you in a minute. I said that strongly positive tests matter, and this is because multiple studies have shown that high titers are associated with increased thrombosis. And by the way, be aware of reading papers which talk about APL positive patients, but when you look at the methods, they're including very weak positive results. So weak positive is not really APS. The APAS paper is an example of that. And it matters which tests are positive. IgG is worse than IgM, and double or triple positivity is worse than single positivity. Pengo and colleagues showed that in triple positive patients, even being treated in a specialist center, 44% of them had recurrent thrombosis. That's evidence that triple positive is worse. So what about aspirin then? There's only been one randomized controlled trial where they divided APL positive people into aspirin versus placebo, and that didn't show any benefit. It didn't show that the aspirin stopped clots. But Laurent Arnault, who's a speaker actually in this conference, I'm looking forward to hearing his talk a bit later, Laurent did a meta-analysis of cohort studies where they'd followed people who were given aspirin, and he said that in 11 studies that he reviewed, there might be a benefit of low-dose aspirin. But then he did a further study where he went into detail in 5 of those studies and found the patient level data. So he went to the authors of the studies and said, can you tell me about whether they're a smoker or not and all the other risk factors so I can allow for that statistically. And that very, very careful study which he did and published in 2015 suggested that low dose aspirin halved the risk of thrombosis in APL positive patients. So this is evidence that aspirin works. And I asked Laurent about this myself, and he might be able to comment later if he talks. And what he said was, in the high risk group, the triple positive group, he would recommend aspirin for those people. And really the EULAR recommendations, the recent European League Against Rheumatism recommendations suggest that too. So people who are APL positive, if they have lots and lots of risk factors, as well as APL, you could anticoagulate them. But if they only have APL, if they're in a high risk profile group, you could give them low dose aspirin, and there's some evidence to support you. The EULAR guidelines say in this group, there's no evidence of anticoagulation, but low dose aspirin in the high risk profile groups. Thank you.
Thank you, Professor Raman, for your excellent presentation and you're making a very difficult topic, a less difficult one for the audiences. Any questions from the audience and discussion? Yes, Dr. Pandya.
Thank you, sir. This is Sapan Pandya from Ahmedabad, India. I had 2 questions. One was regarding, do you expect a surge in APLA after COVID because of the association of APLA antibodies with COVID, number 1. And the second question was the role of evocapan in APLA, since it is also a C5a receptor antagonist.
So I don't have any information on that second drug you've mentioned, unfortunately. I've never used it, so I just don't know anything about it. As for COVID, it's been quite a complex story with COVID. As you know, COVID has been associated with clotting and people getting pulmonary emboli and so on. There was a paper from Jason Knight in the United States, and I discussed this with him, showing that after COVID, they had taken blood from the patients and had found some antiphospholipid antibodies. And those antiphospholipid antibodies, when they tested them in various models, seemed to show similar properties to antiphospholipid antibodies from the antiphospholipid syndrome. But if you read his paper, very few of the patients actually had thrombosis. So it is true that people with COVID can get APL, and that's true of other infections as well. There are other infections which can cause APL to develop, but it doesn't seem at the moment that many people post-COVID have antiphospholipid syndrome. I recently volunteered to work in the long COVID clinic of my hospital, and as a standard in that clinic, they're testing things like von Willebrand factor activity to see if the patients do have a prolonged tendency to clot, but they're not routinely testing antiphospholipid antibodies. So I think my answer to that is, obviously it's early days. There probably are some people who develop antiphospholipid antibodies after COVID, but we're not seeing a signal that it's causing a surge in the actual syndrome.
Any other questions from the floor? Yes, Dr. Ghosh.
I am Dr. Bhaskar Ghosh from Kolkata. I want to ask you one thing, is that we had a patient who is having aplacoria, presenting as acute onset chorea, and the patient had APLA positive, but MRI was normal, and this PET scan showed there are some abnormality in the caudate nucleus. So we concluded that it is probably due to antibody mediated chorea rather than any vascular lesion. So in this case, what would you recommend? You would recommend anticoagulation and aspirin, or only aspirin, or only steroid? What is your recommendation?
So that's a very difficult situation. I've never seen that before. So what you have is a patient with chorea and an abnormality on the brain scan and antiphospholipid antibodies. And do they have the high risk profile, triple positive high levels?
Yeah, the antibody level was high, IgM and IgG.
And do they have?
That I don't remember at this moment, but it was positive in 2 occasions as per diagnostic criteria.
And do they have lupus as well or not?
Sorry?
Lupus.
Do they have lupus as well as antiphospholipid?
Yeah.
Okay, so I would say that lupus is a more likely cause of antiphospholipid antibodies for that syndrome, because usually antiphospholipid antibodies cause an event which is over. So in other words, they cause a stroke, it causes damage, but it doesn't cause ongoing symptoms of chorea. This is kind of a difficult thing to imagine. The anticoagulation will stop new things happening, but whether it will stop something that has already happened is another matter. So in that particular case that you've mentioned, I would treat it as if the lupus is causing it rather than the antiphospholipids. Some people would use anticoagulation as a trial, on a trial basis. But of course, if your patient has very profound chorea, then they may fall. And then if they're on anticoagulation, they might bleed from the fall. So it's difficult because it's an unusual case. My gut feeling is that the antiphospholipid antibodies are less likely to be causing it than lupus is.
One more question. Are there any criteria to select between vitamin K antagonists and the newer anticoagulants which do not require monitoring? What would you use in a patient?
So we're using very little of the DOACs now because the data I showed you, the evidence is against them. The evidence doesn't suggest that it will be a good idea to change to those. The studies I showed you show that there may be more events in that group. Now, there is an argument that in a selected group of patients with venous thrombosis only and a low-risk antibody profile, just one antibody positive, and only venous thrombosis, it could be okay to change to DOACs. At the moment, nobody is arguing to change people who've had arterial thrombosis. Nobody is arguing to change people who have a high risk profile. So it's only a minority of people who it would even be considered for. What we are having a little difficulty with in the UK is people who were changed before this information came to light, maybe as part of the trial. Some people were changed as part of the RAP study. These people like being on rivaroxaban. It's a lot more freedom for them because they don't have to have very good INRs. So with these people, the hematologist is sitting down and talking to them and saying, look, there are some studies saying that the drug you're on may not be as good. What do you want to do? Do you want to carry on with this drug? And many people say, yes, we'll accept the risk, because life is full of accepting risk. And some people will say, okay, it seems to be a small risk. I've been fine on this drug. But at the moment, we're not really changing people to the DOACs because of the evidence. Some people, it might be appropriate for them if they're finding warfarin extremely difficult.
If there is no further questions, then we can close the session. And thank you, Professor Rahman, again.
That's right. Thank you.
Thank you, Professor Rahman, for that wonderful talk. Next up, we have a very interesting and less discussed topic of monogenic lupus and whether we are missing diagnosing it. It's going to be given by Dr. Vignesh, who is a pediatric rheumatologist at PGI Chandigarh. And may I invite Dr. Shuparna Guhu and Dr. Priyankar Pal to please chair the session. Thank you.
So welcome, Vignesh. I think this is your first visit to the city. Vignesh is a pediatric rheumatologist. He has done his DM from PGI Chandigarh.
He is an associate professor at the Department of Pediatric Rheumatology and Immunology at PGI Chandigarh. So I think, so let's listen from Vignesh.
Thank you, sir. So thank you, organizers, for having given me this opportunity, Dr. Alakendra Ghosh and Dr. Agya. So here I am to talk about monogenic lupus. So are we missing those conditions? So what is monogenic lupus? So monogenic lupus are the form of SLE that occurs with a single gene defect. So the main situations where one could have a monogenic SLE can be divided into these three categories. That is the complement deficiency, the genetic overproduction of interferon alpha, and the apoptosis defects. So familial SLE as well as early onset juvenile SLE studies make it possible to identify monogenic causes of SLE because these disorders are usually seen in the pediatric age group. So these are the three categories again. So when we look into the pathogenesis in detail, so this is the genetic overproduction of interferon alpha. So either you have genetic defects that results in loss of regulation, which results in overproduction of interferon alpha, or you have defects which results in excess interferon alpha action. So this could lead to autoimmunity. In case of complement deficiency, especially the early classical components, when they are deficient, so these are mainly needed for clearance of apoptotic bodies and the immune complexes. So due to genetic defects, if they are not cleared properly, this again could lead to autoimmunity. And also C1q, it has a regulatory function on interferon alpha production. So whenever C1q is deficient, you have hyperproduction of interferon alpha. The third group is the apoptosis defect. So you need apoptosis to kill the autoreactive T cells. So when this mechanism is again defective, you again develop autoimmunity. So these are the various genes under these three categories which have been described with monogenic lupus. So this is again the cartoon to show that the defective clearance of apoptotic webs and the immune complexes triggering the autoimmunity and the unwanted nucleic acids triggering the excess production of interferon alpha due to various genetic defects. So this is again the adaptive immune component. So we have various B cell signaling molecules. So when they are overactive, they can again lead to lupus-like symptoms. So when to suspect monogenic lupus? So we consider monogenic lupus if there is atypical or incomplete SLE-like symptoms at a very early age, when there is consanguinity, when you suspect there is Mendelian inheritance, when there is positive family history, or when the disease is refractory to treatment. So moving on to complement defects. So complement deficiency, the prevalence is very rare. It is 0.03%. Less than 1% of lupus cases have been shown to be associated with complement deficiency. Out of that, C1q deficiency has the most association with the SLE. 90% of these cases develop SLE. In C2 deficiency, 10 to 30%, whereas in C4 deficiency, it is 75% of cases. So you would remember that the early classical components, the complement components, they're also involved in opsonization along with IgG. So whenever these molecules are deficient, these patients also develop recurrent infections due to encapsulated organisms. So this is again the C1q deficiency in particular. So generally they have associated cutaneous manifestations, renal, and the CNS manifestation. These are the three most common symptoms of lupus which these patients develop. So coming on to the case, so this is our first case of complement deficiency which we encountered. So this is a 4-year-old boy who presented with fever, discoid lupus rash, oral ulcers, and alopecia since 3 years of age. He landed up here with us with seizures, and the MRI has actually shown a corticosynovial thrombosis. His C3, C4 was normal. His ANA was 4+ in indirect immunofluorescence, and which was a speckle pattern, but his anti-dsDNA was negative. And whereas his anti-Smith and anti-RNP were positive, and he also had positive APLA. So this is a skin biopsy showing the immune complex vasculitis. And this is the family history. So we have an elder sister who had died at early age due to lupus, and the C1q levels in this kid was persistently low. Also, his younger male sibling also had low C1q, and the mother and father who were carriers for this mutation had a subnormal C1q levels. And the most important laboratory parameter to see in this patient is the persistently absent CH50 activity. And this patient had the C1qa mutation, the homozygous nonsense mutation in C1qa. There can also be defects in C1R and C1S. So generally the manifestations are a little bit more severe compared to the C1q deficiency. And they also have recurrent bacterial, viral, and fungal infections. And they also have glomerular nephritis. So these are the 13 and 12 exons of the C1S and the C1R. These defects are not that common as C1q deficiency. Only few mutations have been described till date. So C1R deficiency, it has been described from a patient from African American ancestry and one from Turkey. And recently, this is the third patient, which is an Indian family. So our colleagues from Madras Medical College had referred this child to us. So this is a 4.5-year-old girl who had lupus with skin and CNS involvement, had pancytopenia, again had positive ANA, speckled pattern where the anti-DS DNA is negative, and this patient had anti-Ro and anti-Ro 60 and anti-Ro 52 positivity. And these are the severe skin lesions which this patient had. So this is the C1R, proven to have a C1R defect. So this is the third patient to be described in the globe. And this patient had a deleterious mutation in C1R. C4 deficiency is very rare. The complete deficiency is actually very rare. The complete deficiency is fatal, whereas the partial C4 deficiency, where you have low copy numbers of C4, generally they are not that, the disease is not that fatal as compared to the complete deficiency. And they present with severe photosensitivity, renal involvement, and they also have recurrent infections and deep-seated abscess. So this is the patient with C4 deficiency who had osteomyelitis. So this is what I'm talking about. So this C4 has, in normal human subjects, it varies from 2 to 8 copies. So when you have low copy numbers of C4, people have shown that they have increased predisposition to development of SLE and also nephritis. C2 deficiency is the most common complement deficiency. However, we haven't encountered one patient till now because this is the complement deficiency most seen in adults. This is not usually seen in pediatrics. The type 1 C2 deficiencies are the most common, and it is due to nonsense mutation in C2 or due to 2 base pair deletion in exon 2. The type 2 C2 deficiency is due to defect in secretion of C2 that are normally synthesized. So summing up, so we have the early complement components here, and we have the predominant clinical manifestations. So if we see all these cases, the skin, the kidney, and the CNS, these are the predominant organs to be involved here. And when we look at the autoantibody positivity, generally they are anti-dsDNA negative, but they are positive for anti-Smith or RNP or ROLA. So this is an important point to be noted here. So all these conditions are have an autosomal recessive inheritance. And as I emphasize again, it is the renal, CNS, and the skin involvement with associated pyogenic infections, which is the typical phenotype of these disorders. So this is our single center experience, which we published in 2015, the 7 patients with complement deficiency, early classical complement components deficiency. Here again, we can see the C1q is the commonest deficiency which we have seen. So these are the subsequent reviews which you can go through, where we discuss the exact mechanisms, how these results in formation of autoantibodies and clinical manifestations. So this is again a C1q deficient patient who manifested with Kikuchi-Fujimoto and macrophage activation syndrome, published in Oxford Rheumatology. So how to recognize monogenic lupus due to early complement defect? So they are early onset lupus, predominant skin, CNS, and renal involvement, associated recurrent sinopulmonary infections or deep-seated abscess, positive family history and consanguinity, they generally have normal C3, C4 levels, except in C4 deficiency. In C1q and C2 defects, you see normal complements, and ANA is generally speckled pattern with negative anti-PS DNA and positive anti-Smith or anti-La titers. So this is the laboratory approach. We can look at the C1q levels. They're generally absent or low in C1q deficiency, whereas the C4 levels are normal or elevated, and CH50 is persistently low. So this is one important investigation in this group of disorders. Even when the disease is inactive, the CH50-10, they are persistently low. In C1s and C1R defects, the C1q levels are normal. And in C2 deficiency, the C1q levels are normal, whereas the C2 levels are reduced. And in C4 defect, the C4 levels are persistently low, even in the absence of disease activity. So that is a clue for C4 defect. So this is how we next evaluate. So we have a Luminex panel to look at different complement components, and we have a NGS gene panel to look at different genes associated for complement deficiency. So why to recognize these disorders, these fancy genetic defects? Of course, one is the genetic counseling for the family. They can undergo antenatal testing if they have one affected child. And the treatment modality in these complement deficiency is different from that of conventional lupus because these patients also have recurrent infections. So they need prophylactic antimicrobials, and the skin manifestations especially, they do not respond to conventional immunosuppression like MMF or azacitidine or even rituximab. So these patients have been reported to have a good benefit with fresh frozen plasma infusions. They have the C1q component. And we have also seen that plasma helps in the cutaneous manifestations in these children. The only complement to be secreted from bone marrow is the C1q. The rest other complements are secreted from the liver. So C1q deficiency is amenable for hematopoietic stem cell transplant. But however, results are not uniformly assuring. There are some reports where HSCT have not benefited these children. So moving on, type 1 interferon defects. So we know the association of type 1 interferons and SLE is from the past, since the early 1980s. Type 1 interferons have been shown to have a good correlation with the SLE disease activity. And some patients with malignancies and viral hepatitis who were treated with recombinant interferon alpha, they also develop SLE, and the SLE manifestations resolve with the discontinuation of drug. And TNF is a cytokine that is known to suppress interferon alpha, and we very well know patients with anti-TNF, they have an increased predisposition to development of SLE. So these are the various genetic defects that predispose to lupus due to elevated type 1 interferon activity. So we have TREX1, SAMHD1, ACP5, DNase defects, protein kinase C delta, and even the complement deficiency. As I previously told you, C1q is very important for the regulation of interferon alpha production. So once C1q is defective, it also leads to interferon alpha overproduction. So these genes are generally exonucleases or endonucleases, which are normally required for clearance of unwanted nucleic acids which are present in the cytoplasm. So when these enzymes are defective, these blue ones, when they are defective, these nucleic acids, they accumulate and they stimulate the overproduction of interferon alpha. And these interferon alpha, they undergo downstream activation for the interferon stimulated genes, which results in autoimmunity. So these are the genes generally, these blue, highlighted in blue, these are the genes that are associated with type 1 interferonopathy. I want to take your attention to two specific disorders. One is this spondyloenchondrodysplasia. So this is a homozygous mutation in ACP5 encoding the protein tartrate-resistant acid phosphatase, that is TRAP. So this genetic defect is characterized by skeletal abnormalities like platyspondyly and enchondromatosis, brain calcifications. They have developmental delay and spasticity, and they also develop autoimmunity and lupus nephritis. They can have various autoantibodies ranging from anti-dsDNA to anti-phospholipid antibody. And this is the characteristic clue of this disorder. You see flat vertebral bodies, and you see the abnormalities in the distal end of the bones that is typically called enchondromatosis. So the second disorder is the Aicardi-Goutieres syndrome. So this defect is associated with progressive encephalopathy with neonatal onset manifestations. Though generally they are associated with increase in interferon alpha in the CSF, and this is the characteristic manifestation. They typically have basal ganglia calcification, and the manifestations of AGS, that is Aicardi-Goutieres, they can mimic congenitally acquired torch infection. And these are the manifestations of autoimmunity these patients develop. They typically develop these chilblain kind of lesions, and they also develop autoimmunity. So these patients are also referred to as unwanted nucleic acids that are in the cytoplasm. So once these enzymes are defective, the accumulation of nucleic acid takes place, which results in downstream production of extreme production of type 1 interferons. So this is again a paper to show that these patients with Aicardi-Goutieres, they have elevated type 1 interferon signature as compared to the controls. So they have overlapping manifestations. So generally they have CNS and the skin involvement. So as I told you, they have a developmental delay and the basal ganglia calcification, which are typical of these disorders. The ADAR1 defect, they have striatal necrosis, and the various genes in these trap RNAs, they are associated with the spastic paraparesis. And developmental delay is usually seen in majority of these disorders. And this is again, I want to, sorry. Yeah. So again, the SAMHD1, they have associated CNS vasculitis, and the chilblain, it is associated with the genes that are associated with Aicardi-Goutieres syndrome. And the complement deficiencies are associated with infection susceptibility. This DNase 1,3 defect, they are generally associated with both lupus and ANCA positivity. They have manifestations of both. And the rasopathies are associated with autoimmune cytopenia. The hematological manifestations are more common here. And the complement defects, they generally have a decrease in CH50 as we have previously described. So moving on to a case. So this is an 8.5-year-old girl who had a history of oral ulcers, came with autoimmune hemolytic anemia and thrombocytopenia, diagnosed as Evans syndrome. Her ANA was 3+ homogeneous pattern, C3C4 was normal, anti-dsDNA was mildly elevated, but there was a background history of global developmental delay and spastic diplegia. And the cytopenias actually improved on oral steroids and azathioprine and mycophenolate mofetil. Years later, the younger boy, he also came with similar complaints, failure to thrive, global developmental delay, and had spasticity. However, this child did not have any autoimmune hemolytic anemia or thrombocytopenia. But what is characteristic is the skeletal manifestations these two kids had. So these two kids had the mutation in ACP5, that is the spondyloin chondrodysplasia. And you can see the interferon, type 1 interferon score is significantly elevated as compared to the control. So this is again a patient with RNase H2B, a type of Aicardi-Goutieres, presented with developmental delay, excessive startle, and had recurrent episodes of fever and prolonged lethargy. And the MRI actually showed the typical calcifications. So again, in this patient, you can see the type 1 interferon signature is very much high. It is almost 6 times more compared to the normal control. And this patient had a pathogenic variant in RNase H2B. And this is a child with IFIH1 defect, again, a form of Aicardi-Goutieres, global developmental delay, episodic neuroregression. And this child also had a typical basal ganglia calcification, and also had a high interferon score. So when to suspect type 1 interferonopathy? So whenever you have a child with developmental delay, intracranial calcification, chilblain-like lesions, and associated autoimmunity, when you see this compilation of clinical symptoms, you suspect interferonopathy of Aicardi-Goutieres syndrome or ACP5 defect. And when you have associated short stature, chondrodysplasia with associated lupus, ACP5 defect is the gene that you're looking for. Or when you have features of both lupus and ANCA-associated vasculitis, this is typically seen in DNase 1L3 defect. So how to work up if you suspect a case with type 1 interferonopathy. So this is the in-house interferon signature score, which we have developed in our lab. And we also have a panel for interferonopathy. So these are the genes that are included in panel. Dr. Amit Rawat and Madhubala Sharma in our laboratory, they are very instrumental in developing these tests in our lab. So the final one, apoptosis defects, they are generally very easy to detect clinically. So these are generally autoimmune lymphoproliferative syndrome associated either with FAST defect or FAST ligand or ALPS-like diseases, which are there are many diseases actually which have come up in the recent times, but Benta and STAT3 gain of function mutation, they have manifestations similar to autoimmune lymphoproliferative syndrome. So as I told you, when apoptosis is not taking place in right manner, autoreactive T cells persist and they result in persistent autoimmunity and lymphoproliferation. So this is how these patients present. So they have predominant hematological autoimmunity, autoimmune hemolytic anemia, and immune thrombocytopenic purpura, and they generally have florid lymphoproliferation and hepatosplenomegaly, which we generally do not see in conventional lupus, and they have early age onset. So this is the classical criteria, classification criteria for diagnostic criteria for ALPS. So we have non-malignant, non-infectious lymphadenopathy or splenomegaly, and elevated double negative T cells, the CD3 TCR alpha beta positive, CD4 negative, CD8 negative T cells. So these are the classical manifestations which we see in autoimmune lymphoproliferative syndrome. There are various markers which are elevated in this ALPS, the soluble FAST ligand, the plasma interleukin 10. The more simple marker to do is the vitamin B12, which is very high in this disorder, that is more than 1,500 nanogram per liter. And if you have facility to do IL-10 and IL-18, they will be elevated as well. So this is a prototypic case, a 4-year-old boy with severe pallor and massive hepatosplenomegaly. He had positive DCT, and his ANA was 3+ speckled, and anti-Smith antibody was positive. So he had basically pancytopenia with autoimmunity and hepatosplenomegaly. He didn't respond to IVIG, prednisolone, rituximab, mycophenolate mofetil. Still, he was requiring multiple rounds of PRBC and platelet transfusion. And these are his immunological investigations. The immunoglobulins are high, vitamin B12 is sky high, and the double negative T cells are elevated. And soluble FAST ligand is more than 15,000 picogram per ml. And this patient had a molecular defect in FAST. And what we did, we introduced sirolimus, and you can see the cytopenias have improved, and we could taper down the steroid doses in this child. The final one, lupus in an X-linked carrier for CYBB. So CYBB is a gene for chronic granulomatous disease, but females who carry this defect, the heterozygous defect in the females, they could have manifestations of lupus. So this is one mother of a boy who had X-linked CGD, who had manifestations of lupus. She had arthralgia and malar rash, and she developed transverse myelitis at 32 years of age. Her autoantibodies, the ANA was 4+ speckled, and anti-DS-DNA was positive. She also had positive APLA, and she also had manifestations of CNS vasculitis. So this is the family where the mother had florid manifestations of lupus, and daughter had CGD due to skewed lionization, and the son had the classical manifestations of X-linked CGD. So whenever you encounter mothers with lupus, when you get a history that the son is not well, or the brothers who had died in early age due to chronic granulomatous disease, this is one disorder which has to be thought in mind. So to conclude, complement deficiency, apoptosis defects, and interferon overproduction have been confirmed as responsible for susceptibility to lupus. With the advent of next generation sequencing, we understand a lot of these genetic defects, and more genetic defects are being described for this early onset lupus groups. And acardiotic gluteus, as I told you, it has to be suspected in differential diagnosis of child with developmental delay or episodic neuroregression. And this clinical presentation, as I've highlighted to you, it is different from that of the conventional adult lupus. So I thank you again. These are my acknowledgements. Dr. Amit Rawat and Madhubala Sharma, who developed the tests for complement deficiency and interferon signature in our lab, and Dr. Angela Revelli and Dr. Stefano Volpi, whom we collaborated with the Indo-Italian project. And this has helped us in the development of the type 1 interferon score and the genetic panels, which we have in our lab. Thank you very much.
Thank you, Vignesh, for the wonderful and the enlightening presentation. Any questions from the audience?
Somebody has to keep everyone awake. So my question is, since these are children mostly, there was this data on inflammasome and NLRP3 in lupus nephritis in adults, and people have also tried anti-IL-1. Is there any data in children? Because there are more autoinflammatory symptoms in children.
So inflammatomes, generally they do not have autoantibodies in children. They have a presentation which is rather different, that are called autoinflammatory disorders. So there is a role of anti-IL-1 agents. Generally, these monogenic defects in the in the inflammasome pathway, they do not result in manifestations of lupus. The manifestations are rather different.
Any more questions from the audience? So Vignesh, I have a question for you. So for a child less than 5 years, early onset lupus, what are the screening tests which you would do in order to rule out monogenic lupus?
So in the first visit, we generally see the clinical manifestations. So as I told you, if the manifestations are rather severe, if there is predominant CNS and renal manifestation, and if they have normal C3, C4, and if the ANA has a typical pattern, if the dsDNA is negative and the Smith is positive, we suspect the early classical component pathway deficiency. If they have associated developmental delay, neuroregression, then we think more of AGS or ACP5 defects. And we look at the complements and the ANA pattern and the clinical history and what type of autoimmunity. So suppose if there is predominant hematological autoimmunity, as I showed in the last case, with massive splenomegaly or lymphoproliferation, we definitely do the double negative T cells to look whether these patients are having autoimmune lymphoproliferative syndrome. So these are the various clinical and laboratory clues which we look in these children. And we do the ANA anti-dsDNA. We can get a rough clue from the clinical presentation and from the basic labs. To confirm this, we do the C1q levels. So if the C1q levels are persistently low and CH50 activity is persistently low, then that is very much typical of. Okay, so. Okay, so you can send the samples to us, so we can do it for free because the project is still on.
I have one question. Why there is basal ganglia calcification in these patients?
Yeah. So the complete answer is not known yet, but these patients have elevated type 1 interferons in the CSF. So it is probably due to the CNS inflammation that has resulted in calcification. The entire answer is completely not clear. Why they characteristically develop these calcification only in the basal ganglia area? The answer is not clear.
Vignesh, for the wonderful presentation. Thank you.
Thank you.
Thank you, Dr. Vignesh. Next up, we have a talk on the 10 most contemporary challenges in lupus, which will be given by Dr. Laurent Arnaud. And can I invite Dr. S.R. Pal and Dr. M.P. Das to please share the session?
we proceed to the next speaker, I wanted to introduce you to Professor Laurent Arnaud, who is a very avid researcher from France, and he's in the field of lupus and antiphospholipid syndrome, and he's the president-elect of the Euro-Lupus organization. And he will be speaking on the topic, a clinical topic, 10 most contemporary challenges in lupus. So may I request Professor Laurent Arnaud to deliver his
Hello. I have to apologize. I just had some problem with the internet just a few seconds ago, so I think it's starting to go better. Can you see me?
Yes.
Okay. Can you see the screen?
We can see you.
Okay, thank you very much. So good day, good morning to you all. This is an immense honor for me to be invited to talk in India. This is actually my first time, so this is very much into my heart. I'm really, really happy to share this time with you. I have been asked to talk about the challenges in the context of systemic lupus, and I really hope we are going to have a nice exchange about what are the challenges in France, in the world, in India. I think it's going to be great to compare. So these are my disclosures. And I just would like to say that it's absolutely okay to take pictures of the talk. When I go to meetings, I see people with their photograph or their telephone taking pictures. So that's absolutely okay. I can also give the slides if you're interested at the end. So this is my first time. I just wanted to say a few words. So I'm a professor of rheumatology in Strasbourg in France. If you do not do that, you can follow me on my Twitter account, Lupus Reference. It would be a pleasure to exchange with you. And the city of Strasbourg is a beautiful city in the northeast of France. I hope we will have the opportunity to meet together, maybe in Kolkata or maybe in Strasbourg. That would be amazing. And we are one of the 4 French National Reference Center for Autoimmune Diseases. So we follow huge cohorts of patients with autoimmunity, including systemic lupus, which is really my area of expertise. So I'd like to start the talk by asking what I think is a very important question to you is, what do you think is the most important event in the history of autoimmune diseases? And according to me, it's the discovery of corticosteroids. I'm sure you know that they were given for the first time in 1948 to patients with rheumatoid arthritis, and that for that, Philip Hensch received the Nobel Prize just 2 years later. So that was an amazing discovery. And since this discovery, the prognosis of systemic lupus has really improved. Before corticosteroids, 50% of patients were dead 1 year after the diagnosis. And now we know that survival rates are over 90%, 95% at 10 years in most centers. So this is due to, of course, corticosteroids, but also to many other treatments. And this is also due to a better recognition of the disease. At 10 years, which means that about 10% of patients will be dead 10 years later. And I think this can be improved. The second element is damage. If you follow prospectively patients without damage, 50% of them will acquire new damage after a mean time of 8 years later. The third point is the quality of life. We are all working with lupus patients, and we are all convinced that the quality of life is really not good in systemic lupus. So with our National Reference Center, we've been reviewing what we think are the most important challenges in the field of systemic lupus, and this is really what I'm going to tell you today. Those are what we have identified as the 10 most important challenges. We are going to breeze through them one by one. But first, I really think that the number one challenge is actually to make a diagnosis of systemic lupus. And I think it's the same for you. It's a combination of manifestations that will be compatible with systemic lupus, the presence of anti-nuclear antibodies, and I'll come back into the details in a few minutes. And we also have to rule out differential diagnosis, and there are many. So first is, what are the typical situations when we should think about systemic lupus? Well, we know it's a systemic disease which is highly polymorphic, so there are many situations. It can be inflammatory joint pain, it can be pericarditis, it could be a rash on the skin, cytopenia, so it's very diverse. But I also think we have to keep in mind that we have to think about systemic lupus when there is unexplained fever, and also when we are confronted to strange manifestations that nobody understands, especially if several organs are involved at the same time. The second element is that anti-nuclear antibodies should be present for the diagnosis. They are found in a huge majority of lupus patients, 99%. No anti-nuclear antibodies is a strong element against the diagnosis of systemic lupus. And this is something which is very practical. For instance, in the intensive care unit, you are asked by the colleagues, do you think the patient could have lupus? Well, if there is no ANA, usually it's not lupus. And third, something difficult is to rule out differential diagnosis. I have taken these pictures on the internet. I'm sure you have seen patients like this during the year that has just been behind us. And obviously, this is not lupus, this is rosacea. It's a very common differential diagnosis. And this is just to remind you that there are many, many mimickers of systemic lupus, especially cutaneous mimickers. And we've just heard a beautiful talk about type 1 interferonopathies. So we have to keep this in mind when we are doing our differential diagnosis. So how do we make a diagnosis of systemic lupus? Well, clearly not by using criteria. Those criteria are classification criteria. They have been derived to make homogeneous groups of patients for clinical research, for studies, for trials, but they should not be applied at the patient level, at the individual level, to make a diagnosis of systemic lupus. For that, we should really rely on our intelligence. So now let's move on to the challenges. First challenges, I think, is controlling disease activity. And I think it's a great opportunity to review the general management of symptoms in systemic lupus. We start by a complaint from a patient, I have something. And the first element will be attribution to systemic lupus. Is this manifestation due, or maybe not, to systemic lupus? And this is a complex process, and we decide based on positive findings, test results, negative findings, and occasionally there can be a bit of probabilistic reasoning. We can come back to that later if you wish. And so when you've done this attribution, you will decide whether the symptoms are actually due to lupus or not due to lupus. And the next step, when the symptoms are actually due to lupus, is to determine whether this is an active manifestation or not an active manifestation, and that would be damage. And this distinction is really crucial because active disease will be managed as a flare, and patients will receive corticosteroids and immunosuppressive agents if it's needed. And that's not the case for damage. So in the current definition of disease activity in lupus, we include reversible manifestations. They will disappear after treatment that are due to the flare. And we know that if the patients are not treated or not treated enough, or if they are unlucky, unfortunately, it will progress towards damage, which by definitions are irreversible manifestations that have been due to the flare. And I am sure you know that, but in systemic lupus, we also count side effects of treatments as damage. And so this distinction is really crucial. Disease activity should be treated with hydroxychloroquine, corticosteroids, immunosuppressive agents if needed, but it's too late for damage. No immunosuppressive agent should be used. We should use symptomatic treatment. This is why it's so important to make the distinction between what is active and what is damage. Second question, second challenge, treat to target. We have to treat, but the common question is, what are we treating for? What is our aim? What's the goal? And the answer in systemic lupus is remission. This is an international recommendation. This is true in the British recommendation for Anisur Rahman. This is true in EULAR recommendation for Europe. This is also true in the PANLAR recommendations for Latin America. The main therapeutic target is remission. So it brings us to another question, which is, what is remission? And with Anisur Rahman, we are part of a group called DORIS, which has been thinking a lot about the definition of remission under the auspice of Ronald van Vollenhoven. And we've agreed upon a practical definition of remission in lupus, which is no clinical SLEDAI equals 0, no clinical manifestations, a PGA, physician global assessment of less than 0.5 on a 0 to 3 scale, a maximum dose of 5 milligram per day of prednisone, okay for hydroxychloroquine, of course, and we can use immunosuppressive agents or biologic as long as the dose is stable. If these conditions are met, then the patient is in remission. Then there's another question, which is, for how long should someone be in remission to be protected against damage? And this is the incredible power of remission. Reaching remission, even just a bit, just a minority of visit, is enough to protect you strongly against the risk of damage. Unfortunately, only a minority of lupus patients will actually achieve remission, and especially prolonged complete remission. So some colleagues, especially from Australia, thought, well, they said, if we cannot reach the center of the target, remission is difficult to achieve. Can we go slightly on the side and go only for low disease activity? And so they have derived a criteria called LLDAS, Lupus Low Disease Activity State, which is a combination of different elements. And they have shown that that was a kind of acceptable plan B. If you cannot reach remission, it's okay to reach LLDAS. It's less powerful in terms of protection against damage, mortality, and so on, but it does protect a bit. So that's an acceptable plan B. Third challenge is corticosteroids. I'm sure it's the same in India as it is in France. We are using too much corticosteroids. The amounts we use are too high. We know their amazing properties, immunosuppressive effects, anti-inflammatory. They also can act as painkillers, but we also know that there's a price to pay, and I'm not talking about financial price, I'm talking about side effects of corticosteroids that will not be good for our patients on a long-term basis. So quick question to you, which proportion of lupus patients actually receive glucocorticoids? And I'm sure you know that the answer is many, many of them, almost all of them, 93% in this European study, 100% in the SLIC group study. But we have recommendations. How shall we use them on a long-term basis? And I'm going to be very direct. There is this EULAR recommendations from 2019, with which I do not agree at all. The recommendation is that we should, if we can, stop glucocorticoids, but if we cannot stop them, they should be minimized to less than 7.5 milligrams per day. And I honestly think this is way too high. This was the same threshold as 20 years ago. And we have new data, recent data showing that all corticosteroids is bad, especially for the bones. But there's a significant association between corticosteroids and damage as soon as you use more than 5 milligrams per day on a long-term basis. So I really think the recommendation should have been 5 milligrams and not 7.5. This is unacceptable for me. So how do we do that? Because it's great to start corticosteroids, but if we want to stop them, if we want to decrease them, we need to use additional drugs. And it's true that in systemic lupus, we have a few common immunosuppressive agents we can use. But of course, there is a big challenge about these treatments, which is, when shall we use them? We should not use them too early. Otherwise, the patients are exposed to side effects and especially a risk of infection. But we should not use them too late. And I commonly see patients being put on corticosteroids for several years without any immunosuppressive agents. And that's not good either. So we need new drugs. And I'm sure you're aware that there have been many, many, many trials in the field of systemic lupus. with at least 25 drugs that went to a phase 2 study or a phase 3 study and failed the study, which is really sad. It's sad for the patients, it's sad for ourselves because we would have been loving to prescribe these treatments, but it's also sad for pharmaceutical companies because millions of dollars have been put into the research and development for these drugs and it did nothing good. So why do we have these problems? Well, it's quite complex. It's a complicated answer, but it pertains to the outcome measures. We do not have very good outcome measures in the trials in systemic lupus. And also to the standard of care, especially the use of corticosteroids, especially in the first trials. We gave too much corticosteroids, and this maybe reduced the apparent efficacy of the drugs that were tried. And this goes back to the heterogeneity. This is a major challenge in the field of systemic lupus. I think we all know in the room that when we talk about lupus, it's actually way more complex. I can just take the example of lupus nephritis. I'm curious to hear what you're going to say about India. But in Europe, this is not a recent work, but there's 1,000 lupus cases from Europe. The mean proportion of patients with nephropathy is around 40%. My guess is that it's probably a lot more in India. And so it's interesting to understand why will some patients develop lupus nephritis and some other patients will not have lupus nephritis. And we know that it's connected to the genetic background, which is highly complex. With the exception of monogenic lupus, we've heard in the previous talk, lupus is generally speaking a polygenic disease with more than 100 genes or variants that contribute to the risks. So there's a high complexity here. And we also know that not all the patients have the same patterns of immune dysfunction. This is an amazing work in pediatric lupus by Banchero. And we are doing the same in Strasbourg. We have a huge program, $30 million, euros, to do a very large multi-omic studies on southern lupus patients to profile them more precisely. I'd like to skip to pregnancy because we're talking about young women. And so pregnancy is obviously a big challenge in systemic lupus. We know that there are some contraindications, such as recent disease activity during the 6 month or last 12 months, depending on the manifestation. But we know that there is an extra level of complexity due to APL profiles. When the patients have antiphospholipid antibodies, following the pregnancy is going to be more complex. And also if the patient has anti-SSA, anti-SSB antibodies, there's the risk of neonatal lupus, which complicates the follow-up. Apart from the contraindications that are on the slide, I'd like to add two contraindications we sometimes forget, which is severe renal failure and also severe pulmonary hypertensions, which are general contraindication to pregnancy. And it can be actually quite complex to follow lupus pregnancies with some of these elements. So the precise follow-up is actually quite complicated. I made this slide for Twitter with Laura Andreoli from Italy. We talked a lot about what to put on the slide. I'm not going to go into the details, but we all know that the follow-up of pregnant women with lupus is quite complex and it has to be done very carefully because there's a bit of risk, both for the mother, but also for the children. I have good news. This was published very recently. An important question is, our patients with systemic lupus will receive immunosuppressive agents, hydroxychloroquine, azathioprine during the pregnancy. And a question is, how are the children going to be about their neuropsychological development? And we did not have good data. And now we have a very good study performed in Denmark on very, very good population-based approach, which shows that there is strictly no difference in school performance between the children that are born from the general population and those that are born from SLE mothers. So that's something very important to be reassuring with the mother that the children are going to be okay. I'd like to talk about the comorbidities. Our patients hopefully survive systemic lupus, and so they have time to acquire damage and to develop complications. So a quick question to you is, which comorbidities can you think of in the context of systemic lupus? and I see many. One of them is infection. We've heard about complement deficiency in a previous talk. We know that there's a major role for corticosteroids and immunosuppressive drug for the risk of infection, systemic lupus. So we really have to be careful about these treatments when we use them. And so my little advice is, of course, to check the vaccine status, to check the vaccination against the flu, and also to update the vaccination against pneumococcus when it's not done. This should be included in the best practice and updated if it's not the case. A quick question is, of course, the COVID vaccination. This is a big challenge. And maybe you know that, but I'm now the executive president of the European Lupus Society. And so with our colleagues, we have derived some recommendations for COVID vaccination, specifically for lupus patients. So you can download the flyer if you're interested. The link is on the screen. Another comorbidity is osteoporosis. This is a big challenge. We have to think about the importance of corticosteroids, but also to the fact that we are recommending photoprotection to the patients. So their vitamin D levels are not okay. And that's, of course, not okay for the bone health. So we really have to use the lowest possible dose of corticosteroids, but also to ensure that the vitamin D levels of the patients are correct due to this photoprotection. And finally, an important comorbidity we have to think of is cardiovascular risk, which is due to classical cardiovascular risk factor, as in the general population, but also to disease activity, disease duration, damage. There's, of course, a role of antiphospholipid antibodies and a role of treatments such as glucocorticoids. In small dose, it helps controlling disease activity, but when it's given in very high dose, it will promote atherosclerosis, and that's not good. So I think about the little advice I can discuss, one of the most important one is to be sure to assess and treat modifiable cardiovascular risk factors. I see many patients who have not underwent any lipid testing or glucose testing in many years. And occasionally I see patients with abnormal LDL levels and nobody has done anything. This has been seen by several doctors, but no doctor has decided to do anything. And this is also not good. Now I'd like to give you a bit of feedback upon the patient perspective. When we derived these challenges, we invited patients to give them the feedback. And I'm just presenting the typical journey of a lupus patient. You know, it starts by the first symptoms, then there's a bit of doubt. People think it's going to go away and it does not go away. So they go to their general physician and then they are referred sometimes for a long time to many physicians until they see a rheumatologist or a pediatrician specialized in lupus. And so in Europe, the Lupus Association for Europe, Lupus Europe, they have made a huge study. There are more than 4,000 patients in the study. And it shows that in 2020, the median diagnosis delay for lupus is still around 2 years, which is very long. So we should all work together to try to decrease this delay to something more acceptable. And then when the diagnosis is made, it's true that for the patient, it's a kind of gain of monopoly. They go through their rheumatologist, to the nephrologist, they go to the eye specialist for plaquenil, they're referred to the dermatologist. It's actually quite complex, quite boring for them. So we really need to think about ways to improve patient pathways. And this is something we're doing in my region, Alsace, trying to assess systematically using artificial intelligence pathways of patients in order to optimize these pathways. Finally, I'd like to talk about holistic approach because it's great to treat disease activity, but there are many other things we can do. And one of these approaches is smoking cessation. We know that tobacco smoking is very toxic. This is true for everybody. But we know that there's specifically a deleterious impact upon the course of systemic lupus. Smoking will increase the risk of SLE, increase disease activity. If you have skin lupus, you will increase the number of lesions. Of course, it has bad effects on the heart, on the bones, on the risk of cancer. but also it decreases the efficacy of treatments. So we have to keep that in mind. Plaquenil is working 50% less in smokers compared to non-smokers. Then there's a big issue, which is therapeutic adherence. Lupus is a chronic disease, so obviously when the treatments are not taken, they cannot work. And in France, and I don't know about India, it's going to be interesting to discuss, we can measure a plaquenil blood levels in the blood, and it's a very easy way to spot out, to find patients who stopped taking their treatments. That's really, really important, because if you are confronted to a flare, the good strategy in a patient who is not taking the treatment will not be to add another treatment on top. It will be to discuss with the patient and just assess that the treatment should be taken. And actually, when you follow up these patients prospectively, following a good discussion, a huge majority of patients will start taking the treatments again. So I really believe in the medical relationship between the patient, the doctor, to be able to talk in a very nice atmosphere about why the treatments are not taken and how we can help improving adherence. Then this is the end of the talk, not the end of the day for you. I think you may be a bit fatigued, and so I just want to finish talking about that. This is the #1 manifestation quoted by patient as the most bothering, most bothersome due to systemic lupus. And we've done big studies about fatigue. Fatigue being significant is reported by around 2/3 of lupus patients, and 1/3 of lupus patients reports major fatigue, which means as strong as what can be seen using validated scales, such as in multiple sclerosis. So we're talking about real fatigue, very, very heavy fatigue. And we've performed cluster analysis of our patients with fatigue, and we found interesting findings. I think the cluster which is the most difficult to take care of is cluster number 2, which is around 25% of patients. I'm sure you've seen patients like that. They have no or very low disease activity, and this contrasts with very high level of fatigue, very high anxiety, and high level of depressions. And sometimes this is very difficult for the physician, for the rheumatologist, because you feel like the disease is perfectly under control, and the patient is complaining from fatigue, very intense fatigue, and it can be a bit difficult to manage. So this is my final slide, a kind of summary of the holistic management of systemic lupus. I think the heart of our treatment, the heart of our rheumatologic management is the control of disease activity, targeting remission, and if we cannot target remission, is targeting the LLDAS. This will prevent flares, this will prevent the risk of damage, and the proper way to do that is to use antimalarials, ideally for all the patients until it's contraindicated, to use limited amounts of corticosteroids, to use immunosuppressive agents when it's needed, not too early and not too late either, to try to manage comorbidities such as osteoporosis, cardiovascular risk, the risk of infections, and the risk of thrombosis. This was developed beautifully by Anisur Rahman. There's a big challenge around fertility and pregnancy, also around monitoring, because it's great to treat the patients, but we have to monitor them prospectively. I'm thinking dipstick, urine dipstick for proteinuria. We have to detect this complication, which can be very deadly as soon as it appears. And finally, there's some space for lifestyle intervention, photoprotection, smoking cessation, reinforcing therapeutic adherence, and managing the disease globally, including fatigue. I have to thank you very much for your invitation. It's a great honor for me to be here and to exchange with Indian rheumatologists. I know autoimmunity is very strong in India. I have been talking with many colleagues, and it's a great honor for me. Thank you very much.
Sir, thank you for your wonderful presentation. It was indeed a pleasure listening to you. Maybe we can take 2 questions from the house. 2 questions, if there are any.
Can you hear me? It's David De Cruz here.
Hello, David.
Excellent. Lauren, fantastic. A really good talk. I really enjoyed that.
Thank you very much.
One of the points that you raised was not to use drugs too early. Yes. And the question is, what do you mean by too early? As you know, colleagues around the world have been giving rituximab very early in the disease course, and they've shown reductions in cumulative steroids, cumulative suppressive agents. So this is a real challenge, and I agree with you. When is it too early?
That's really a talk about the challenges. So many questions remain open questions. In the context of rituximab, as you underline very, very well, we have data, but we don't have a randomized controlled trial that is fully validating this strategy. So I would be careful about the very positive result. I think there's very much a challenge about when to start these immunosuppressive treatments. What I was thinking is that too often, I would say maybe 10 times per year, I see lupus patients referred to me. They have very high levels of corticosteroids, 40 milligrams per day, 20 milligrams per day. And it's been like that for several years. And the rheumatologist in charge has always thought, oh, I'm going to manage to decrease, but it never happened. And so these patients, of course, they should receive immunosuppressive agents to help reducing the amount of corticosteroids. But on the other side, if it's a very minor manifestation, a first cutaneous flare, a first episode of joint pain, of course, we should start hydroxychloroquine, but this is an immunomodulating agent. But I'm not sure we should start immunosuppressive agents systematically as soon as the disease is active. That was really my point.
Thank you.
Can I? Yeah.
Yes, sir. Yes.
Yeah. Bonjour.
Bonjour.
This is Sapan from Ahmedabad. My question was the opposite of what Dr. Cruz asked. When tapering off medications in clinically silent cases of lupus, do you use serology also before tapering them off totally, number one? And number two, in cases who have relapsed once, do you continue hydroxychloroquine forever or you taper that as well?
Okay, those are very interesting questions. So this is something I've learned from many colleagues, is that you can help guiding the treatment based on serology, which is complement and dsDNA levels. I'd say that what matters the most are the clinical manifestations. And in that, I include common laboratory, such as cytopenia and so on, of course. So this is my main guide for tapering corticosteroids. But I always take into account the risk of flare, the risk of relapse, which is due to the combination of anti-double-stranded DNA antibodies and complement. I must say that now we can measure interferon alpha in the blood, and this is also a good predictor of following flares. So if it remains very high, I'm more careful about the tapering. But I would say I would guide my reasoning based on the clinical manifestations first. As your second question, relapsing patient and how to manage hydroxychloroquine. Actually, we have a survey, international survey, that has just been accepted. I think it will be online in the next few days. We sampled around 300 physicians, lupus specialists worldwide, and it shows that 70% of them are going on with hydroxychloroquine forever at the same dose, and around 25% of them only decrease the dose of hydroxychloroquine. Only 5% of them stop hydroxychloroquine when the patient has been in remission for a long time. This is really an area we need to research a bit more, I think.
Thank you. May I ask a simple question? So, is it possible to withdraw corticosteroids in a case of lupus nephritis who has gone into remission? So do you recommend?
Yes, I would recommend that. So, but it's a very good question and a very subtle question, I think. I think the target should be, after some times, no corticosteroids at all. That's a kind of general recommendation. But if the patient has had a very severe lupus, sometimes I think it's acceptable to leave a small amount of corticosteroids. The maximum is, which is okay for me, I talked about that before, is 5 milligrams. A patient, I'll talk later about neurolupus, a patient with a very severe case of neurolupus, maybe I will not try to remove completely corticosteroids. In the context of lupus nephritis, if it's a proliferative lupus nephritis that was non-severe, no renal insufficiency, like terminal something, I would try to remove corticosteroids completely.
Another question, sir. What is your take on avocapan steroid-free treatment, is it possible? What is
Yes,
your
well,
carry
that's
on that?
really, really interesting. Well, David De Cruz has clearly underlined that. So in some cases, you can use rituximab with very limited or no corticosteroids. We've published similar cases. And so everybody's, I think, is thinking about new strategies without corticosteroids. I can only tell you that I'd be very curious to see the results of a randomized controlled trial of avacopan in lupus. I'm waiting.
And
Hello.
how does artificial, sorry.
Yeah.
Please. You please.
Lauren, this is Olokendu Ghosh. It was a wonderful talk. Yeah.
Thank you very much.
So yeah, namaskar. What would be your technically quiescent but serologically very active lupus? So what would be your take in reference to immunosuppression, precisely steroids?
This is a very important question. I'd never change the treatment based on serology only if I have no clinical manifestation. If the patient has no disease activity and the serologies are changing, such as raising double-stranded DNA antibodies and complement going down, I warn the patient that a flare might be coming and that we should increase the follow-up. This is a case, for instance, where I increase the frequency of proteinuria check, for instance, but I do not change immunosuppressive agents just based on the serology.
And what is their practice in Paris? 0.5 milligram per kg vis-a-vis 1 milligram per kg in active lupus nephritis, like that, or hematology? Yeah.
So I think it's difficult to answer in a very general manner. What I would say is that before, especially for lupus nephritis, it was quite common to use 1 milligram per kilogram, especially if you had crescents. Now we are really trying not to go over 0.5 milligram per kilogram of prednisone, doing infusions before, like 500 milligrams times 3 or something like that. But in some cases, especially severe cases, for instance, a lupus patient in the intensive care unit, I'm not going to discuss about small dose. I go strong, of course, to save the patient when it's needed.
You prefer more with NIH or with Eurolupus protocol in lupus nephritis?
So it depends on the context. If you have a severe lupus nephritis with renal insufficiency, renal failure, then the only good level of evidence is for the NIH regimen. This is what I used. If you have a very moderate renal failure, then in most cases, or no renal failure, in most cases, I go for Eurolupus or MMF, which is widely available.
Thank you. Thank you very much.
Thanks to you.
So with a big thanks to the speaker and to the members in the House, I think we'll wrap up this very interesting session. Thank you, sir.
Thank you very much. It's a great honor. Thank you.
Thank you, Dr. Lauren, for that wonderful presentation. Next, we have APS, can we stop anticoagulation? We would like to re-invite Dr. Anisur Rahman for this talk. And may I invite Dr. P.P. Mukherjee and Dr. G.D. Chaudhary to chair the session, please.
So now we are going to a very interesting chapter. APS, can we stop anticoagulation? Now this is very important topic. Now most of the patients of this APS will also have this SLE together. So we have to know how we can manage these patients without anticoagulation. So with this, I just invite Professor Anisur Rahman to give his lecture. Yes, Dr. Rahman.
Hello, good evening from India.
Good evening from India, sir.
Hello?
Good evening.
Can you hear me?
Yeah, we can hear.
Okay, great. Well, thank you. This is my second lecture. I've been enjoying Laurent Arnaud's lecture. My friend Laurent, as you can see, can take on 10 challenges at the same time in a lecture, whereas I can restrict myself only to one challenge in this lecture. But it was quite a complicated challenge because it's not something I'd thought of before, and I had to review the literature. So I'm just going to share my screen now and start my talk. So, can we stop anticoagulation is the question. And here again is my disclosure statement, which I showed you before. Antiphospholipid syndrome, as I said previously, the commonest acquired cause of thrombophilia, a common cause of recurrent miscarriages, can be primary or secondary, but remember about 5% of healthy adults can test positive for APL, and it doesn't cause any clinical effects. And the treatment is essentially preventive. So we're trying to stop stroke or miscarriages and not treat symptoms. So this is where we come into this idea of, can we ever stop anticoagulation? Remember that the evidence said that after you've had a thrombosis, the treatment is long-term anticoagulation, and there was no safe time to stop it. That was the received wisdom in the past. The classification criteria I mentioned before, and I mentioned a positive test. So let's go to this slide, which again I showed before. And remember I told you that the systematic reviews in 2006 and 2007 all supported that anticoagulation was the only evidence-based treatment to prevent a recurrent thrombosis in APS, the only evidence-based treatment. And none of the studies showed that you could stop anticoagulation. A very famous early study by Munther, Kamashta and colleagues at St. Thomas's looked at the retrospective outcomes in patients with APS treated there. And what they found was that the highest risk of thrombosis was in the first 6 months after stopping anticoagulation. Remember, this was retrospective. They were looking at what they'd been doing in the 80s and 90s. So they really said, it's not safe to stop anticoagulation, and nobody has said anything different apart from that. So in patients who have had a thrombosis and remain positive for APL, there is currently no evidence to support stopping anticoagulation. And there is some evidence that thrombosis occurs after stopping anticoagulation. And can anybody do an RCT of this? So have a think about that. So you have a patient who's maybe had a stroke or a pulmonary embolus, they're on anticoagulation, and you ask that patient to consent to stopping the anticoagulation so that you can see if they have another stroke or another pulmonary embolus. How can you ethically consent somebody into a trial like that unless you have good reason to suspect that they won't get a thrombosis? None of the literature would support us doing that ethically in somebody who is positive for antiphospholipid syndrome, for antiphospholipid antibodies. So I can't see how they could do a randomized controlled trial which would be large enough to answer that question. So does that mean that forever in the future, everybody has to be on anticoagulation? I'm not saying that, and I'll come back to why that might not be in the end of this talk. But currently, because there's been such a lot of evidence over so many years that anticoagulation long-term is the treatment, it's very hard to see how you can get evidence to stop it in patients who are positive for APL. I'll just include one caveat to that, which came from the European League Against Rheumatism guidelines a couple of years ago, where they distinguished provoked from non-provoked thrombosis. It wasn't clear what the evidence was for this, but what they said was, if your patient with antiphospholipid antibodies had had a thrombosis, but there was a very good reason for it, for example, it was a thrombosis around an indwelling central line, or it was a thrombosis after a very long flight where they hadn't moved a lot, maybe under those circumstances, if they don't have a high risk profile, maybe then you could stop the anticoagulation. But I'm not sure what the evidence for that was. It was an interesting idea and I hadn't seen it before. But at the moment, the bottom line is, if you want evidence, you can't really find much evidence to say you can stop anticoagulation in people who have remained positive. But what about people who lose their antibodies? So there are a proportion of people who were positive and they were persistently positive. In other words, they fulfilled the criteria. They had 2 positive tests, at least 12 weeks apart. But at some point during the long-term follow-up, the antiphospholipid antibodies went away. And you can repeatedly test them and they're negative. Now, we think that antiphospholipid antibodies cause the syndrome. So if there are no antibodies anymore, why should we be treating these patients? Now, we have to be a bit careful with that whole argument, because it's possible that there are what are called non-criteria antibodies. The antibodies still exist, but we can't detect them with our current assays. And there are some of these non-criteria antibodies. The criteria, as set out by Miakis, only include IgG and IgM anticardiolin and anti-beta-2 GP1. IgA also exist, but they're not in the criteria. So it may be that there are antibodies that we're not measuring. So you've got to be a little bit careful about it. However, there is this group who become persistently APL negative. There are lots of potential benefits to stopping anticoagulation in terms of lack of side effects and so on, lack of risk of bleeding. So could we stop anticoagulation in these people, the people who seem to have lost their antibodies? So I reviewed this literature in preparation for the talk, and I found 5 studies, which I'm going to tell you about. Now, all of these studies have limitations. 4 of them are retrospective, only 1 prospective. All of them have relatively small numbers, as you'll see. 3 of them, including only patients with primary antiphospholipid syndrome and not people with lupus. All of them said there are some patients with lupus in which you may be able to withdraw anticoagulation. But remember, small numbers, retrospective studies. So the first study which looked at this was from Criado Garcia and colleagues in Cordoba in Spain. It was published in the Revista Clínica Española in 2008. This is the only prospective study. There were 6 Spanish patients with primary antiphospholipid syndrome. But if you look at their profiles, only 1 was lupus anticoagulant positive and most had low titer APL. So these were not the high-risk patients. They were slightly atypical. And only 1 had arterial thrombosis. They had been anticoagulated for a mean of 25 months, and then they stopped and they followed them for 21 months. So a short-term follow-up. None of the 6 patients had a recurrent thrombosis. So this is limited evidence. Only 6 patients, not high profile, low titer APL, relatively short follow-up, but they did all right. They didn't have a recurrent thrombosis. Now, the next paper is bigger. Now, this is a retrospective study from the famous group which deals with lupus and APS in Barcelona in Spain. So they had 263 patients in their database. And they looked back retrospectively at all these patients. And they said, these are our PAPS patients, our primary antiphospholipid patients. How many of them lose their antibodies? And they found 11, so 11 out of 263, a very small population, persistently became negative in APL. And of these patients, 7 of them had had clots before and they were on anticoagulation, and 4 had had only obstetric APS. And they had been treated for a mean of 8 years, 96 months. And so anticoagulation was stopped and they followed them for 20 months. Now, again, just like the Criado paper, there were no triple positive patients, no high risk, no arterial thrombosis. So these were lower risk type patients to start with. There weren't very many of them. There was a small number of patients, and only 7 actually had clots. But none of them had thromboses. So 2 papers now have said people who lose their antiphospholipid antibodies, you can stop the anticoagulation and they don't thrombose. But remember, so far we've only talked about 17 patients. Now, here's a third study. This is a French study now, and this is a multi-center study, not just one study. And they looked at patients with APS, and they were looking for anybody who had discontinued anticoagulants between 2014 and 2016. So in this case, they're not restricting themselves to primary APS, and they're not restricting themselves to people who have lost their antibodies. This time they're looking at all the patients in whom anticoagulants have been discontinued for any reason. And there were 44 of them. So what about these patients? 26 were primary, 18 had SLE as well. The median duration of anticoagulation was 21 months, and they followed them for 19 months. So you can see it's a similar sort of picture. Everybody's been followed for about 2 years. So now this study does have some of the high-risk patients. The other 2 studies from Spain I've talked to you about didn't have the high-risk patients. And this study has half with lupus anticoagulant. So here are the results from this multi-center study. The first important thing to take home is these were people who had anticoagulation stopped for lots of reasons, not just one reason. And overall, if you look at the bottom line of the table, there's a high risk of recurrent thrombosis, 25% risk, 11 out of 44. This isn't suggesting that stopping anticoagulation is something safe if you've got a 1 in 4 chance of a recurrent thrombosis. But there's a but here. It matters why you stop it. So you can see there are various different reasons for stopping it, like poor adherence and bleeding and so on. But right at the top, there were 10 patients who were stopped because they'd lost their antibodies. So it's not like the other two studies. In the other two studies, they were concentrating on people who'd lost their antibodies. In this study, that group is a minority, but it's a minority with a good outcome. Because of those 10 patients who became negative, only 1 had another thrombosis. So you can see that overall, the risk of stopping thrombosis stopping anticoagulation seems high. But in this particular group, the group which loses their antibodies, the risk seems to be a lot lower. The fourth study, another French study, but this is a single center in Lille in France. And it's just like the other study. This time, they're looking back at their patients, 210 patients. They're trying to find anybody who had anticoagulation withdrawn for any reason, not just because of loss of antibodies. And they found that 20 out of the 210, 1/7, had had the anticoagulation withdrawn. 20 of them were just withdrawn because they'd been followed up for a long time and they hadn't had another clot. 6 had non-adherence, and only 2 of this group had it withdrawn because disappearance of the antibodies. Now, this is a long follow-up. Remember, the previous follow-ups in the other studies were about 2 years. This is a maximum of 10 years. There's another thing they did in this study, which the other studies didn't do. They did a case control analysis. So they compared these people, the people who stopped their anticoagulation, with a matched group, matched by sex and disease duration and what type of thrombosis they have, who continued their anticoagulation. So this is like a case control study where we actually look at how safe it is to withdraw anticoagulation. So this is clever. This is different than the other studies. So what are their results? These results are not very favorable for stopping anticoagulation, because the risk of recurrent thrombosis was higher in people who stopped their anticoagulation, 7.3% per patient year versus 1.5% in the people who continued the anticoagulation. So almost 5 times higher, the hazard ratio of 4.83. So this study is saying in these 30, in the patients that they studied, 28 which were matched, they couldn't match 2 of them, stopping anticoagulation increases your risk of having a thrombosis by 5 times. 5 times, that's what they're saying. And what are the bad things, the things which make you really not want to stop anticoagulation? Male sex, triple positivity, anti-beta-2 positivity. These were associated with risk of recurrent thrombosis. So again, the 2 French papers are bad news for stopping anticoagulation. They both suggest a high risk of recurrent thrombosis. But both the French papers leave open the possibility that these people with negative antibodies could be a favorable group. And why do I say that? So there are 30 patients, remember, who stopped their anticoagulation. 17 of them didn't have another thrombosis. 13 of them did have another thrombosis. And if you look, 7 out of the 17 who were okay had disappearance of their antiphospholipid antibodies. So again, there's this hint that if people lose their antibodies, it might be safe in those people. And lastly, the most recent paper is from Margherita Zen and colleagues, and she's working at a very famous lupus center in Padova in Italy. Now, this center has been following lupus patients for 50 years, for half a century. There are not many places in the world which can give you data from half a century of lupus patients, but these guys can. So they published on 513 patients followed in their cohort. 135 of these patients had been positive for APL antibodies at some time, and 58 of them, 11.3%, had APS. So this is a paper about the APS patients. And this is how they broke it down. From the 58 antiphospholipid syndrome patients, 55 had thrombotic APS, 3 had obstetric APS. The 55 thrombotic were divided into 36 who persistently had positive antibodies, 16 who became persistently negative. So you can see all the time we're breaking it down to really, really small numbers. In the Criado paper, there were 6 patients. In the paper from Barcelona, there were 11 patients. In the last paper I talked about in France, there were 7 patients with negative APL. These are really small numbers. It's a really small population of patients. So in this case, there are 16 persistently negative patients. 3 they weren't sure because he didn't have lupus anticoagulant. So these 16 persistently negative patients in this retrospective study, 3 continued oral anticoagulants and 13, this is the study group, discontinued oral anticoagulants and started aspirin instead. And in most of the papers I've shown you, the people who discontinued anticoagulation started aspirin. They didn't leave them with nothing. So the paper is about what happens to these 13 patients who've got negative antibodies and discontinue anticoagulation and take aspirin. None of them had a thrombosis. None of them had a recurrent thrombosis over the follow-up period. So this again suggests a possible safe group, the group who lose their antibodies. The likelihood of becoming persistently negative was higher in those who had had immunosuppressants, but lower in the high-risk triple positive group or anybody who had APS before SLE. So the conclusions. There are no randomized controlled trials to say whether you can discontinue anticoagulation in patients with APS who continue to have the antibodies. And there are not likely to be any controlled trials like that because you could not, based on the evidence I've just shown you, particularly from the French studies, you could not ethically consent a patient to say, stop anticoagulation and take aspirin and we'll see what happens. We'll see if you get a stroke. I don't think you could do it. You could do it, though, if there was an alternative therapy which you thought might be as good. So you remember I showed you the papers in my earlier talk where they randomized to warfarin or DOACs. Okay, so that was ethical because there was a possibility that the DOAC group would have been really good. And there are lots of other therapies which are kind of in development. For example, for anti-complement therapies, antibodies to peptides of beta-2 glycoprotein 1. If these therapies come to clinical trials, it would be ethical in principle to randomize people to anticoagulation versus one of those alternative therapies. It might be possible to do that. So we might see in the future something which is an alternative to anticoagulation. The 2 French studies I showed you suggest that anticoagulation should be continued. And if you discontinue it, overall, there's a high risk of thrombosis. One said a 1 in 4 risk of thrombosis, remember. And the other said there was a 5 times increased risk if you discontinued anticoagulation compared to continuing it. But all the 5 papers I've showed you leave the door open to the fact that people who have persistently negative antiphospholipid antibodies may be a group in whom discontinuation could be safe. And I think that now, having reviewed all this information, if I have a patient in this situation, I could say to them, look, there's not much evidence of it, but there are 5 papers, all of which had small numbers of patients in, and we're talking about usually less than 20 patients in each paper. And those people who had negative antibodies did not get thrombosis. The vast majority of them did not get thrombosis. And then it's a question of talking to the patient, because it's the patient who's taking the risk, not me. And all the other individual risk factors may be taken into account. So, for example, if I had a patient who had become negative, but, for example, they were also a very heavy smoker, they were maybe very overweight, they had other reasons that they might get a thrombosis, I would be less likely to discontinue anticoagulation in that person. And the last thing I would say is, of course, we all have patients who do it by themselves. They stop anticoagulation by themselves without us telling them to. And sometimes you're in a situation of, should we restart it? If they come back to you after 5 years and nothing has happened to them, do you restart the anticoagulation? And in that case, checking the antiphospholipid antibodies to see if they are negative or positive might help you with that decision. So my take-home message is, overall, there's no good evidence supporting discontinuation of anticoagulation, but there is a small group, a group in which the antibodies become persistently negative, where there is an increasing amount of data suggesting that it might be safe to discontinue in those people. Thank you.
Thank you, Dr. Anisur Rahman. In fact, I have been listening him for the last 4 to 5 years in this Lupus Meet. And most important part of his slide presentations is that he put a questions and then gives the clarifications. So whatever normally comes in our mind, they are all been answered. In spite of that, if there are any questions to be asked, the floor is open.
David
Yes,
Cruz here.
Molly?
David Cruz, can I?
Yes, Dr. David.
Hello, yes. As always, Anna, so a very lovely talk. So the caveats are all there. These are small studies, mostly retrospective. But I'm just wondering if it was possible to dissect out the possible effect of hydroxychloroquine. So in other words, did these patients carry on hydroxychloroquine, and did that contribute to a lower risk of thrombosis in these patients? It may not be easy to dissect out, but we know that hydroxychloroquine has a powerful, relatively powerful antithrombotic event. And I just wondered your comments on that.
Yeah, I mean, because the data were they're in such small numbers of patients, they couldn't do that statistically. I can't remember off the top of my head how many people were on hydroxychloroquine in the studies. Remember that most of the studies were primary APS, so they may not have been on hydroxychloroquine anyway. It was not a feature that they brought out in the discussion that hydroxychloroquine could have been helpful. But aspirin, they were on antiplatelet. They didn't leave these guys with nothing. I have to say, David, there's an irony about you and I sitting in London talking to each other on a Zoom conference in India.
It is.
Another without sweater.
Sir, I have a question. In a typical patient with APS, how frequently would you do antiphospholipid antibody testing? Because the facility is not very commonly present, and money is also an issue for most of our patients, especially. So in a lifetime, how many would you advise before you call them persistently negative?
Yeah, that's a really, really good question. And David may have a different answer to me because he works in a center which is very well known for antiphospholipid syndrome. Now, I was somebody who was not very keen to repeat these tests in general because I thought, what difference will it make? We're just going to continue the anticoagulation forever anyway. So why am I repeating the test? It won't change my management in any way. And if I was working in a system where people had to pay for their tests, as I think they do in India, then I wouldn't put the patient to that extra expense when it wasn't going to change my management. Now, there are other organizations, I think the Padua one and others, who do it yearly. They test the antibodies yearly and they keep a record, maybe for research purposes, or maybe because they think it's good practice. I hadn't seen the point of it if you weren't going to change the management of the case. Now, having read these papers, if there were a possibility of stopping people's anticoagulation if they became negative, I could see the rationale for that. My answer to your question personally is that I don't do it routinely at frequent intervals. I don't do it yearly. There are many patients under my care who they had it done in the beginning, and I haven't done it for years and years. But I know that my hematology colleagues, people in the blood department, often do repeat the phospholipid antibody tests every year or every 2 years. So I'm kind of changing my mind. I used to never do it because I didn't see any point in it. And now I'm more inclined to do it perhaps every 2 years or so. And I don't know what David does in his practice.
I think like you, Anna, sir, I did exactly that. Somebody comes along with a clear diagnosis of APS, positive on 2 separate occasions, and I wouldn't repeat the testing. But I think like you, I'm coming to the idea that, if the winds are in your favor and maybe you might change treatment, I will test them again. But it's not a systematic testing. I know Michelle Petrie, for example, tests every 6 months, I think, but I suspect that's mostly for research purposes. And Beverly Hunt in our department does repeat them reasonably frequently, perhaps every couple of years like you. So it's a moot point, yeah.
But I think you make a very good point, the question about what if it costs money So it actually costs money to do these tests. In our hospital, they tell us how much money it costs. They actually have said us, they don't make us pay for it personally, but they tell us how much it costs. And it's not a trivial amount. And if a patient is having to pay for it, I don't think you can justify it unless you're going to change the management on the basis of the test.
Yeah. Is Aman Sharma still online? I just saw. I hope
Yes, I am.
wanting to ask a question.
No, no, I'm fine. I'm just enjoying the deliberations. And my hi to Anis sir and David De Cruz and everybody else.
Excuse me, sir. I had a question. So my doubt is in a patient.
Just take your mask for a
Yeah, sure.
Yeah.
My question is in a patient with a history of intracranial vein thrombosis. So is it safe to stop with triple positivity? So is it safe to stop anticoagulation? And in the studies you quoted, sir, any such cases they have mentioned where the anticoagulation has been stopped and any adverse effect of recurrent thrombosis in these patients?
I'm really sorry, I didn't hear the question clearly. Could somebody repeat it slowly for me?
Yes, sir. I'll repeat. So, in a patient with a history of intracranial vein thrombosis and he is triple positive, is it safe to stop anticoagulation even if the patient is asymptomatic after a good years of treatment? And have the studies what you've quoted before, have they done any, have you have any information on those patients who had a history of intracranial vein thrombosis and on whom the anticoagulation has been stopped?
Okay, so essentially triple positive patients seem to be a group that, so the data only supports withdrawing anticoagulation in people who have become negative, and people who have been triple positive are very unlikely to become negative. So I don't think I would favor stopping anticoagulation in somebody who at any point in their life had been triple positive, because the triple positive patients are a very high risk group. So I would be very, very reluctant to stop anticoagulation in somebody who had ever been triple positive. And those people are really unlikely to become negative in all the assays.
Sir, please close.
Okay.
Anyway, yeah.
Yeah,
My
question was in continuation with what Cruz asked. In fact, that was the question I wanted to ask. But if I understood correctly, one of your penultimate slides, you said that it's in that study showed that it was difficult to stop anticoagulation in patients who had APLA first and lupus manifestations later. Is that one way of saying that either immunosuppression or hydroxychloroquine in those patients worked and that you were able to stop in those lupus patients?
To be honest, what the study showed was that the people who had APS first were very unlikely to become negative for the antibodies. It wasn't that they were less likely to be able to stop the anticoagulation. What they were saying is, in the really small number of patients, and remember there were 16 of their patients out of 530 altogether, in the very small number of patients who became negative for antiphospholipid antibodies. So I should say they had 135 who were positive at some point. 16 became persistently negative. And they said those people were very unlikely to have had APS before SLE. Anybody who has APS before SLE, according to the Italian study, is not likely to lose their antibodies. Just as I said, people who are triple positive are not likely to lose their antibodies. That was what the paper said. So it's really a question of repeating the antibodies. I think the take-home message is not that you can work it out by who has hydroxychloroquine or who had APS first. The only way you can identify this group in whom it might be safe to stop is by repeating the antibodies and showing that they are negative and persistently negative.
Arudha, anything?
So if there is no other question, we are going. So we are going to close this nice session. Thank you all.
Thank you, Anisu. Thank you, Dr.
Bye.
Thanks, Alison.
Next up, we have Dr. David De Cruz, who will be speaking on learning lupus through atypical clinical challenges. May I invite Dr. Arup Kumar Kundu and Dr. Parthu Sarkar to chair the session, please?
Ma'am.
Good afternoon, everybody. Now there is a novel topic entitled Lupus, Learning Through Atypical Clinical Challenges, and which will be dealt by none other than David De Cruz. He is the consultant rheumatologist of Louis Coute Lupus Unit, the Guy's Hospital, London, and he is the team leader of the autoimmune diseases which deals with systemic vasculitis, APLA, and SLE. His research portfolio includes a translational medicine program in collaboration with Basic Sciences laboratories in the Division of Immunology, Inflammation, and Infective Diseases, King's College School of Medicine. Dr. Professor De Cruz, please.
Well, thank you very much indeed for the introduction. And as always, it's an honor and a pleasure to speak at this Lupus Meet in Kolkata. I'm just checking, can you see my slides?
Yeah.
Johan, okay, good. So I've subtitled this talk, Lupus and the Art of Clinical Medicine. And here are my disclosures. So I'm just going to talk a little bit about history. William Heberden lived in 1710 to 1801. By coincidence, he was born in Southwark in South London, which is actually where I work now. It's the site of Guy's Hospital. And William Heberden, as you all know, was one of the very famous physicians of that century. He was known as the last of our learned physicians. And his legacy extends to our current time. His legacy was the excellence in the practice of medicine, the art of observation and critical assessments of those observations, and above all, compassion for his patients. Now, actually, William Heberden was well ahead of his time. In that time, physicians had a tradition of concocting their own potions and medications to treat their patients. And one of Heberden's potions, known as Heberden's ink, Mr. Ferri aromatica, actually was based on the bark of the cinchona tree, cinchona leaves. And as you all know, hydroxychloroquine is derived from quinine, which comes from the bark of the cinchona tree, which was used by the Incas to treat fevers, used to treat malaria for decades, and is now widely used to treat lupus and rheumatoid and many other diseases. So this whole meeting is about lupus, and there's no need to talk too much about this slide. These patients can present with mild, moderate, or severe disease. So learning lupus through atypical clinical challenges, as Laurent said and many others have said, if you understand lupus, you can certainly understand medicine. So this is a very clinical talk. I'm going to just talk about 3 patients who I've looked after over the years, illustrating complexity, diagnostic uncertainty, patient factors that have governed outcomes, and risks of investigations. So the first patient is a 35-year-old secretary. Age 17, she developed the first signs of her lupus with joint pains. Age 19, she had pleuritic chest pains and probably serositis. She was negative for pulmonary emboli. Her investigation showed a high CRP, high ESR, positive lupus test, ANA and anti-D antibodies, but normal complement at the time. And from the very beginning, she had positive IgM and IgG anticardiolipin antibodies. She was diagnosed with lupus and was then referred to our unit. On further questioning her, she had a clear history of photosensitive rashes, fatigue, alopecia, migraines, intermittent joint pains, and ongoing pleuritic chest pains. She was single, a non-smoker, no previous thromboses, no previous pregnancies, and the family history was highly relevant. Her father died at the age of 38 from lupus, and he died from renal and cardiac complications. When I examined her, she had macroscopic nail-filled loops. She did have Raynaud's phenomenon, mild synovial thickening, extensive livedo reticularis, a soft pleural rub at the left base, normotensive, and urinalysis was negative. So he was given a single intramuscular depomedrine injection and started on hydroxychloroquine and aspirin, and she did pretty well. This was a chest X-ray showing some blunting at the left costophrenic angle, indicating a very small pleural effusion compatible with serositis from lupus. Subsequent history, she developed a pneumonia, requiring a critical care admission and a tracheostomy. A few years later, she developed quite severe hypertension. An echocardiogram showed left ventricular hypertrophy and mitral regurgitation. Hypertensive was rather difficult to control. An MR angiogram did not show renal artery stenosis, which we've described before in APS, and she required doxazosin and bisoprolol, but she couldn't tolerate ACE inhibitors. So as time went on, she had more and more lupus flares, rashes and arthritis, but in 2008, she first started to develop neurological symptoms, pyramidal signs, increased tone, brisk reflexes, but downgoing planters. She had a mild expressive dysphasia and mild ataxia. She was on, at that time, prednisolone and azathioprine. She had positive anti-DNA antibodies, but normal complement, and we admitted her for investigation of these new pyramidal signs. So the imaging was quite clear. It showed established cortical infarctions and small vessel disease on cerebral imaging. This is a cerebral MRI scan indicating a cerebral vasculopathy. The neurologist investigated her. She had a lumbar puncture, which was normal, negative for oligoclonal bands, but the EEGs showed, and she had a few EEGs over the years, she had frontotemporal theta waves, which have been described in association with cerebral ischemia. And we wrote up a series of patients with APS and this abnormal pattern of EEGs indicating cerebral ischemia. By this stage, she was triple APL positive, lupus anticoagulant, anticardiolipin antibodies, and beta-2 GP1. So she now clearly has antiphospholipid syndrome with these cerebral manifestations. She was commenced on warfarin with a high target INR 3 to 4. So a few years later, she was fairly well. She was planning pregnancy, obviously going to be a high-risk pregnancy, so she was counseled very carefully by myself and the obstetric physicians, and the suggestion was to continue warfarin until the pregnancy test was positive. During that time, she had some chest pain, and investigation showed mild reversible cardiac ischemia, and she was started on nitrates. She had a long-haul flight to, I think, America, and at that time she had a low INR, and she suffered a deep vein thrombosis. So a few years later, she was quite keen to conceive, and after a lot of discussion, rather than carrying on warfarin and switching her to heparin when she commenced pregnancy, we decided to switch her to enoxaparin. Her periods were regular. She had normal female hormones. The problem was, on heparin, she started to have progression of her neurological deficits, slurred speech, ataxic gait, and dysdiadochokinesis. And the imaging showed progression of the bihemispheric cortical infarctions. You can clearly see them delineated by the yellow arrows. So this is progressive cerebral ischemia on heparin at a treatment dose. For reasons that are not clear, she was treated with methylprednisolone. She did have positive serology for lupus and a few lupus symptoms, and I think she wasn't under my care at this time. I shared her care with a colleague in the district general hospital. Warfarin was restarted. She was given the methylprednisolone. The azathioprine was switched to mycophenolate, and her neurology improved. The cerebral manifestations, however, impacted severely on her quality of life. She did become pregnant, but unfortunately miscarried, and at that time she had a transient ischemic attack. A year later, she had a lupus flare-up. So at this stage, she was being looked after by my colleague in a local hospital. She was admitted to the A&E department, and she was given methylprednisolone to treat the apparent lupus flare. And immediately after the methylprednisolone, she had a grand mal seizure, bit her tongue, and she was postictal. And this was almost certainly the seizure related to hypertension aggravated by the methylprednisolone. At the time, she had renal impairment and proteinuria, and you can see that between 2002 and 2014, her renal function deteriorated and her protein-creatinine ratio increased. So here we are faced with a young woman who clearly has got lupus. She had evidence of cerebral involvement of the lupus. She's clearly had lupus nephritis. She had antiphospholipid syndrome with imaging evidence, at least, of a thrombotic microangiopathy, cerebral involvement, cardiac involvement, and renal involvement. I'll come back to the cardiac involvement later. And she was hypertensive with an encephalopathy that was probably aggravated by the methylprednisolone. So a very complex clinical problem. I have to say, she was a very perceptive patient, and she kept saying to all of us, Doc, it's not my lupus. This is my antiphospholipid syndrome. She was very perceptive, and she was absolutely spot on. So she was admitted. She was transferred to our care after those seizures. She was very hypertensive. She had extensive livedo reticular. She had a mitral murmur. Fundoscopy showed hypertensive changes, and she had ataxia, dyspraxia, and a cerebellar scanning speech. The neurology was pretty clear-cut. She had increased tone, normal power, very pathologically brisk reflexes, an upgoing plantar on the right, positive Hoffman sign, and clonus at the ankles. So extensive evidence of cerebral involvement. There was no evidence of transverse myelitis at this stage. So her numbers were in keeping with her clinical picture. She had renal impairment. She had evidence of cardiac involvement with a high troponin and high BNP. She had an elevated CRP, although she wasn't septic, and a very high ESR. Her INR at this stage was 4.8, so well within or just above the therapeutic range. Here was ECG, which confirmed left ventricular hypertrophy from her long-standing hypertension, which was difficult to control. In terms of the heart, she underwent a cardiac MRI scan, which showed clear evidence of Libman-Sachs endocarditis. You can see the vegetations on the mitral valve on the cardiac MRI scan, and she's had a myocardial infarction. There's an inferolateral myocardial scar on the cardiac MRI scan, compatible with the elevated troponin and the BNP. Despite intensive treatment, you can see between 2008 and 2014, she had progression of her cerebral imaging changes with bilateral parietal occipital lobe infarctions. This is the EEG. This is one of many EEGs, which showed these left temporal sharp waves, which have been associated with cerebral ischemia, and this confirmed her susceptibility to focal seizures. So the current problems we were facing as an inpatient: uncontrolled hypertension, worsening neurology, previous seizure, cardiac ischemia, acute kidney injury and proteinuria, and she was anemic, and her INR was very difficult to control. It was all over the place. You can see here the acute episode with renal impairment, protein-creatinine ratio, which did come under control with an ACE inhibitor, and DNA binding remained positive throughout. It never became negative. So the differential diagnosis here was antiphospholipid syndrome. There was no doubt about this diagnosis with cerebral, cardiac, renal involvement. Her lupus seemed stable, at least clinically. She had few symptoms. And we had a lot of discussions with the renal physicians, and we came down on the side that the renal biopsy would be far too risky. And the primary aim of treatment was controlling her blood pressure and maintaining her anticoagulation in the therapeutic range. Despite all this, she had another myocardial infarction, and an angiogram showed small vessel occlusion in the right coronary artery. And again, and I didn't agree with this, my colleagues in the local hospital gave her high doses of prednisolone, and again, not surprisingly, she became hypertensive and had 2 further seizures with the prednisolone. Sodium valproate was added. So she gradually improved, but she's now, and so between 2015 and 2021, I saw her last year virtually during the pandemic, and she is very disabled. Despite anticoagulation, her neurological deficits have progressed, and she's now quite disabled with quite a poor quality of life, and she's just in her mid-40s now. So what did I learn from this patient? I learned, listen to the patient. She kept telling all of us, this is not my lupus, doc. This is my antiphospholipid syndrome. And actually, with the retrospectoscope, she was spot on. The key treatment here was controlling the blood pressure with anticoagulation, avoiding steroids. And as everybody has said in this meeting, there's a great temptation when you're faced with a complex patient with lupus to hammer them with high doses of steroids. And in this case, it was actually very deleterious. The methylprednisolone and the high doses of steroids triggered the hypertension or worsened the hypertension and triggered seizures. So that was her. The next illustrative patient was when I first met her. She was 25. This is now 20 years ago. She was a journalist for one of the major newspapers in the UK. And she presented with lupus, with a photosensitive rash, symmetrical inflammatory polyarthritis, and oral ulceration. She had a positive ANA, strongly positive anti-DNA antibodies. She was Rho positive, hypercomplementemia, negative antiphospholipid antibodies. And from the first visit, she had low-grade proteinuria. Eventually, she had a renal biopsy, which showed class 4 lupus nephritis. She was treated with methylprednisolone and mycophenolate and did very well. She went into remission. She was thinking about a pregnancy, so the mycophenolate was switched to azathioprine. After a few years, the patient stopped the azathioprine of her own accord because she said, I'm doing very well. And indeed she was. She had no symptoms, and she was on a tiny dose of steroids and hydroxychloroquine. Over the next few years, her disease course was characterized by recurrent renal flares, and each flare was managed with methylprednisolone and mycophenolate in varying doses. We did offer to do a repeat renal biopsy, but she declined. Eventually, she did come under control on azathioprine. She had a healthy baby boy. She had peripartum hypertension, which was controlled, and postpartum, she did have a renal flare, and mycophenolate was restarted. The proteinuria continued and her renal function started to deteriorate. So she eventually agreed to have a repeat renal biopsy in 2013. And this again showed a class 4 lupus nephritis, but this time with crescents, fibrinoid necrosis, and perhaps not surprisingly, hypertensive changes. So given the progression of the disease, we stopped the mycophenolate. And in fact, this was just after pregnancy. So we gave her urolupus cyclophosphamide, 500 milligrams fortnightly for 6 doses with a very good response. So this was her disease course. You can see here right at the beginning, she had a flare. She stopped the mycophenolate, switched to azathioprine, had the pregnancy, then had another flare up. And then further down the line, she had another flare up. And this is when we gave her the urolupus cyclophosphamide. Now, the bottom line is very important. You can see that throughout this time until 2010, she had good renal function. But from around 2010 onwards, she started to lose renal function and had significant renal impairment. And that was one of the factors why we progressed to urolupus cyclophosphamide. Now, this lady is now in San Francisco. She emigrated there because her husband moved there for a job, and she got another job in journalism. Just before she left, she had a confession. She said, "Dr. De Cruz, all those times you admitted me to hospital because of the renal flares, actually, it was my fault. The reason I was flaring was because I stopped all her treatment, because I was doing very well. I didn't tell you that I'd stopped the treatment, but she stopped the treatment nevertheless." So you can see the consequences. And as Laurent Arnaud very elegantly said, medication adherence is a big issue here, and you can see the consequences here. And she told me before she left for USA that she felt very guilty about stopping her medication because she's now left with chronic renal impairment. So in summary, this particular patient, recurrent renal flares that were directly attributable to medication non-adherence by her own admission, which has resulted in hypertension and renal impairment. Just a couple of points from the maintained lupus nephritis trials, which we were involved in. A subsequent analysis by Frederick Husio showed that if you look at proteinuria at 3, 6, or 12 months, if at those time points, 3, 6, and 12 months, your proteinuria is less than half a gram, your long-term prognosis is excellent, compared to if you have persistent proteinuria greater than half a gram, your chances of doing poorly are greatly increased. Subsequent studies, this was a review by Maria Dalla Era of our data from the urolupus trials, showed that actually it's not half a gram, it's actually 0.8 grams at 12 months predicts long-term outcomes. So if you have less than 0.8 grams of proteinuria at 12 months, you generally have quite a good outcome in the long term. So what are the poor prognostic factors in lupus nephritis? These are all very well known from the literature: African ancestry, poor socioeconomic status, severe initial presentation, severe pathological changes on the biopsy, poor blood pressure control. That should be number one, I think, poor blood pressure control, recurrent renal relapses, as in our patient, delayed response to therapy, poor medication adherence, and comorbidities. So medication adherence is a huge problem in the whole of medicine, not just lupus and rheumatology. And medication non-adherence rates can be anything from 45% to 64%. There's two types of non-adherence. There's intentional non-adherence. In other words, the patient very politely says, "Thank you very much for my hydroxychloroquine and mycophenolate." They go out the door and they put the prescription in the bin, and they have absolutely no intention of taking your medication. The other more common type of non-adherence is non-intentional, and there are many reasons for non-intentional non-adherence. So they don't understand the treatment. These are very complicated diseases, and trying to explain different treatments to different patients is quite tricky. Patients are fearful of adverse effects. Young age is a major contributor to non-adherence. We all know, I run a pediatric lupus clinic at the Ebolina, and this is a huge problem. The 14, 15, and 16-year-olds just don't understand. They don't, they haven't understood the disease, and they have a high rate of non-compliance. And complex treatment regimens. So you turn up to the nephrologist on hydroxychloroquine, you have a biopsy, and you leave the nephrologist room with steroids, mycophenolate, ACE inhibitor, and a whole bunch of other drugs. They might walk out with about 10 different drugs. So it's not surprising that non-adherence is high. And then there are others that say, well, the medication's not working, so I'm going to stop it. So here's a fearsome paper, just compounding the issue, but clarifying the issue even more clearly. This is a Medicaid population, drug dispensing data on prescription refill data from California. So adherence to azathioprine in the first year in a huge study, 2,000 patients, 17%, only 17% took azathioprine as prescribed. And mycophenolate was just as bad. Only 21% of patients took mycophenolate as prescribed, and most of these patients had lupus nephritis. So it's really not surprising that we're seeing patients with relapses and progression to renal failure. So non-adherence to therapy is difficult. Patient education is clearly important, but it's very resource intensive. And as Laurent said, we now have the ability to measure drug levels. So we now have access to measuring mycophenolic acid levels and hydroxychloroquine levels. And I'm sure Nathalie Costa-Chalamet and Laurent, you see these patients, they are absolutely adamant that they are taking their drugs, and you just say, well, I'll just check your levels, and they come back zero mycophenolate and zero hydroxychloroquine. And the patient scratches their heads and say, I don't know how that could be, doctor. I'm taking all my medications as you prescribed them. So this is a really difficult issue. Okay, so my last patient is a 32-year-old gentleman who worked, when I first met him, was working at a major hospital, and he presented at the age of 11. So he was a juvenile onset lupus in 1993, acute onset of lupus, lower motor neuron facial palsy, skin rashes, liver dysfunction, positive ANA, DNA, low complement, but negative antiphospholipid antibodies. Biopsy at Great Ormond Street Children's Hospital showed class 4 lupus nephritis. It was obviously a very active disease, so they plasma exchanged him in the early 1990s, gave him methylprednisolone, and he was failing to respond to that treatment, so they gave him 2 months of oral cyclophosphamide, which is fairly heroic for a young boy, and that was switched to azathioprine. This young man continued to have relapses. At the age of 13, he had another lupus nephritis flare, again treated with methylprednisolone and intravenous cyclophosphamide, and then between 1996 and 1999, he was treated with azathioprine. After a second renal biopsy, which again showed class 4 lupus nephritis, that biopsy was complicated by septic shock with E. coli, and then he was started on mycophenolate. A year later, he had a nephrotic flare with hypertension. His third renal biopsy showed class 4 and class 5 lupus nephritis, and he was continued on mycophenolate, and cyclosporin was added, and he went into remission. He had another flare a year or two later, again, high DNA, low complement, methylprednisolone, 2 shots of cyclophosphamide, and then mycophenolate was restarted, and the cyclosporin dose was increased. He was then transferred, he then transitioned to our unit. This was now 20 years ago, and we saw him in our joint renal clinic. His lupus was stable. He had osteoporosis, not surprisingly, from all the steroids that he'd been having, and he continued to have E. coli urinary tract infections. There was a family history. His brother, so RR is our patient, AR was his brother, who also had lupus nephritis and end-stage renal failure, and had a transplant from their father, which was quite successful. So by 2004, he had rising proteinuria, increasing creatinine, increasing hypertension, and for the first time, he became positive for antiphospholipid antibodies, cardiolipin antibodies, and the lupus anticoagulant. So in discussion with the nephrologist, he had a 4th renal biopsy showing class 4 lupus nephritis, and this time, for the first time, he had a thrombotic renal microangiopathy. And we commenced him on warfarin with a high target INR. We treated the lupus aspect with urolupus cyclophosphamide. Despite this, his proteinuria continued, his creatinine continued to rise, his hypertension was difficult to control, and he had yet another biopsy, his 5th, under the renal physicians, which again confirmed a class 4 lupus nephritis, active disease, and another evidence of thrombotic microangiopathy. This time, after his renal biopsy, he had a large perinephric hematoma. He was admitted to our hospital with a hemoglobin of 38, requiring lots of blood transfusions and a laparotomy for the perinephric hematoma, and the wound dehisced. At this stage, he was treated with rituximab, more urolupus cyclophosphamide. Warfarin was restarted after he stopped bleeding, and his creatinine definitely improved, and his blood pressure came under control. So a few years later, he had, again, rising creatinine, dropping albumin, rising proteinuria, and the warfarin was stopped. And for reasons that are still not clear, the nephrologist insisted on doing his 6th renal biopsy. which showed class 3 lupus nephritis, activity 5 out of 24, chronicity rising now 4 out of 12, and fibrous intimal hyperplasia, but no obvious renal thrombi were seen. Soon after the biopsy, he was hypotensive, had abdominal pain, and was admitted to the critical care unit with pulmonary consolidation and a huge right perinephric hematoma, which I will show you. And that kept on bleeding, and he required coil embolizations to that bleeding point in the right kidney. So here you can see the little bit on the yellow arrow here, you can see the point, the bleeding point. You can see the needle track here from the renal biopsy, and you can see this absolutely massive hematoma. This was the coil embolization here, which successfully stopped the bleeding. At this stage, he was very hypertensive, and he had a hypertensive encephalopathy. He had PRES with seizures, and eventually came under control with antihypertensive therapy. The problems with the kidney continued. That big hematoma caused a right renal infarction, and you can see the hematoma here. And then he became infected. So that hematoma extended and then became infected, and the pus extended into the paracolic gutter, and several attempts by the interventional radiologist to drain that was unsuccessful. So he had a long admission between April and December, requiring a filter. He had further episodes of bleeding, PRES, infected collection, paracolic collections. Into the mix, he had cholecystitis and gallstone pancreatitis. His nasojejunal tube eroded, resulting in a duodenal peritoneal fistula, and he had lots more episodes of neutropenic sepsis and MRSA. Eventually, the urologist decided enough was enough, and he had a right nephrectomy. And after that, he didn't look back. So this patient illustrates this difficult clinical scenario of a young man presenting with undoubted biopsy-confirmed lupus nephritis, but clearly then developed antiphospholipid syndrome with an APS nephropathy, a thrombotic microangiopathy with thrombosis and ischemia. And the treatment, obviously, of these two conditions is immunosuppression versus anticoagulation, depending on what the predominant clinical or pathological problem is. So Graham Hughes, many years ago, when he first described the syndrome, reported labile hypertension in connection with livedo reticularis. We and others have shown that hypertension in these patients is associated with renal artery stenosis, and it's a smooth mid-portion renal artery stenosis here. It's not atherosclerosis. You can see it on the MRA and the arteriogram. And this is a study from the Europhospholipid group. In 1,000 patients with antiphospholipid syndrome, 2.7% had APS nephropathy, characterized on biopsy by glomerular thrombosis, renal infarction, renal artery thrombosis, and renal vein thrombosis. This is almost certainly an underestimate. In order to make the diagnosis, you need to do a renal biopsy. So this is almost certainly an underestimate of the prevalence. Maria Tectonidou has described some criteria for APS nephropathy, at least one of the following: either acute thrombotic microangiopathy lesions or chronic lesions, fibrous intimal hyperplasia, organized thrombi, fibrous arterial or arteriolar occlusion, or, as in this patient of ours, subcapular zone infarction with fibrous cortical atrophy. So quite a big spectrum of APS nephropathy. So what are the risks of renal biopsy? I think our young man has illustrated them very clearly. There are definite risks to renal biopsy in these patients. Here was a young Asian woman who presented with a bleed. You can actually see the renal biopsy tract here, and you can see that she's bled not once, but twice. You can see 2 hematomas here. So we looked at our series of patients, and we had some very serious adverse effects of renal biopsy in our antiphospholipid syndrome patients. One patient sadly died. 2 patients, of which one I just presented, had nephrectomies to stop the bleeding and or sepsis, and there were 8 perinephric hematomas requiring transfusions or embolizations. So Natasha Jordan looked at our patients. This is our database of 215 percutaneous renal biopsies in just under 200 lupus nephritis patients. She divided the groups into 3 patient groups: those with lupus alone, those with lupus and APS, either thrombosis or obstetric APS, and those who had lupus but just antibodies, so no thrombotic manifestations or pregnancy morbidity, so just the antibodies with lupus. And she asked a simple question in all these patients who had undergone renal biopsy: what was the complication rate? In particular, what was the bleeding complication rate in these 3 groups of patients? So I guess not surprisingly, so these are the lupus patients alone, 80 patients, and only 1% of them had bleeding complications, which is what we tend to counsel our patients about. But those patients with antiphospholipid syndrome and those patients with antiphospholipid antibodies, but no syndrome and not an anticoagulation, also had a similar rate of significant bleeding after renal biopsy. So remember that these patients with APL alone were not anticoagulated. So was this a problem that we weren't following the anticoagulation protocols? In other words, we weren't stopping the anticoagulation before doing the renal biopsies? That was not the case. So the interventional radiologists who do our biopsies insist on having a clotting screen on the day of the biopsy. And you can see here that the clotting screens in all the patients were all around 1. So we'd followed the protocol absolutely to the T. And you can see that there was no correlation with bleeding or no bleeding with the INR, which was all normal on the day of the biopsy. So there's something else going on. So we then asked the question, was there a correlation between the finding of a thrombotic microangiopathy on the renal biopsy, which was contributing to bleeding? And the answer was definitely. So the red bar is thrombotic microangiopathy as reported on the renal biopsy, and the green is no TMA. And you can clearly see that patients who had a thrombotic microangiopathy on the biopsy had a higher risk of major bleeding. So I mentioned fibrous-intimal hyperplasia is a feature of APS, and I think this is the clue to why these patients bleed. So this was the biopsy from the young man I just described earlier who had the nephrectomy. Other parts of his histology showed clear evidence of glomerular and hilar thrombosis, but you can clearly see here extensive intimal edema and fibrosis. And one can imagine if you stick a needle into this vessel, it is not going to vasoconstrict as it would in a normal, otherwise healthy individual. So I think this is the clue to why these patients bleed. So that was confirmed by Natasha Jordan when we looked at the prevalence of fibrous intimal hyperplasia and the correlation with bleeding. There was indeed a correlation between the presence of fibrous intimal hyperplasia and the increased risk of major bleeding. So the hypothesis seems to hold good, that this is a vasculopathy driven by APL and fibrous intimal hyperplasia that increases the risk of bleeding. So risks of bleeding in APS patients, and indeed APL positive patients, thrombotic microangiopathy and fibrous intimal hyperplasia. So around the time we were doing this work, Kanud and colleague were working in Paris in a big transplant center, and they audited their patients who had had a transplant. So they transplanted a number of patients with antiphospholipid syndrome. And you can see in the orange line, so this graph is all APL patients who underwent a renal transplant. Sorry, these are the top two were APL negative patients, and here were APL positive patients. And the difference here was the use of sirolimus in the transplanted patients. So sirolimus, if you did not use sirolimus in their anti-rejection regimen, they did badly. So one of the things about renal transplants is that you have protocolized renal biopsies. And so they had comparison renal biopsies. So these were patients with ordinary renal failure, diabetes, hypertension, and so on. So these were APL negative patients. And these were the APL positive groups, representative biopsies. So here were APL positive patients who did not have sirolimus, and you can see florid intimal hyperplasia. And these were patients who did receive sirolimus, which looked identical to the patients who did not have APL. So again, intimal hyperplasia, this fibrous intimal hyperplasia was responsible for graft failure. So what they showed in a very elegant series of laboratory investigations, they showed that sirolimus averts the mammalian target of rapamycin complex activation and thereby reduces fibrous intimal hyperplasia. And this protective effect is independent of anticoagulation. I think that's a very important point. So we now know a lot more about antiphospholipid antibodies. We know the mechanisms of thrombosis. We know now that complement activation is important. But we now know that there is a vasculopathy, which is probably driven by activation of the mTORC pathway. And there's a potential now, a potential intervention here with sirolimus. So I raced around to my renal colleagues and said, we now need to put our APS patients on sirolimus. They said, don't do it, David. Sirolimus is now a bit old-fashioned. It's quite a toxic drug. And it's not the same as tacrolimus. Tacrolimus does not seem to have this effect. So we are looking now for a similar drug to sirolimus to reduce this vasculopathy in APS patients. So these are high-risk patients. We have stopped doing biopsies in our APL or APS positive patients unless it's absolutely essential. At the moment, we now just anticoagulate these patients on the presumption that they've got a thrombotic macroangiopathy, and we try and avoid doing biopsies. So our renal biopsy rate has reduced considerably in this specific population of patients. So our man has done very well. Warfarin was restarted, he recovered, and I saw him a few months ago. He's actually doing very well in remission. So learning points for this patient, pediatric onset lupus. We know that lupus nephritis is very frequent. A positive family history is more common, so there is a genetic component. And APS vasculopathy certainly drives the clinical features and increases the risk of renal biopsy. So the summary of my talk is patient 1, distinguishing cerebral APS from cerebral lupus is very, very difficult, but it's clearly important because the management is difficult. Patient 2 apparently had refractory lupus nephritis, but that was all entirely down to non-adherence, which she admitted to much later on. And patient 3 was a patient with very difficult APS nephropathy, which can complicate lupus nephritis, as we saw in him. And the message we're learning is consider renal biopsy exceedingly carefully in these patients. So final slide. So antimalarials, actually first used by William Heberden in the 1700s, antimalarials, corticosteroids, immunosuppressive agents, biologic agents. But even in that time, William Heberden made this prescient observation for new medicines, and belimumab and other drugs are new shiny medications. For new medicines, new methods of cure always work miracles for a while. These are all my colleagues who've helped me with these complicated patients. Thank you for your attention. I'm happy to take questions.
Okay, thank you, Professor Cruz. It's an absolutely wonderful talk. And it's also exciting learning experience for me. And I feel, I guess, many of us in the podium. So the session is now open for any questions and comments to Professor Cruz. Any questions from the audience, please? We are much ahead of our time, I think. So,
good.
Question is there. Yes.
Sir, we also have stopped. We think twice before doing biopsy in APS positive patients of ours. So, how do you propose that we distinguish whether it's the nephropathy is because of lupus or whether it's because of APS nephropathy? Because the treatment will obviously differ in both cases.
So as I tried to illustrate in that last patient, this is really, really hard. In fact, both patients, the first patient and the last patient, identifying antiphospholipid vasculopathy is very, very hard. So maybe in our first patient, the cerebral manifestations were a bit more clear-cut. There was cerebral infarction. She was having stroke, so that was a little bit easier. When it comes to the kidney, you can sometimes see renal infarctions, but they are very rare. So trying to identify a renal thrombotic macroangiopathy is really hard in somebody who already has lupus. So one of the things I've learned is that these patients are often very hypertensive, often out of proportion to somebody with lupus nephritis, ordinary lupus nephritis. You can certainly get hypertension in those patients, but APS thrombotic macroangiopathy, these patients tend to be very hypertensive. They have proteinuria and they have active urine sediment, so there's no way of distinguishing on that point. We always try and exclude renal artery stenosis in these patients where possible. So our current approach is if we strongly suspect, and it is clinical judgment, that these patients may have an APS thrombotic macroangiopathy, we will just anticoagulate them. We will try and avoid doing a renal biopsy. And if we suspect that they've got lupus nephritis, we'll treat them with mycophenolate and steroids. If we have to do a renal biopsy, this is not a day case. So all our nephrologists are agreed on this point. These are very, very high-risk renal biopsies. They will be admitted to hospital. They'll have a pre-biopsy workup with clotting studies. They will have the biopsy, and after the biopsy, they will remain an inpatient overnight with the blood count in the morning, and they will have a repeat renal ultrasound the next morning after the renal biopsy to make sure they haven't bled. So using these very, very strict protocols in a very tiny number of patients where we've had to do a biopsy to distinguish the predominant problem we've had many fewer complications. So very targeted selection of patients for biopsy, very strict protocols of pre and post biopsy observations with ultrasound scans, and the patient's always counseled, if you have loin pain or hematuria up to 2 weeks after the biopsy, come back to the renal unit immediately.
Any question? Any questions from anybody? Oh, my co-chair is.
Hello, Dr. Cruz. It is a
Hi.
mesmerizing presentation with a spectacular performance. I have a simple question. Among all these 3 patients, first 2 were female and the last patient was a male. We know the difference of prognosis in male and female SLE. But in a case of secondary APS, do you feel any difference of sexual difference, male or female, the outcome in your third case?
I think anecdotally, I'll have to look back at the literature. Maybe Anna Sir can help me on this one. My impression is that there's not a particular difference in terms of outcome, in terms of pure APS, whether you're male or female. These are very complicated patients. But I'm not aware of any major differences in prognosis with purely with respect to antiphospholipid syndrome. A lot of the outcome depends on adherence to warfarin or inability to control the INR, inability to control blood pressure. These are all the predictors of a poor outcome. And my impression, I'll have to go back to the literature, is that there's no particular difference whether you're male or female. Now, with respect to lupus, I think there is some controversy here. Some studies have suggested that if you have lupus and you're male, your prognosis is worse. Others have contradicted that and have found no difference between male and female poor outcomes in lupus patients. And I think David Eisenberg has looked at this and he said, well, I don't see a difference in male versus female lupus patients. But the number of lupus patients who are male is obviously a lot smaller. It's sort of 10% of the population.
Thank you. Thank you.
Any question from the floor? So if there is no more question, I once again thanks Professor Cruz, and I wrap up the session over here to proceed for the next session. Thank you everybody in the audience.
Thank you very much. Thank you again for the invitation. Yeah.
Our next talk by Dr. Lauren will be starting at 6. I would
go ahead.
break for tea right now for 20-25 minutes and rejoin at 6 again. And after that, we will have a cultural program at 6 o'clock. So I would request you to stay for that, please.
Somnath. Somnath. Somnath.
Good evening. We'll continue our program. The next and the last talk for today is by Dr. Laurent Arnaud again on challenges in managing neurolupus. It will be moderated by Dr. Bhaskar Ghosh and Dr. Parthajit Das. Can I request them to come on stage, please? Thank you.
Am I visible now?
Hello again. Shall I go on or shall I wait a bit?
Just a minute, please. Dr. Ghosh? Dr. Ghosh? Dr. Ghosh?
Hello. Yes, Vinalda. Bolo.
Yes, I can see you. Can you see me?
I cannot see you.
Have you seen the screen?
Acha, let us start the session. Then you come.
No, I am already joined. I can see you very much. I can see Parthajit also.
Oh, now you can be seen. Yeah, now you can be seen. Yeah.
Okay, fine. You can start the session. You introduce the speaker.
Okay.
Partho is here also.
Okay. Thank you, Professor Minal Rai. Now, good afternoon, everybody. This is the last session for today, and but this is a very important and very interesting session on challenges in managing neurolupus. And as you all know, neurolupus has a very different set of presentation, particularly if it is not associated with other systemic features of lupus, and it is very difficult to diagnose and manage neurolupus among the several differential diagnoses of presenting symptoms. So with this challenge, we will have a talk on challenges in managing neurolupus by Dr. Professor Laurent Arnaud. He is MD and PhD. He is Professor of Rheumatology, University Hospital of Strasbourg and French National Reference Center for Rare Autoimmune Diseases, France. He has got an excellent professional background, and Professor Laurent with his team contributed to more than 150 research projects in the field of rare diseases such as giant cell arteritis, Takayasu's arteritis, relapsing polychondritis, and systemic capillary leakage syndrome. His main research interest focuses around the development and systemic evaluation of biological and immunomodulatory treatment for systemic diseases, with particular interest in the pathogenesis, diagnosis, and treatment of SLE and antiphospholipid antibody syndrome. So without wasting any more time, we will be handing over to Professor Laurent Arnaud. And in the meantime, our third chairperson, Professor Minal Kanti Rai, we can see him. He has also joined. Any comment, Professor Rai, before we start?
I think, thank you, Professor Ghosh. The brief introduction has already been given by Dr. Ghosh, and today I personally feel that this will be a very interesting session. Though it is in the last part, the cerebral part of our body is situated in the top, but actually this is actually a topic which actually befits everybody. In our clinical practice, when we are confronted with problems of various manifestations in the neuroaxis, especially of the central nervous system, without any evidence of any peripheral nervous system involvement or any other systemic involvement, that becomes a real problem. When it comes in the background of a specific collagen vascular disease, we are very confident to treat them, but we do not get any sort of evidence in the any other organ system like your infections and other things which mimics very much. So that becomes a big problem. And based on biopsy, probably the diagnosis become a really challenging one. With these few words, and my regards to both the chairpersons, a young budding chairperson, Parthajit also here, and also Professor Ghosh, I now request our learned Professor Laurent Arnaud to start his deliberation. And if Parthajit to comment something, he can do it. Thank you.
Thank you very much.
Please continue. That's fine. Thank you.
It is an immense honor for me to be with you virtually today. And indeed, I'm going to try to talk about neuropsychiatric lupus because I have to be very modest. It is a very difficult involvement. And so I'm not going to solve the mystery of life tonight, but I hope we are going to discuss all together to see how we can take care of these very difficult patients. Can you confirm that you see my slide? Yes, you can, I think.
Yes, please, yes.
Perfect. Okay, so these are my disclosures. And I just wanted to start showing you this. It's a survey I did on Twitter, I think 2 months or 3 months ago, among SLE doctors, and everybody voted for neuropsychiatric lupus as the most difficult manifestation of lupus. So thank you very much for your invitation to talk about that. It's a real challenge. I hope I will succeed. So maybe one of the reasons why everybody is kind of concerned and afraid, it's because it's difficult to diagnose, but also because it's associated with significant mortality. The risk of death, if you have NPSLE, is multiplied by 10 compared to the general population, and multiplied by 2 to 3 compared to lupus patients who would not have NPSLE. So we see this is very serious. Not all manifestations will increase mortality, but as a whole, this is really significant. So this is my agenda for this talk. We're going just briefly to review what is NPSLE. We're going to insist on how diverse and how common are these manifestations. I suggest we review briefly what are the typical manifestations of NPSLE, and then we are really going to enter the difficult part of this talk, how to make the diagnosis, and more precisely, how to attribute NP events to SLE, and finally, to talk about the treatments. So without further ado, let's start by this first slide. I was just trying to remind everybody, because I'm going to say NPSLE all the time, that NPSLE stands for neuropsychiatric lupus. I think everybody knows that, but at least now we are clear about that. So we know that systemic lupus is a very systemic disease. Any tissue, any organ can be involved. And among these involvement, there is neuropsychiatric lupus. So this is a slide I have shown in the previous talk. When we are talking about the general manifestation of symptoms, often it starts by a complaint or a clinical finding in a lupus patient, such as a neurological or psychiatric manifestation. And the first step is to decide whether the symptom is actually due to lupus, yes or no. And this is a complex process. It's based on positive clinical findings. We as doctors, we like to have something objective, something we like to see, a clinical sign, an imaging sign. When there is absolutely nothing to see, things are getting really complex. Then, of course, there's the results of the tests and imaging studies. It helps finding objective complaints. There's a big part of negative findings, and in the context of NPSLE, it's mainly excluding differential diagnosis, especially infections. And occasionally, there's a bit of probabilistic reasoning. I'll come back to that later. So when we perform this attribution, at the end, we either attribute the symptoms to lupus or they are attributed to something else. And in the case of neuropsychiatric symptoms, when those symptoms are attributed to systemic lupus, then it is called NPSLE, or for some people, it's sometimes called primary NPSLE in some papers, but I don't really like this term. When the neuropsychiatric manifestations are found in lupus patients, but not due to lupus, then we call that non-NPSLE neuropsychiatric events. So I think from the start, it's very important to make the distinction between neuropsychiatric events and neuropsychiatric lupus, which is the attribution to systemic lupus. So how diverse are these manifestations? Well, I'm sure everybody in the room is aware of the American College of Rheumatology classification for NPSLE. There are 19 manifestations that are reported, but there are other manifestations that are not included. A majority belongs to the central nervous system, 12 of them, and 7 of them belong to the peripheral nervous system. And by the way, this also includes autonomic disorders. Something very important to state from the start is that none of these manifestations are specific to systemic lupus. So unfortunately, there is not something we can see and then we say, oh, that is systemic lupus. It does not work like that. all these neuropsychiatric manifestations, they can be found in other contexts, in Sjogren's disease, without any underlying disease, as isolated neurological syndromes. So nothing is specific to systemic lupus. Then there is another layer of complexity. Some manifestations can be focal, some others can be diffuse. Some can be mild or moderate, some can be very severe and life-threatening. And also the time is important. Some manifestations can be acute, others can be chronic. So it really makes the spectrum of neuropsychiatric lupus very broad and very complicated. So how common are these symptoms? How common is neuropsychiatric symptoms among SLE patients? Well, if you have followed the talk carefully from the start, it's actually not one question, but two different questions, which are: how common are neuropsychiatric events among SLE patients? And then which proportion of these neuropsychiatric events can actually be attributed to systemic lupus? And what I suggest is that in your mind, you think of a number. What is, according to you, the proportion of lupus patients who will have at least one neuropsychiatric event during their life? Do you have an idea? Well, the answer is 52% in the SLIC Inception cohort. Almost 2,000 patients followed for around 10 years. 52% of patients will have at least one neuropsychiatric event. Another layer of complexity is the attribution. This is what I mentioned. Actually, between 20 and 30% of these events are due to systemic lupus only, and this is stricto sensu NP-SLE, which means that more than 70% of these neuropsychiatric events are not qualifying for NP-SLE. So this is really important. About 1/3 of NP events attributed to SLE constituting NP-SLE. Related question is, when do these events occur? Well, this is medicine, so it can happen anytime, at the beginning of the disease, at the end of the disease, of course, but there is a significant association with the period during which systemic lupus is the most active, which is the first few years, especially during the first 2 years following the diagnosis. The likelihood to observe neuropsychiatric events during these first 2 years is 6 times higher than during the rest of the follow-up. So it's very much at the beginning. But of course, not only. About 1/4 of patients will have relapses, at least one relapse. So what are those typical manifestations? So I want to show this slide again. None of these manifestations are specific. And in most cases, they will involve the central nervous system, around 93% of cases. Involvement of the peripheral nervous system is possible, but it's rare, and it's quite rare compared to the involvement of the central nervous system. So I'm just showing 2 slides, one for CNS, one for PNS. It shows how many papers there are and how many data we have. These data are very heterogeneous, and many papers do not report all manifestations one by one. So it's really difficult to find the top manifestations. But if I had to make a summary, I would quote those. The most frequent manifestations attributed to systemic lupus are cognitive dysfunction, mood disorder, anxiety, headache. And among the most common, you also have seizures and cerebral vascular disease. So I'm going to dig into the details. We are now moving on to the most difficult question of this talk, which is how to decide whether a neuropsychiatric manifestation is due to lupus or whether it is simply present in a patient with lupus, but due to something else. That is really, really key. And this attribution to SLE is absolutely crucial, and I think the most complicated part. The big problem, if you look at the most frequent manifestations that are reported in SLE patients, is that they are also very common in the general population. Who has never had some kind of mood disorder? Who has never had a bit of anxiety? Who has never had headache? So there are papers showing that the ACR classification criteria for neuro-SLE do not perform very well. In this study, which was a case-controlled study, the case were SLE patients, but the controls were the general population. 56% of patients from the general population qualified for at least one ACR criteria for NPSLE. We see that this is too high, this is not possible, so it shows how poorly specific are those criteria. What it actually means is that some NP manifestations will never be attributed confidently to SLE. This is the case for headache, you will never be sure. This is the case for anxiety, for mild depression, for mild cognitive impairment, or for something else, which is polyneuropathy without any confirmation. That cannot be attributed confidently to SLE. Just to show you the example of headache, it's so common in the general population. So it's very logical that lupus patients, as the others, will also report headache. But actually, headache in a lupus patient is not lupus headache. Lupus headache has a very specific definition. I have given you 4 definitions depending on the disease activity score you use. In the SLEDAI, SLEDAI 2K or cylinder SLEDAI, it has to be non-responsive to morphine. In the BILAG, it has to be non-responsive to morphine and to last at least 3 days. In the ECLAM, it has to be relieved by corticosteroids. So we understand that in many cases, we hear a complaint of headache in a lupus patient, but this is not enough to qualify for a formal diagnosis of lupus headache. And this is why attribution is actually too complex. A second element is that because none of these manifestations are specific, there are many mimickers. If you take acute confusion, seizure, and headache, it can be an infection. If you take mood disorder, depression, confusion, it can be side effects of treatments. If you take cerebrovascular events, but also seizure, chorea, myelopathy, it can be antiphospholipid syndrome or linked with antiphospholipid antibodies. In any case, it can be metabolic. Hypoglycemia can mimic anything. So we have to be very careful when we have an acute confusional state in a lupus patient. It may not be neurolupus, it may be hypoglycemia. And finally, there are some connected disease, especially in the context of optic neuritis or myelopathy. I am sure everybody in the room has heard of Devick's disease, neuromyelitis optica, which associate optic neuritis or myelitis. This is a disease by itself, but it can be found in other autoimmune disease, such as lupus, but also Sjögren. So it means that when you have optic neuritis in a lupus patient or myelitis in a lupus patient, you should search for Devick's disease. And this is done by searching specific antibodies, anti-NMO antibodies that target the aquaporin 4, the water channel with specific antibodies. And of course, it can be comorbidities. I have migraine since I was born, and I don't have systemic lupus, but some patients can have migraine completely unrelated to systemic lupus. And the reason why it's so important to make the difference is obviously because the treatment is not the same. In the context of neurolupus, we're going to give corticosteroids and maybe immunosuppressive agents. But of course, if it's an infection, it's going to be antibiotics. And this is obviously very different. So proper attribution is absolutely crucial for the diagnosis, but also to guide the treatment. And this is why it's so complex. So how are we going to succeed? Well, for me, this is a three-step process. First is trying to document objectively the involvement of the central nervous system or of the peripheral nervous system, such as by doing some imaging, such as by doing a lumbar puncture with CSF. This is absolutely crucial. You can find very typical images. I'm showing you this. This is a limbic encephalitis in a lupus patient. Very clear hypersignal of temporal lobe with memory problems at the same time. You can have that kind of lesions. This is PRESS, posterior reversible encephalopathy syndrome, with clear hypersignal in the occipital lobes. You can have this, nothing to see, And this is actually quite common. Around 50% of patients with neuropsychiatric lupus have normal brain MRI. So a key finding is that a normal brain MRI does not rule out NPSLE. And occasionally you can have very spectacular images, such as white matter hyperintensity signals, very widespread. Does anyone in the room know what this is? Well, this is not lupus, this is PML, progressive multifocal leukoencephalopathy. This is an infection with a JC virus. If we do nothing, the patient is going to die. So again, there is no image that is typical of NPSLE. Any image should be documented, and we should decide whether it's systemic lupus, an infection, or something else. So this is why lumbar puncture and CSF analysis is so crucial. I will come back to that later, but what I want to say right now is that it's absolutely crucial to rule out an infection. And very often we start antibiotics waiting for the results of the lumbar puncture. And when we know that this was not an infection, then we open the door for neuropsychiatric lupus. And finally, I've talked about MRI, but there are other types of brain imagery we can perform. Just to give you an example, I have seen about 1 year ago, a lupus patient who had a pattern of limbic encephalitis. She had very strong memory problems, very specific. The neuropsychological testing was very formal. This is limbic encephalitis. The MRI was strictly normal. And we performed a brain scintigraphy. This is what you have on the slide. And it was completely abnormal in the temporal area. So we have to decide sometimes to go further than a simple MRI in a way. The second step is to look for confounding and favoring factors. And this is really complicated. I'm sure you know that, but in the criteria by the ACR, for each manifestation, you have a list of confounding and favoring factors. So it's complicated because for different manifestations, you have different confounding and favoring factors. So you can review them one by one, but I think this is of limited applicability in clinical practice. It's always very nice in the books, always very nice to make lectures and publication, but in real life, you cannot open a book every time you see a neuropsychiatric manifestation. So we have to find other ways to go around. And something that was said by the two wonderful speakers in their introduction is that occasionally you can have a flare in other organs. So if you have neuropsychiatric manifestation and a flare of systemic lupus in the kidney or in the joint, usually it's related. But of course, NPSLE flares can be isolated without any flare in another organ. And this is actually quite common, and this is more difficult. So now we've been reviewing this step. What do you do? And this is really difficult. There are some algorithms giving you points for each manifestations I have just quoted. And you see at the bottom of the slide that you can attribute NP events to SLE if you have a score of more than 7. Well, what do I think? I think this is of limited applicability in clinical practice. This is great for studies, for trials, where you look for official attribution rule. But in daily clinical practice, I don't think scoring points will really help you. So I think we really have to think about a more pragmatic approach. And I want to say thank you to my friend Bertsias, who has sent me the paper, who is unpublished yet, because I think it summarized really well what I actually think, is that a very pragmatic strategy when we are confronted to a manifestation from the neuropsychiatric spectrum is first to try to exclude non-lupus conditions and especially infections and metabolic problems. And this is where the lumbar puncture, this is where calcium, TSH in the blood, everything counts, to first try to find something that is different from lupus. And then a very pragmatic approach is that when you have ruled out an infection, you are absolutely sure or almost certain it's not going to be infectious, well, you can make a trial of corticosteroids. This is a very pragmatic approach. When it's an inflammatory manifestation of systemic lupus, NPSLE, it should improve with corticosteroids. And that's a if you use sufficient doses, I'm going to go into the details. That's a very good way to test whether, yes, this is yes or no NPSLE. So now I'd like to dig in some additional diagnosis consideration because I think it's really important. First of all, I have mentioned that around 50% of lupus patients will have neuropsychiatric events. So obviously, we cannot perform an MRI and a lumbar puncture in 50% of all our patients as soon as there is a neuropsychiatric complaint. That is not realistic. So what I suggest is to try to determine whether this is a minor complaint or whether it goes for something significant. And I'd like to take the example of brain fog. I'm sure some of your patients have talked about brain fog, which is actually a part of cognitive dysfunction. This is a screen capture I made from a website for patients and doctors in the US. It says that it means more than memory problems. It refers to cognitive difficulties, trouble helping the child, homework, grocery list, memory problems, concentration problems. This comes very often. And actually, I mentioned this, it counts as cognitive dysfunction. So it's a CNS manifestation of lupus. It is actually the most common neuropsychiatric manifestation that is reported in lupus patients. Depending on the series, it can go from 5% to 80% of patients. So we see how complex and variable it is. Usually, there is something to see at the clinical examination, so it will be easy to decide. But when it's subjective findings, such as psychiatric manifestations, it can be more difficult because the doctor sees nothing. And I have 4 secrets I'd like to share with you. When it's a psychiatric manifestation, a brain fog, a memory problem, a cognitive dysfunction, I always try to get some feedback from family members of partners. So I ask the patient to come to the consultation with the partner and we listen. And if the partner confirms that there is a major something, then we know it's real. When only the patient is complaining, often it's more mild or moderate. Then I'm trying to see if coping solutions are used, such as post-its or alarms on the telephone or a very well-done agenda. If a patient complains from memory problems but is not using these coping solutions, usually it's not very severe. And finally, I'm always thinking about whether there are some confounders such as depression, because we know it's related to memory problems, anxiety, and so on. Something very crucial is that there is no specific pattern of cognitive dysfunction in systemic lupus. It's a mix of slowing, decreased attention, impaired memory, and executive dysfunction. But again, nothing is specific of systemic lupus. So when you think that the manifestation is real, that there is an impact on the patient life, we have to go through screening tests. And you know that for neuropsychological involvement, for cognitive dysfunction, you have tests that can be done by the patients themselves. This does not work well. There are tests that should be administered by physicians, and there are 2 big tests in the world. One is the MoCA, Montreal Cognitive Assessment. The other one is the MMSE. I hope you can tell me about what you do in India first. I'm really curious to know. In the context of neuropsychiatric lupus, it's been well studied, especially by Vaihi Tumar, who has a really good expertise on that. And I would recommend the MoCA because the negative predictive value is higher. If you have a normal MoCA, you can be quite reassured that there's no cognitive problem. So I'm sure you know how it works. It's different tests that the patient can done in about 10 minutes, and you need a score of more than 26 points on a range up to 30 to say that it's considered to be normal. When these screening tests are abnormal, well, we have to go through the full neuropsychological testing. The ACR has defined what is the minimum battery of tests. It's quite long. I don't know if it's easy access in India. I'd be happy to hear what you can tell me about that. And in the States, it's not always reimbursed by the insurance. So maybe the patients have to pay for that, which can be complicated. So we have to keep that in mind. I've been talking about brain imagery. I've said it's very important to try to perform an MRI to find some objective finding. But I want to say something about white matter hyperintensities, because it's a very, very common problem. When you perform brain MRI to lupus patients, even if they have no neuropsychological symptoms, it's very common to find white matter hyperintensity signals. And actually, it's been done very beautifully by my friend Matteo Piga. Baseline MRI, 50% of lupus patients have such signals. And when you follow them prospectively, and that is what was clearly amazing in this study, they followed prospectively the patients for 20 years. And 20 years later, not 50, but 70% of the patient had these abnormal signals. So what we can say is that there are things that predict the progression of these signals. Positive for antiphospholipid antibodies, associated cardiovascular risk factors, especially hypertension, and also general disease activity. And it's really crucial because these new signals, they are associated significantly with new neuropsychiatric events, but also with cognitive decline. So we have to do something. And what do we have to do? Well, it must be discussed on an individual basis, but it can be aspirin for primary prevention, especially if cardiovascular risk factors are high, but also the control of disease activity. This is very crucial. I'd like to talk about lumbar puncture and CSF analysis. I have already said it's crucial to rule out an infection, but we can expect more, especially finding of an intrathecal synthesis, so elevated CSF IgG index or presence of oligoclonal bands is often reported in neuropsychiatric. About autoantibodies, 3 categories of autoantibodies have been associated with neuro-lupus manifestations. It's antiphospholipid antibodies, which are associated with cerebrovascular events, of course, in the context of APS, but also with seizure and chorea, anti-ribo-P antibodies, and anti-neuron antibodies, including anti-NMDR receptor antibodies. So I suggest, if it is available in where you live, that when you are confronted to neuropsychiatric lupus, you ask for these antibodies. It may help making the diagnosis more specific. You can ask for these antibodies in the cerebral spinal fluid. There is an association between anti-ribo-P and anti-neuron and several manifestations of neuropsychiatric lupus. Of course, you are not going to ask for antiphospholipid antibodies in the CSF. This cannot be done. So we've been reviewing the diagnosis, which is really complex, seeing the role of MRI, seeing the role of additional imaging techniques, seeing the role of CSF analysis. I just want to recapitulate. We start by neuropsychiatric manifestation in an SLE patient. First question, is this significant, yes or no? And you can ask the family and the friends if it's needed. If it's significant, is this due to systemic lupus? In other words, is this neuropsychiatric lupus? And to do that, you confirm the event using objective methods, and you try to exclude differential diagnoses such as infections. When it's confirmed, you need to treat, and unfortunately, patients with neuropsychiatric lupus are generally excluded from the clinical trials. When you look at all the clinical trials that are currently ongoing, or the last ones, I'm thinking voclosporin, I'm thinking belimumab, I'm thinking anifrolumab, NPSLE is an exclusion criteria. So how do you do? When you read the books, they say all the same. You have to decide whether it's inflammatory or whether it's thrombotic. If it's inflammatory, you give glucocorticoids and immunosuppressive agents. If it's thrombotic, you do give aspirin or anticoagulants. The problem is, how do you make the distinction? And actually, it's never written in the books because I think it's really, really difficult. You cannot look at the patient and decide just like that. And I'm going to be a bit provocative, but I am not sure this is a very important question because unfortunately, we have this study, which is a very good study. It is brain autopsy from lupus patients, around 20 brains. And what it shows is that vasculopathy, especially thrombotic vasculopathy, is very common in NPSLE. So you can always say it's inflammatory, but actually almost always at the pathology, at the cellular level, there is some thrombosis. So my suggestion is to try glucocorticoids first. And to be honest, I have discussed in the previous lecture earlier today that I try to use the lowest dose of corticosteroids as possible. In the context of neuropsychiatric lupus, I prefer to start quite high to be sure that we are going to give enough to test the reversibility. Usually I give 1 milligram kilogram for a few days. If there is no improvement, this is really against active neuropsychiatric lupus with an inflammatory component. Then if glucocorticoids work, we cannot maintain high doses. So very quickly, I will taper corticosteroids, but then I need to add an immunosuppressive agent. And well, there are case reports and data with all immunosuppressive agents, but the three IS that are been the most used in the literature are IV cyclophosphamide, MMF, or rituximab. And how do you decide? Well, my point of view that it depends on the context. If you have a flare in another organ, for instance, the kidney, well, I'm going to start by cyclophosphamide or MMF. I am not going to use rituximab because this is not first line in kidney involvement. Then there are specific contexts. Now, unfortunately, it's COVID. And you know that rituximab is associated with severe form of COVID. The second problem with rituximab is that you cannot stop the treatment. When you have given rituximab, the B cells will be depleted for a long time, typically 6 months, and you cannot take the drug back, actually. So when you give rituximab, you really have to think about this is going to be beneficial or cause problems, but for several months. So we have to think about this in the context of a pandemic. And finally, I think severity is a very important modulator. If it's very severe, I would definitely use cyclophosphamide because it's the fastest and the strongest drug we have. If I am called by the intensive care unit for a case of acute delusional situation or confusion due to systemic lupus, or the patient is comatose, I will do infusions of corticosteroids. And if I have evidence for NPSLE, I would usually use cyclophosphamide. Finally, we're moving to the difficult point. Shall we use anticoagulant or aspirin? Well, I use anticoagulant as soon as I make a diagnosis of antiphospholipid syndrome that is thrombotic. If you have a diagnosis of APS, such as for cerebrovascular events in systemic lupus, I'm going to anticoagulate the patient. So really the tricky part is, shall we give or shall we not give aspirin? Low dose aspirin, 75 milligrams to 360 if you want. Well, there is no rule in the literature. My feeling is that if the patient has antiphospholipid antibodies that are positive, I will give aspirin. I also think that the risk of bleeding is usually not very high with low dose aspirin. So it's like it cannot do harm. That's my philosophy. So if I don't have a high bleeding risk, and if the patient is APL positive, usually I will add aspirin to the treatment of glucocorticoid and immunosuppressive agents. And finally, there's the question of symptomatic treatments, such as anticonvulsivant treatment. I don't have the time to go into the details of epilepsy in the context of lupus, but around 5 to 8% of lupus patients will have seizures. So this is a question that comes quite often. Shall I start anticonvulsivant treatment? Well, not for all seizures, not for the first flare. The typical indications are repeating seizures, such as 2 seizures in less than 24 hours, or if you perform the brain MRI and you see abnormal signals, or if you have clear epileptiform discharge on the electroencephalogram, then I would start anticonvulsivants. But I don't start them for a first episode in all patients. And usually, when I think that these seizures are due to lupus activity, which is the case in NPSLE, I also give a course of glucocorticoid plus immunosuppressive agents. I just want to remind you that some drugs can actually trigger systemic lupus, drug-induced lupus, but we think that some of these drugs can actually aggravate systemic lupus. And this is the case for carbamazepine that has been associated with worsening of systemic lupus. So I would really keep in mind that the best drug for epileptic seizures in the context of lupus is depakine, valproic acid, because it has the lowest potential for induction of potential lupus flare. Finally, and this is my last slide, I started with this. We have to keep an open mind, to be very modest, because neuropsychiatric lupus is one of the most difficult manifestations to manage. Something very important is to think again about the case we've seen regularly, to regroup your team and say, oh, one month, the patient has been treated for 1 month. Now we think again, is this really neuropsychiatric lupus? And this great paper shows that in a significant proportion of cases, you will change your mind. So I really think that we should keep our mind open to check whether this is really a neuropsychiatric lupus or whether it could be something else. I hope I have satisfied your hope on this very difficult theme. I have to say thank you very much. And well, I'll be happy to take your questions and discuss about the Indian practice, which is probably a bit different from mine. Thank you very much.
Right. Thank you, sir, for a very nice and clear presentation of a very complex disease, which we struggle to manage on a daily basis.
Yes.
I'm sure there are lots of questions. First, I'll start with, do we have any online questions? Then any questions from the audience?
Thank you for a very illuminating discussion on this neuropsychiatric lupus. I just want to make a small comment that anti-epileptic drugs. So I think phenytoin is also not very good choice in patients with SLE. So phenytoin should not be used along with carbamazepine, as you have already shown. But we often use levetiracetam. So levetiracetam is a very good drug, but I agree that it aggravates some psychiatric manifestations sometimes. But nowadays, levetiracetam has come into the market, which has got all the properties of levetiracetam minus psychiatric manifestations. So we are yet to apply this drug in SLE patients. I cannot tell you the outcome, but literature says that it is good for patients because they do not aggravate the psychiatric symptoms.
Now,
so what is your take?
I completely agree with you. Thank you. I think this is an important comment. Depakine is quite a cheap drug and it's widely available. It's quite safe. But of course, there are other options. My point was really to underline the fact that some drugs can actually aggravate lupus, systemic lupus, and that when we make our selection, we have to keep in mind the fact that this is not normal epilepsy. We have to discuss with our colleagues from neurology together to select the drug that will take the less risk of increasing the level of disease activity in systemic lupus. That was really my point, but I fully agree with what you said.
Yeah, thank you. But you know, the valproate has got certain disadvantages, like that it has got some drug interaction, number one, and number two, as in a female patient, valproate often produces this obesity, and also that's a problem in a patient of SLE because they are prone to develop obesity due to steroid therapy and so on. So another question I want to ask you is that we know that hydroxychloroquine is a drug which aggravates seizure. So what is your take on hydroxychloroquine? Whether we should start hydroxychloroquine at the onset of diagnosing SLE with neuropsychiatric manifestation, or we should start treating the patient for some time, and when we can bring the disease under control, then we should start hydroxychloroquine. What is your opinion?
It's a very difficult question because we don't have good data to answer based on evidence. So it's a very personal practice. What I do is that I start hydroxychloroquine from the start to help controlling disease activity in systemic lupus, prevent relapse. And I think this is a very important drug in the setting of systemic lupus. I understand the perspective of starting a bit later when you have controlled the flare. I think both options are actually acceptable, and we need good data to compare these strategies, and we don't have that for now.
Mrinal sir, do you have any questions or comments?
Okay, thank you, Parthaji. Just I have got a small comment. This is really an excellent talk. What I should say that is an excellent, superb talk. But the problem lies in the fact that the challenges which we come across in our day-to-day clinical practice for the diagnosis and the treatment purpose of this particular entity remains an enigma still now. Now, I want to ask only one question, that whether there is any role for seeing the MRI wall by MRA, the vessel wall thickness, and also in the later part in selected cases, how many percentage of the people should undergo the biopsy for confirmation because of the fact that we have to start some therapy which has got some detrimental effect in course of time. So obviously, without getting 100% sure, if we were to start those types of therapy, when there is such an intriguing situation, what is the role of biopsy in general? Which cases should be selected for biopsy?
So I'm sorry, are you talking about brain biopsy?
I'm talking in terms of brain biopsy.
Okay, so this is something interesting because this is something we almost never do in France. So I'm really interested in hearing your experience. Basically, the idea I have for a brain biopsy would be a doubt with a tumoral lesion. This would be the best indication. And there are ways to go around, such as doing spectroscopy, spectro-IRM, MRI. So it would help to make the distinction. And also in case of suspicion of a tumor, you can always make a control of the MRI 1 month later, 3 months later, to have an idea of the progression. For me, the good indication for a biopsy is mostly a meningeal biopsy when you have some kind of infiltration and you don't know what it is. But I have not done a brain biopsy in a lupus patient in more than 20 years.
Okay. Thank you, sir. But as far as the literature is concerned, which I was actually searching prior to this lecture, I find that in some of the institutions in Italy and Germany, these people are actually doing some biopsies, even from the deeper area to stereotactic way. And they're also trying to correlate those things with the MRI finding, especially the vessel wall thickness and other things, and white matter changes, what we have actually elucidated. But probably some of the non-specific MRI findings are very common. That's why it is very difficult. It's very difficult to come at a diagnosis. However, I do agree with you because this is a very hazardous procedure. Obviously, we should stick to the clinical findings and other types of your protocols which have been put forward by our different authoritative bodies to come to a diagnosis. Thank you very much for your nice lecture.
My pleasure. I fully acknowledge the fact that this is a heterogeneous disease, so I can understand that different parts of the world, Italy, Germany, do differently. This is quite okay to me.
Yeah, thank you, sir. I think I can see quite a few questions from the audience. Yes, please.
Thank you, sir, for your excellent speech. Sir, I'm a resident doctor working in Kolkata. So my question to you is the lupus patients who have got rituximab for a different indication like severe autoimmune hemolytic anemia or lupus nephritis, the patient then the patient develops neuropsychiatric lupus even after getting rituximab. So is there any benefit of starting second immunosuppressant like MMF or cyclophosphamide, or should we wait for the response of rituximab?
So that's a very difficult question because we don't have data, very specific data. What I can say is that you know that rituximab failed 2 randomized controlled trials, LUNA and EXPLORER, in renal and extrarenal manifestations. but there is quite a lot of observational data on neurological involvement improved by rituximab. And what you said is very true, is that rituximab has some delay of action. So if a patient has neuropsychiatric manifestation and is treated by rituximab, I would not expect a short-term improvement. You can obtain that with corticosteroids. So if it's aggravating under rituximab and corticosteroids, I would definitely do something else. And in this context, I think I would go for cyclophosphamide. But this is a discussion on a case-by-case basis. It's difficult to give generality here.
Thank you, sir. Able, sir, please.
I have a comment and a question. I'll put the question first, but you can answer that later. How often do you see CMV in complicated neuropsychiatric lupus? Because CMV manifestations can mimic some of these MRI findings, can mimic PMLE, can cause white matter lesion, periventricular lesions. We have seen patients of which we initially diagnosed as neuropsychiatric lupus, patient doesn't improve and then turns out to be cytomegalovirus. So it can mimic neuropsychiatric lupus. So how often do you see that? Second is a comment on we in the beginning of the pandemic, we also thought like that, try to avoid rituximab. And what happened was that in the pandemic, with the pandemic restrictions on travel, the need for COVID testing, etc., patients could not take cyclophosphamide, and we lost many kidneys and many organs because of the choice of cyclophosphamide, which patients cannot take. The cost of cyclophosphamide therapy also went up because you had to factor in the COVID test for the patient, the relatives, and all the paraphernalia associated. And then we went back to rituximab. It's better to, anyway, patients are stuck at home. Why not give rituximab? And now my rituximab use has gone up during the pandemic. And another thing is that, as you said, in neuropsychiatric lupus, you may have to do everything. It's very difficult to attribute. Suppose we had patients with, catatonic neuropsychiatric lupus, catatonic manifestation. We are giving rituximab, you are giving methylprednisolone, you are giving ECT, we are giving everything. It's very difficult to say what works. Probably all of them are needed. And again, there is evidence that in EAE models, if you give rituximab prior to the onset of symptoms, rituximab can worsen. That may also be explained. If you, before an organ manifestation, if you give rituximab, it can accelerate the disease by eliminating the regulatory B cells, which are preventing probably the development of the disease. And whereas if you give rituximab in an established disease, by removing the inflammatory B cells, it can cause recovery. So it is possible that rituximab can precipitate.
And I fully thank you for your comments. I think this is very relevant. My point is just that when you give rituximab, you cannot stop the drug very easily. You know that when the patient is depleted from his B cells, it's going to be for several months. To answer your question about CMV, I'd say that when I have a significant suspicion, I will perform a CSF analysis. And in France, but I think this is the same almost everywhere, this automatically includes a herpes virus PCR panel, which includes CMV. And also, as soon as I have a very significant lupus flare, especially with fever and cytopenia and so on, I always make EBV and CMV viremia testing in the blood.
It's David De Cruz here. I just wanted to follow up the comment about brain biopsies. So I agree, there's no role for brain biopsy to confirm a diagnosis of neuropsychiatric lupus. We've done 3 brain biopsies over the years, and they showed anything but neuropsychiatric lupus. The first patient was a lady with progressive multifocal leukoencephalopathy. The second patient had cerebral TB, and the third patient had a B-cell lymphoma. So I think there is a role for brain biopsy, but very, very carefully judged. And you know, the clinical picture really wasn't that of what you're describing of neuropsychiatric lupus.
Thank you for the comment. I really think my message here is to say that brain biopsy are not a standard diagnostic procedure for neuropsychiatric lupus. I fully agree that in some selected indications, it can be discussed by experts team, especially to rule out something else. But my really pedagogical message is that, of course, we should not perform brain biopsy to make a diagnosis of neuropsychiatric lupus.
Exactly.
Just one last question from the audience.
Thank you for your enlightening talk, sir.
Thank you very much.
I am Yes, I am a postgraduate trainee in Kolkata. Sir, I have basically two questions. Number one is that if a patient is suppose having isolated cranial neuropathy in a diagnosed case of SLE with normal MRI, MR angio, and APLA profile negative, can I attribute the cranial neuropathy to vasculitis?
Oh, that's a difficult question. For sure, in this situation, I would perform a CSF analysis to be sure there's no inflammation there. And then I would do a course of corticosteroids to see. We know that cranial neuropathies are the most common cranial neuropathies seen in the context of systemic diseases. The most common peripheral neuropathies, sorry. So I would be pragmatic in this context. I don't think it has to be attributed to vasculitis, yes or no. That is going to be impossible to determine. I would treat.
Okay. First, I will rule out infection and I will give a trial of steroid.
Yes,
That's what you're saying, sir. Okay. And my second question is that if a known case of SLE again has one episode of seizure and white matter abnormalities in the MRI, in CSF, that patient has oligoclonal band, but which is absent in blood. Then can this be explained only by SLE, or should I think of a demyelinating disease like multiple sclerosis?
No, I think if you have a proof that the patient has systemic lupus, I would not open a door for something else. The most likely diagnosis is NPSLE. As soon as you have ruled out infections and other things like that, the question of multiple sclerosis versus neuropsychiatric lupus is always very difficult, especially because you can find anti-nuclear antibodies in systemic sclerosis. So in the context you described, if you have strong elements for a diagnosis of SLE, I would follow that path.
So even if oligoclonal band is present in CSF and absent in blood, even then I will say it because of SLE.
Yes, oligoclonal bands are very common in NPSLE, even
Okay, sir.
absent in the blood. Yes.
Okay, sir. Thank you very much. Thank you,
pleasure.
sir. Yes.
Any more comments or questions? Just last one question, please.
Thank you for allowing me. Actually, I want to share one patient I had recently. I had in my clinic, and the patient presented, middle-aged person, patient, female, presented with acute onset hemichoria, and yes, after excluding the basic like infections, the CSF analysis was negative, and we went for MRI. But MRI didn't reveal anything. But patient was having right-sided hemichoria, and then on immune markers, it revealed that patient's ANA was high positive high titer positive. But all other immunological markers were negative, including APS. But again, contrast MRI didn't reveal anything in the brain. So how do we attribute this, whether this is autoimmune chorea or chorea, it's NPLE?
Yeah, it's obviously complex questions, and it's difficult to provide an answer there. I have to be very modest without seeing the patient, and in complex cases, it's difficult to be certain. What I can say is that chorea usually evolves positively. There are ways to improve, such as xenazine. I don't know if you have the drug in India. Maybe it's a kind of benzodiazepine. But if you find evidence for systemic lupus and active systemic lupus, for sure in this context, I would use aspirin low dose, even if the patient does not have antiphospholipids positive antibodies. And maybe I would treat with corticosteroids and immunosuppressive agents. I think I would do that. But the formal attribution is not possible, I think.
And do I need to add any anticoagulations or aspirin to this patient?
I would not give anticoagulants, but I think we can discuss antiphospholipid antibody associated manifestations. You have not found them. This is what I've heard. But still, I think I would give a course of maybe there will be no benefit, but probably not worsening. this is a fully open discussion, I think.
Thank you so much.
Okay.
Thank you. Thanks to you.
Thank you, sir, for the brilliant presentation.
Thank you very much.
Yeah, I'd like to close the session if there is not any comments or. Thanks very much. Thank you.
Thank you. Thanks to you for your invitation. Good day.
Thank you, everyone. This is the end of today's academic session. I would like to thank all the speakers and the audience for what was obviously a very enriching experience. We will be gathering here again tomorrow at 9 o'clock for tea, followed by 3 sessions. I hope you all can join us. And we have a preclinical immunity and lung in lupus, and then a few case discussions by students tomorrow. So followed by lunch. So we hope to see you all tomorrow at 9 again. Thank you.